the offset, I should say that I'm really grateful to the organizers of this event for giving me and my team a chance to showcase our work. More importantly, it's an absolute honor and privilege to be able to present this in front of with my teachers, both direct and indirect, some of whom have trained me and some of whose work has inspired us to go ahead and try all this in our alma mater. And I have to say, I'm missing someone very much today in the audience, Preeti Nair ma'am, who would have been so happy to see one of her students stand here and present, because that was always madam's dream. So with those lines, let me start. I have to first introduce you to my organization so that you're able to understand from where I come and the kind of work that we do. And let me say that none of my presentation involves excessive finances, because one thing that everyone is concerned about is about how to best utilize resources for tracking and managing antimicrobial stewardship activities. So, So this is my organization. It's a 70-year-old hospital with multiple specialities. I deal with a lot of bigwigs in my organization. The photograph I have put here is of Padma Shri, Padma Bhushan, Dr. Jose Peripuram immediately after he got his Padma Bhushan. We have lots of people like this who are stalwarts in their respective areas. Our departments of cardiology, gastro, all of that goes out all over. And interestingly, when I joined, I was the first ever clinical microbiologist that they've ever seen. So you have to imagine the huge mountain I was up against. And if I decided to go to war with them, nothing would have materialized. I am sure of it. So AMSP is something which all of you are very familiar with. It goes from leadership commitment, accountability, expertise, tracking, reporting, and action. And during the course of my slides, you're going to see all this come together, or how we have managed to try to keep it together in our organization. So what we did is, how we planned this, or unknowingly how we implemented this, was by investing in or taking the time to study 4 key areas. One is lab, one is antibiotic policy and the audits that we have done connected to that, how we managed to get feedback and how we managed to communicate with quite a good number of stubborn clinicians, and how we quietly went about building the team. And disclaimer, I love my clinicians. Please don't get it wrong, they are amazing, but still breaking the ice with them was not easy. So why should any hospital that wants to implement AMSP invest in the lab? Because ultimately it depends upon the quality of your reports. Unless you give accurate and timely reports, AMSP is not going to happen. So this was my story as well. Not so long ago, we had a very sleepy lab doing a lot of culture sensitivity reports, which was of no use to my clinician. My poor clinician would get very frustrated, and likely my patient would go to heaven also. So from there, we understood that unless we do something about this, it's not going to work. So over a period of time, of course, we do have Vitec, we have Bactalert, we have Vitec, and the latest that we have is BioFire. I'm not going to be talking about how we have integrated that, but I'm just going to shed some light on the first thing we did, which was we strengthened our lab. We worked on our SOPs. It was initially a lab that was working only till the evening, and night they were just doing culture. From there, we slowly managed to convince the organization the importance of making it 24 hours. We started implementing round-the-clock reporting. I was the only microbiologist for quite a good number of years, so you can imagine how the round-the-clock reporting would have had its own shortfalls there. But morning and evening, 2 times we would definitely report. And at night also, emergency report. Normally, we have a WhatsApp group in the department, so all the reports come there. And when I have a quick look at it, I would allow them to report, and I would also directly send communication to my consultants. This is where we have used technology. We extensively rely on WhatsApp. You will find that in my coming slides also. All blood culture positives, smear positives would be informed over WhatsApp. We started putting direct sensitivity for all Bactalert samples so that we would have a fair idea of what the organism was. Although CLSI says it directly for blood culture samples only, but we do it for all Bactalert. Similarly, ICU samples, we started giving the gram stain. We have a policy of putting a preliminary report. Suppose today we have a growth and we know it is Streptococcus pneumoniae. We have not reported the Vitek. We would have put the penicillin strip. We will just report Streptococcus pneumoniae penicillin sensitive as a prelim so that the clinician has an idea what the organism is. And we started sending it out for all sample types coming from the ICU. Staff are very, very important. In a private organization where there's just one clinical microbiologist, you can't do any of this unless you elevate the quality of your staff. So we started giving in-house trainings. We started doing split sampling to improve their quality of work. And we slowly we started with training them how to pick up organisms from the culture plate. For example, you have an MHA plate with imipenem, meropenem resistant and non-fermenter gram negative. My technicians will be able to identify that it is Steno. So I brought it up to there so that they can easily understand from the biochemicals and MHA plates. And now they are actually good at even interpreting Vitek reports, because Vitek, again, you have to be a little careful even though it's automated. As a clinical person, you still have to interpret those reports. And they can identify antimicrobial resistance from culture plates as well as from Vitek. They have the discretion now to pick up the organism. So based on this, once the lab got strengthened, the quality of the reports started going out. Over time, this year I have another microbiologist. So now currently we release all reports with notes and advice. We give them the option. I do not release MICs because I know my clinicians will not be able to decide on which is the best drug just by seeing the MIC. So going by the breakpoint to MIC, we give them their options. We add notes on intrinsic resistance, site-specific advice, renal hepatic dosing, duration of therapy, and we make sure that this is followed as much as we can. So that was on the left. What you see was my previous report. Nothing. Klebsiella pneumonia, a lot of SS. But from there, we have worked on carbapenem-resistant Klebsiella. We give them the option. We tell them stop all antibiotics, give Ceftavi with Estrio, give it at this dose. Together, we give them all the dosing advice. If it's a specific one like Streptococcus viridans, strepmitis, this was an endocarditis. So we give them the advice on which drug, how to give for how many weeks, site-specific. Dosing-specific recommendations are also there. This is a patient whose renal function is not optimum, so Ceftavi, Estronam dosing gets modified to suit the renal function. So accordingly, we do this and we started dishing out these reports, and it made a world of a difference to my clinicians. They started looking forward to seeing my reports. So what I figured out was to make a clinician happy, the most important thing is timely report. They need the report on time. When I say timely report is not in the system, they have to be made aware of the report. It has to be accurate, it has to be, somebody has to take accountability and give them the relevant information. What is this organism, what drug works best, what drug doesn't work. And over time, they actually start to value the inputs that you give. Now, everything has to be based on antibiotic policy, and you need to do audits because you will never know what's happening on the ground unless you go looking for it. So, our robust antibiotic policy, thankfully now after 10 years of working there, I can say that's the backbone of AMS, but it was so hard with them. I don't know, some of you must be facing the same problem. They will give you their policy and they want you to implement that. So, the one thing that helped me to break that problem was guidelines. I liberally started using the word guidelines for every discussion because they really don't know their guidelines. So these are some of the guidelines. I've just taken snapshots. What I'm trying to say is, I have my clinicians who love WHO and CDC, so I have to drag them from there to India. I have to tell them national guidelines, state guidelines, ICMR, because they want to listen to only international guidelines. And of course, over time, you will have to have your own data. So start picking up your cultures and looking at what works best for you. So over the years, we have our antibiotic policy. Our policy is only available in the system. And we started putting up the revisions and the updated antibiograms and we circulated it. So this is a communication which we have given. What all is there in the latest antibiotic policy and where you can find the antibiograms. On the first slide, we put this. Otherwise, sometimes they will not even know where to look. These are our antibiograms. We go extensive with our antibiograms and we prepare newsletters based on these. We circulate it. We show them which are the common isolates and what are the antibiotics that work best for these isolates. And we have a small sentence at the bottom that gives them an idea what they can choose empirically for these isolates. Now, still we were a little unhappy. We thought, okay, this has to work more. We need to make this more inclusive. How can we make this more informative to the clinicians? So we went back and touched upon our pharmacology. We started giving them ideas about mechanism of action. You won't believe how many arguments I've won with just this one slide on the left, because my clinicians love to give meropenem with metrogyl and piptaz with metrogyl. So every time I have to show them, see, piptaz and meropenem and all of that has got anaerobic coverage. You do not have to add a metrogyl. So we started adding notes on intrinsic resistance, spectrum, and irrational combinations. That one that you see are the irrational combinations that are rampantly being used or were being used in my organization. Then we went in for updates. Every year we look for the ICMR or any other update, IDSA AMR update. We increase the dosage of minocycline to 200 BD, arguing with this one small box that you see there. Similarly, I do not never endorse them giving tigecycline 100 mg. Always it is 200 and 100 BD. That again came from that. So we started adding more latest dosing so that the clinician would stay interested. And over the years, the policy has had multiple revisions. We have had multiple meetings. Now when we come to restricted, we have started working more on those drugs, how to dose, how to give, what is the duration, when to stop. All those things are given. And this is my biggest weapon that I use for AMS, which is my newsletter. And all of them are e-newsletters. I do not take prints. I just send it on WhatsApp. Now comes the audit. We have an AMS team. We do daily rounds and the data is presented at our committee meetings, and these are some of the audits which we carry out. Now, AMS committee, I don't know how it works in different places, but for me, the AMS committee should not be a jumbo committee. It should be a committee with clinicians who have a reasonably good knowledge of antimicrobial stewardship. And it should be small, it should be personal also, because sometimes the matters that are discussed there with the clinicians may not be something which is very pleasing to everybody's ear. So we have very select group of people, but all the data is presented in the AMS committee. Now these are some of the analysis which we have been carrying out. Empirical antibiotics, we look at the different departments, we go each department wise, we point out what is the mistake that is there, and then we give the communication. Similarly, for restricted drugs also, we do an audit to see which department is using it most culture-based versus which department is using it empirically and culture-based. This is the form that we have used for restricted antimicrobial prescription. We have actually included 2 more points to the empirical versus culture-based. Suppose a patient has a clinical, radiological, or a laboratory worsening. That is also considered as a reason to go give the drug. And suppose somebody is having a lack of response to targeted therapy. I'm showing this because when we put it just as culture-based and empirical, it looks as if many people are choosing it empirically, but there could be some other reason for the clinician to choose it. Antifungals we are extensively using, most of you must be using. We need to know which is the antifungal which is given most, what is the problem with antifungals. We picked up the lack of loading doses simply by doing the audit. Many of the clinicians were not giving loading doses, or were giving only half the loading doses. So again, that was communicated. This is our biggest weapon at the moment. Culture-based prospective audits are carried out daily. So what happened was I would send the text to the clinicians, change the drug. All my clinicians are very sweet to me. They say, yes, ma'am, we are changed. Now, once the audit went on the floor, we realized nothing is happening. So they were not changing. So now the AMS team goes for rounds, and then they start to pick up, see, this is not given, that is not given. So now they are forced to. This is the audit sheet which my clinical pharmacist uses. And she goes there, audits, comes back, we sit, discuss, then again we reach out to the clinician. And this slide I'm showing you because for one of the major reasons for culture-based non-compliance was not escalating or de-escalating antibiotics due to as per the advice given. Now when we sat on this and further analyzed this, I found this to be so funny. None of the reasons I got from my clinicians were scientific. They had huge problems with patients being VIP, bystander not allowing, drain being inside, what is your problem, all kinds of questions. And when I would put on the note, de-escalate, they hated that word. When I changed that word to better therapeutic index, their compliance is unbelievably good. When you say de-escalate, they're like, are you sure this is a good option? So that word should be totally taken off from everybody's reporting format. Surgical antimicrobial prophylaxis, all of you must be auditing. We went and used this audit to improve our documentation also, because sometimes the nurse's note versus the clinician's entry would show difference. So we started improving our documentation also based on this. So there is a lot to be done in terms of audit. Dishing out good reports is only one side of your AMSP journey. You have to go on the ground and do the audit. Now there is no point in doing the audit and sitting on it unless you go back and send feedback and communication, because active dialogue is everything for AMS. So how do we communicate? We are very good at sending letters. From all my talk for so much time, you know I love talking. So we send out letters, we have meetings, we do WhatsApp, we do e-newsletters. So sometimes we send out individual letters to clinicians. You are not using the right drug. Kindly make it a point to change over to this. I hope you will cooperate and all that blah blah we put. Sometimes we send out group communication to all our clinicians saying that there have been so many issues, you're not dosing it right, you're not entering it right. Restricted antibiotics, you're continuing, we do this also. But the biggest icebreaker for me has been the department-wise meetings. We meet with all the departments in my organization. It could be to discuss infection, some other issue. Basically, if they call me and say, Madam, we want a meeting, we are there for them. And we document and give the meeting minutes not to the HOD, we give the meeting minutes to every clinician on board. And we keep doing this all the time. And these are some of my meeting minutes for my surgical teams. We want antibiotic cyclings because unless we put it down on paper and give it to them, after 6 months they'll say you haven't done anything. So we put it down on them, we tell them what are you using, ortho, gynec, you name it, we have met with them. My favorite WhatsApp, I use it liberally. These are my WhatsApp groups. Every day morning I'll be raining requests and raining suggestions on all of these WhatsApp groups. In the organization, I catch hold of the DNBs. I'm not as gracious to my DNBs as I am to my clinicians. I really shake them up because I have a fear that they are going to be treating me somewhere down the line. So I'm not at all kind to them. So I keep telling them this is not the way to do it, that is not the way to do it. So this is how we communicate. These are just some texts. This is what we do day in and day out. Basically, is this okay? Can we give? So this is how it goes. My newsletters, I feel they've gone a long way. Antifungals, colistin, what is the problem? You're not dosing it right. Pharopenem, my clinicians love it. So we went and started put up a newsletter on pharopenem. Based on aware classification, are you using the right beta-lactam combinations, irrational combinations? Are you dosing it right? Are you giving loading doses? It took me years to convince them that loading doses could be given irrespective of the renal or hepatic function. They would touch the drug and make it a mess. So now they all give loading doses 100%, almost 100%, and shortening the duration of therapy. 14 days, 21 days, that was stuck inside their head. So we told them, no, the duration of therapy can be shortened, and we referred to the ICMR guidelines for that. This is a new form, we have just introduced it because my clinicians are very smart. Over the phone, they will tell me all sorts of things. I wanted them to put it down on paper. So the AMSP team would go for rounds and they would write what is a suggestion, and if the clinical team is willing to comply, yes. If not, we wanted a reason. No reasons like VAP and drain and 7 days and all that, but real reasons why. So we have started by introducing this form. It is basically a documentation, and don't think that all this comes easy. They ask a lot of questions. Are you going to be keeping this in the case sheet? The insurance company guy is going to come and take a photo of this and it's going to go against our. So then you have to have the answers to everything. No, we won't keep it in the case sheet. We'll give it to the nurse. You can fill it up, hand it over. We will take it from them. They never make it easy. They really, really make me work hard at this. But the biggest reason I'm able to stand in front of you and tell you all this is because a dream that started to implement AMS in my organization, I value the confidence my management has placed in me. It's not easy. I come from a Christian organization where everything is hierarchical. So they do not want you to ruffle the feathers of any one of your clinicians. But at the same time, the present director placed his trust in me. I remember in the beginning of the first AMSP meeting, all the members on the panel and the management took a 15-minute class for me, how I should not anger the clinician. Because the clinician is a neurosurgeon, you all know the story, right? They're bringing in a lot of money. So it was all about, see Rohita, we know you know how to talk, but don't irritate. How I was sitting on pins and needles because if I messed up that one meeting, there would never be any more AMSP meetings. But I must tell you, somehow by the grace of God, he never got the feeling that I was trying to tell him he was totally wrong in giving Ceftavi, Estionam and Colistin 6th hourly. That was my job. But somehow at the end of the meeting, he got up and went without feeling bad about it, and he has never given that ever. And after the meeting, they were like, no, we knew that you could do it, but... So that's how the story goes. So it's very difficult, and it started with a very small team, but now the team is big. Now when you see all these people, don't think all of them are doing AMSP. The core team is the one that works for AMSP, and I do not budge from the department. I sit where I sit and I do my calls. It's my junior clinical microbiologist and again my management. I'm thankful to give me a fantastic clinical pharmacist solely for AMS. You need somebody to do AMS only. Not that they're doing everything and then doing AMS. She works exclusively on AMS and she is really good. So the core team works, but that's my lab, and this is the rest of the clinical pharmacists who give me the news from what's happening all over. Another thing I have won, the battles I have won has been through the committees. Of course, Hospital Infection Control Committee is my own committee. I can do what I want there. But slowly over time, I started taking over the pharmacy and therapeutics, because every time there would be discussion, cefixime clav or cefiperazone tazo, then I would look up and everybody would look at me and I'd be like, are you sure you want this? Then none of them would say anything. They'd be like, madam, you don't want it? Okay, then we don't want it. So that's how. So a clinical microbiologist should be present in the pharmacy and therapeutics to block the entry of the wrong drug into your hospital formulary. Once it comes there, getting it out is again very difficult, because clinicians will say it is the clinician's freedom to write what they want. Or, what do you know? You just sit and talk. We are seeing the patients. It's never been easy. I've had to listen to a lot of stuff. The latest I heard just last week was, you want me to change from meropenem to ceftriaxone? Fine. Come and put it down on the case sheet that you are taking over the responsibility if the patient dies. I can't be going and putting that. So they will tell you all sorts of things. It's not going to be easy. IT can help. How we use IT is antibiotic policy and antibiogram are available on their fingertips, but whether they're activating their fingertips, I do not know. Critical alerts can be generated, okay? You can send out critical alerts. We use it mainly to extract data. If you have a sensible person in the IT department, they can help you. But if you tell them, see, we want organism-wise, location-wise, antibiotic-wise, there is limitless possibility for the IT, but right now my IT team is not working their heads very well. So that's why we have to go on the ground and pick this up. Otherwise, even restricted antibiotics, I talked for this for a really long time. I wanted that when the entry would be put in the EMR, the first colistin first dose, this form should pop up, and unless the form is filled, they should not be able to go ahead. It was a very simple request. And I tried talking to them for so long, but those guys couldn't help it, so I had to go back to paper. So finally, to conclude, I feel that diagnostic stewardship should always precede AMS. Unless you work on strengthening your lab, and unless your clinician is convinced that you're dishing out good quality reports, it's not going to help. I have used the word guidelines a number of times in the years to get out of difficult situations. But over time, you will understand that you can actually refine those guidelines to suit your own organization. I do believe that excellent communication always helps. Use the method that works best for your clinicians, but remember to keep it relevant and to always phrase it right. You know more than me the types of clinicians we deal with. They are egoistical, some of them don't have a clue, some of them don't like you, some of them don't want to hear you, but if you can be very sure about how you're going to take this forward, trust me, it's possible. The best drug, I managed to drill this into their heads. It cannot save the day unless prescribed and administered properly, and I'm really happy now to say that even super specialty departments call and ask how to give. Can we give this with this? Can I give it as once or twice? So I'm happy to give them the input. They should know that, and they keep on saying, you said meropenem, it's not working. Are you giving it as extended infusions? That's the biggest question, right? And this is how I always trap my clinicians. They say, madam, we are giving meropenem because it could be some other bug. And I always ask them, which bug? They have never answered that question till now. So they don't know what they're talking about. So I always tell them, it's highly unlikely that it's going to be one. I say this in all my meetings, it's not eminence-based medicine. We need to practice evidence-based medicine. Just because you're heading a very powerful department, you still may not know your antibiotics. So let's talk evidence-based. And sadly, as I showed you, the main reasons for non-compliance are usually not scientific. So to conclude, who is a clinical microbiologist? In my definition, a clinical microbiologist is somebody who has the knowledge. But more than that, he or she has to have excellent PR skills. I say this to everybody I meet, work on your public relations, because if you know how to talk, you can get them to do the work. They will come with you, but you need to know how to talk. And if we as a community of clinical microbiologists refuse to give up, because I know against what I have worked over the last decade, I feel that AMS goes from being nowhere to now here. So with that, I conclude my talk. Thank you so much.
Excellent talk, and you actually told a lot of points regarding how to strengthen your lab, basic things like importance of timely reports, and how to strengthen the antimicrobial stewardship program, how to take the clinicians along with you as a team, and you showed the whole team work which has brought a lot of dividends in your hospital. Very nice to hear you, and I'm sure all of you must have heard and must be going to experience, and I'm sure this is going to be a very fruitful talk for all of you, and you are going to practice it in future if they have not started already. Any questions or queries?
No, we are not doing pre-authorization. We are doing prospective audit and feedback, because there is no one person or no one group who can pre-authorize and who can actually convince the clinician not to do it. There is another point I never touched upon. If anybody asks me who's the AMSP champion of my hospital, it's me. I have not given any clinician the charge of being the AMSP champion, because to be honest, I have never met a clinician like that. So it's very important that there should be one clinician who can always talk 100% sense when it comes to antibiotics. We did have a clinician like that, but sadly he doesn't work with us anymore. So it's still, because my clinicians don't want to engage with anybody else. They're like, they can do what they want, I will do what I want. So we don't have pre-authorization and formulary registration. Usually on the first day, within 24 hours.
I just wanted to congratulate you on doing such a wonderful work, and I think as the first presentation of this Academy of Clinical Microbiologists, I think this was the best topic to start the day with. So all of us have now got into that stream of thinking, and now we can go forward. Congratulations.
Thank you so much, ma'am. Coming from you, it means a lot. Thank you.
All right, thank you. Thank you so much to the ACM for putting up such a wonderful CME, getting it started with such a firebrand session from Dr. Rohita Chandra, and hopefully we will be able to take the tempo on, maintain the same tempo or increase it further, because antimicrobial stewardship is one dynamic process, and a lot is said, a lot is talked about this, but not too many of us really do a huge amount of work in antimicrobial stewardship, because it is very difficult a task to do or something to achieve. And all of us really did congratulate. It's a very sincere and a very honest congratulation to Dr. Rohita Chandra. She really has done a wonderful job of the whole thing. All right. Now, if it comes to blood cultures, now why did I choose this whole thing when they talked to me about this AMS program and said, please give a lecture? Bloodstream infections is a totally different ball game altogether, right? It encompasses a huge number of clinical situations, many organisms, and it's not very easy all the time to de-escalate antibiotics. I'm sorry, we shouldn't be talking about de-escalating antibiotics. Many a times you're left answering questions, why not escalate rather than de-escalate? And as the previous slide showed you, I come from a children's hospital, and that is an entirely different ball game when you're talking about and dealing with neonates, with women in labor, with patients who have had a PPROM for more than 12 hours or 24 hours, and they deliver a baby which is 24 weeker, 26 weeker, which weighs just about 870 grams, 500 grams, 600 grams. That's the kind of patients that we have to deal with. And no neonatologist is going to take a chance. And many of these 26 weekers are all precious babies. That's because we live in a world of IVF. Everybody, any couple that gets married and goes on for 2 years and without a baby lands up in an IVF clinic. Whether it's correct or incorrect, this is the truth. It's the bitter fact that we all have to live with. Now coming back to bloodstream infections, it's not just about soft tissue infections. You have to deal with a whole lot of clinical situations. It's not just about enteric fever. You have osteomyelitis that can become bacteremic. You get bacteremic community-acquired pneumonias. You have bacteremic ventilator-associated pneumonias. You have endocarditis, which anyway is endovascular. You have endovascular infections, particularly in patients who have had a problem with their endothelial structures and the vascular compartment, and somebody who undergoes treatment. On top of that, we deal with children who have meningitis, who land up with a hydrocephalus. They're just a few months old, and then somebody puts in an Ommaya reservoir so that they can drain out as much of the CSF as is needed to prevent more and more of the hydrocephalus from coming into being. And on top of that, somebody puts in a VP shunt which gets blocked and infected. So those are the kinds of bacteremias that you're dealing with. And in that situation, if you go and tell a pediatric ICU consultant or an NICU consultant, can you come down to ceftriaxone and can you come down to amoxicillin clavulanic acid, everything else will be done except for giving me a good blow on the face. So transient bacteremia, intermittent bacteremia, and continuous bacteremia. Now this is extremely important as far as the history taking is concerned. We all brag about, I get 200 blood cultures in a day, but then from what kind of patients do you get? What are the clinical situations that we get our blood cultures from? Is it something that is under our control? Is it blood cultures just being done for revenue generation, particularly in private hospitals such as ours? Or is it truly being done to come to a diagnosis and to give appropriate antibiotic therapy in clinical situations? So I come from a children's hospital, so I'm going to talk a little more on neonatal sepsis, which can either be an early sepsis or it can be a late onset sepsis. It can be an immunocompetent child. We also get children born out of HIV positive patients. We get kidney transplant recipient mothers who deliver children. There are a lot of things that happen in our world, and not only this, you get community acquired bacteremia, you get hospital onset bacteremia, you get hospital onset community acquired bacteremia. There are various ways of looking at those kind of bloodstream infections. Anaerobes is something which very few of us talk about. That's because hardly anybody does anaerobic bacteriology. It's one of the toughest bacteriologies to do and to achieve and to get some data out. On top of that, you have central line related bloodstream infections. You have infective endocarditis, which can either be native valve or prosthetic valve. And it's far more complicated when you also have to deal with a pediatric cardiology or a pediatric cardiothoracic surgery, wherein you have supracardiac TAPVCs, you have the transposition of the great vessels, you have coarctation of the aorta repair, you have all sorts of major complicated clinical situations to deal with. And then of course, we all live in a sea of immunocompromised patients. Yes, anything and everything is immunosuppressed these days. There are patients who have been on long-term steroids. There are patients who are transplanted. Every single hospital down the road boasts about doing kidney transplants, and many of us also boast about working in a hospital which does liver, heart, lung, uterus, all kinds of transplants, small bowel. Now these patients, particularly the BMT ones, they all have neutropenia with cancer chemotherapy, you have organ transplantation, And then we also get thalassemics and sickle cell anemics. Those children have hypersplenism or sometimes even total autosplenectomy undergoing that, and of course they'll end up without a spleen. And many of these cases just have unusual organisms, particularly the encapsulated bacteria. Now these are the factors that's going to affect your culture yield. How much, how often, how many bottles, how much is the volume into each bottle, particularly the transportation time. In the next few succeeding slides I'll show you this. It's got a huge amount of impact on what you grow. Now why am I talking about this in an AMS lecture? That's precisely because for a long time microbiology departments have been branded as NG departments. No growth. I mean, you don't grow anything, so obviously we've got to do something. So we can't be sending our patients home with fever and with one antibiotic, so we give a broad spectrum. Now you tell us, under this culture negative situation, what do you want us to do? These are standard questions, just like she said, from your clinical colleagues in Breton. So the first thing is strengthen your home. Tidy up your own house before you get on to other people's houses and trying to tidy them up. Blood cultures is something which is very, very important. It's vital. To make a diagnosis, you must catch every bacteremia that has happened. And even then, we don't catch many bacteremias due to mycoplasmas. We don't catch many fungemias or fungal bacteremias. We don't catch viremias. You could have a cytomegalovirus disseminated going on in the circulation, and the bactec will flag it off as positive. And in many of those cases, you scurry around doing multiple gram smears and you find nothing over there. Why don't you find nothing over there? That's because it could either be a non-tuberculous mycobacteria, it could be a mycoplasma, it could be a virus, it could be many, many things which are positive in that blood culture, and we aren't in a position to make a diagnosis. So it's very important to cut short and pay attention and even bring it to the notice of our clinical colleagues as to what are the problems with blood cultures and what factors may impact the positivity in a blood culture. This is an IDSA document. I'm sure everyone has had access to this, talking about how well could you use your laboratory. And look at some of these, 2 ml in a neonate and 4 ml and 6 ml and so on. Try talking to your neonatologist about this, about getting 6 ml. And I tried doing this in one of the meetings and they said, Dr. Iyer, are you planning to exsanguinate our babies? You're talking about a 600 grammer, 26 weeker, and you want 4 ml of blood into a blood culture. Is that, I mean, do you really want to exsanguinate babies and then give them blood transfusions? These are some of the questions. It's all very nice for IDSA to put up these wonderful guidelines, but then how much of this can be followed in our situation? So guidelines will remain guidelines. It's a guidance, but then you need to work your own way around using that guidance and making sure that you're doing a good job. Well, preparing the site is extremely important. Postgraduates sitting in the back, what's the blood culture contamination rate that we need to sit up and take notice? How much blood contamination rate is not acceptable? Anybody? I'm sure there are some PGs at the back. Oh, there aren't. It's okay, it doesn't matter even if you give me a wrong answer, it's fine. 10%, 5%, 6%, 12%. It's like color, what color do you choose? So how much do you want to choose? It's 3%, universally accepted 3%, but then you need to sit up and take notice even when it is 1%. That is because every blood culture which has gone wrong because of skin contaminants is a blood culture lost to diagnosis. Remember, that particular child, that particular patient could be having something which has not been caught on. Why? That is because the person who collected the blood culture did not prepare the site properly and introduced contaminants. A second blood culture may never ever be sent. right, may never ever be sent. They will say, okay, fine, jane do. I mean, whatever's happened has happened, and we are not going to send any more blood cultures to you. It's possible. So now we have moved on from, these small bottles that we have. Many of the state government medical colleges still function with these bottles, nothing wrong about it. You get it from high media. And then we moved on at the Armed Forces Medical College when we were postgraduates in the early 90s to Castaneda bottles. That's because they said Brucella also grows in this, and you can keep these bottles for a long time. You just need to tilt them and keep them on for a long, long time. Yes? But then everything depends upon how much of the broth goes and touches the lid to introduce contaminants in those bottles. And then we started having these wonderful, fanciful instruments. Very nice looking, slick looking instruments. And we have multi-top and we have everything for the diagnosis. Yes? The more rich the hospital is and the more furnished is your laboratory, it's like going into a well-furnished home. So you have all sorts of gadgets at your disposal. But then people at the back, can you see this small graph over here? Unfortunately, it has disappeared even from Professor Anant Narayan's textbook. Unfortunately, I would say this, because who likes reading bacterial physiology? Even in the MD course, nobody wants to read bacterial physiology or understand it, yes? Leave alone the MBBS graduates. But then do you see this lag phase, log phase, stationary phase and decline phase? Just imagine a blood culture collected at 7 a.m. in the morning by a resident, and he just says, he tells the nurse, correct the blood culture, and then she passes it on to the next person because she has to go away from the 8 o'clock duty. So whoever comes in, settles down, has breakfast and tea, and then they will say, okay, fine, now we will see what all has to be collected, and they will collect it by around 9 o'clock. And then they keep looking around, who's going to take this blood culture to that microbiology department, which is two blocks away. All right, this is all I'm talking about, big places. So it sits. Where does it sit? Fortunately for the patient, if it doesn't go into a refrigerator, it sits on the ward table. This has also happened. I've seen all of this. Blood cultures collected, beautifully put into the refrigerator, and then you keep cribbing that nothing is growing. Obviously nothing will grow. Yes, so it sits on the ward table. And then somebody comes in at around 12 noon for their duty, and then they pick up everything and then they take it to that block away. In between they go for lunch, so it goes into the F&B department also. It sits on one table while that guy has a good lunch, and then it reaches the lab at 2 o'clock. Lab reception. From the lab reception, those guys have gone for lunch, so therefore it comes to the lab at 4 o'clock. And then our technologists are worried with work, so then they say, okay, fine, there's no prioritization of work. That is another problem with all of us, yes? Urines are dealt with before blood cultures are dealt with before brain abscesses. There has to be some kind of a prioritization of work if you need to catch organisms on time. And it goes into one of these fanciful instruments, and you get a false negative blood culture report at the end of 7 days. Why? That is because your organisms were at the lag phase at the time of collection. All through the day they were at the log phase. You didn't do anything about it. And then you pushed it into a blood culture system which detects the carbon dioxide from actively respiring organisms. And once the respiration is stopped and your organisms are in the stationary and still worse, the decline phase, how on earth will you ever detect anything which is actively metabolizing and respiring? Nothing is active over there. It's all reached a nadir. And that's where your organisms are, and the headspace will never be detected of carbon dioxide. And that's why one of the most important things is make a subculture before you load your bacteria. That is the only practical thing that can be done if there is an anticipated delay in getting your blood cultures in. The turnaround time, this is something which the previous speaker has already talked about, and there is no service in microbiology which demands faster turnaround times than CSF in meningitis and bloodstream infections in your blood cultures. If we can't give out these on time, I think we've failed. We might as well close our laboratories and go home and take retirement, even if it is premature retirement. Results must be notified on phone, followed by WhatsApp, email, whatever works in the hospital. It's very important not to lock up laboratories. It's very important not to wait for the next day morning at 9 o'clock and then say, I'll come at my own sweet time. Yes? Sometimes certain organisms leave you baffled. We had a 6 months infant. A blood culture was done for a small intestinal obstruction. Post-surgery, the infant went bad and the blood culture flagged off positive on day 4. And what we saw was this. Can people at the back at least tell me what's your initial impression? If you've been seeing gram smears, you should be able to talk about this. What is your initial impression? Come on. It's not a monologue. Interact, talk. Even if you're wrong, it's fine. No problem. Did anybody think that this could be Candida? Anybody thought of an elongated yeast? Yes, Candida krusei, something which can look like this. Yes. Our technologist thought about it. I was on leave. That's how I saved my skin, by saying that I was on leave. Yes. And then the bowel resected went to histopathology, and that's a histopathology picture. And do you see this? They did a grams on the histopathology section, and they found nice long. I mean, will you still say that this is an yeast which is long and strap shaped? No, I can't think of any yeast which is like this. Yes. Fortunately, we grew a fusarium. And that is when, and after this, we had several cases where you say, give meropenem, you give fluconazole, you give liposomal amphotericin blindly, just by looking at that gram smear and say, yeah, yeast, so give fluconazole. Yeah, yeast, so you give liposomal amphotericin. But then what are you treating is to be known before you start giving out, prescribing wonderful advices to people. This was a Fusarium solani. It was not a Fusarium oxysporum. And when it is Fusarium solani, we all know that Fusarium solani is a species that has high MICs to liposomal amphotericin. So it's much better to treat those kids with voriconazole, use a higher azole, or still better use an echinocandin, or a combination of the two. So that is, even if you can't use fluconazole and you have to go up, it's very important to give a right direction to an antimicrobial stewardship program. That's also a part of illness. Yes? Many a diagnosis gets settled with pathology. How many of you all still live in that thing that we don't talk to pathologists, they are our enemies, and we are branched out from them, they are useless, they are all morbid. They are not morbid. A lot of diagnoses can still be settled with good relations with the pathology people. Yes? Identifying organisms is something which is caught on to us. Even today, you can identify a streptococcus with a bacitracin disc. There's no problem. A group A beta hemolytic strep can still be done there. You can use your TSIs, but then it's how fast you do is something which is very important. And even by using these wonderful, fanciful instruments, one can go wrong. I've had Shigella from urine. I've had some pukuria from something which doesn't make any sense. But then we still persist in using these instruments when sometimes it becomes very easy. Gone are the days. There were days when we never had any fanciful instruments in our laboratory. Something which was a non-fermenter, which was pale looking on a blood agar, which is oxidase negative, which is non-motile. And I know the next day my sugars are going to be, alkaline by alkaline and give you a non-fermenter. What's wrong about calling it a probable Acinetobacter? There's nothing wrong about it. But then today you have these fanciful instruments, and then it gives you Acinetobacter lawophi. And then you don't know what the lawophi is going to do, whether to call it a contaminant or whether to call it a pathogen in a blood culture. There are problems with automated instruments which we need to take cognizance of if you have to achieve anything like a good this thing. One fast track has come from the UCAST, and it came up some 6 or 7 years ago. In our laboratory, we use UCAST. We don't use the CLSI guideline at all for interpretation. And the UCAST is generally a forerunner. It comes much earlier than the sleazy guidelines that everybody follows. And this is a rapid antimicrobial susceptibility testing which can be read at 4 hours, 6 hours and 8 hours. So most of our gram negatives go out like this, within 4 hours and 6 hours. And that is very important. Why is it important? Because it gives them preliminary information whether they are dealing with a CRE, a carbapenem resistant enterobacterium, and that needs an urgent phone call. So just as the previous speaker said, we work 24 hours with a WhatsApp group, otherwise there's no other way that you can make this work. Right? Blood cultures don't come out positive only in the morning. They come out positive at any time of the day. A synergy testing is extremely important. We had ceftazidime avibactam, and that was supposed to be working wonders with CRE Klebsiella. But then the minute we had NDM Klebsiella, we all knew that ceftazidime avibactam is not going to work against NDMs, the New Delhi metallo-beta-lactamases. So then what do? Then our clinician said, no, we combine it with Astronam. Fine, it seems to be a wonderful thing. But then in every case, do you need the Astronam to tag on with it? No, you don't. That comes only when you look at what carbapenemase genes you're dealing with, and all this has to happen within that same 12 hours, 24 hours, yes? Otherwise, it doesn't make sense as far as achieving good antibiotic management is concerned. So it's very important to have this carba-R gene detection. You can either do it using a gene expert and achieve a result within about 55 minutes. And then you can put up a ceftazidime avibactam and an Astronam MIC, and you can so it's if you get an NDM1 or if you get an NDM plus OXO48, you need to do a synergy testing, and that is a laboratory direction towards using this combination of ceftazidime avibactam and Astronam. If you get an OXO48 alone, you could very well just do a ceftazidime avibactam and give out that. Yes. Sepsis diagnosis, and no bacteremia is complete without sepsis diagnosis discussion. And we've used lots of molecular assays in the past. You see that three things, that old one, that was in the 1990. This was the original PCR machine which came up in 1990. Right? And the first time I saw it was in the Hinduja hospital, wherein manually you got to pull it from this to this from this to this. And today you have all these wonderful, fanciful instruments, but then even in 1990 people did do PCRs. It just goes to show that. So therefore we live in a world of theranostics in infectious diseases, wherein you have PCRs and you can do PCRs for anything under the sun. But then you need to be mindful about what you are doing a PCR for. There is something called as a therapeutic window within which you can save a patient as well as achieve good AMS, or you don't. And there are 4 such scenarios. The first scenario is where results have come out very fast, a patient is treated appropriately, and the infection is also treated appropriately. Now, mind you, you may treat the infection, but then you could still lose the patient. That is because there is a very, very narrow time period beyond which that patient moves into sepsis and septic shock, because there is a cytokine storm that causes this. If you give that much amount of time, if you take too much of time to give appropriate antibiotics, you persist in using vancomycin and meropenem when you are dealing with say a CRE, a Cyanobacter, against which both of them are not going to work, then you're asking for trouble. And those are the types where you may make a good diagnosis later. You may start using colistin plus tigecycline, but you will still lose the patient. Yes. This is one scenario where you have pyelonephritis, cystitis, cholecystitis, and so on. The therapeutic window is pretty long. So it gives you a lot of time for you to work on. But then every patient doesn't come announcing, I'm going to give you a long therapeutic window. Will they? No. So you really don't know what you're dealing with. And that is why your blood culture facility has to be as fast as possible. Like in this case, you have empiric therapy given, which may be inappropriate. You have taken your own sweet time to give out a result, and your therapeutic window is pretty short. Your patient has already slipped into sepsis and septic shock and they die. So even though you aren't able to make a diagnosis because of all those blood culture factors which have come into play. The third scenario is, yes, we gave out very good results, but then it wasn't timely. You still lost the patient. You treated the infection but lost the patient. And the last one is where it was a deadly scenario, but you've really worked very hard and your blood culture service has been truly useful in correcting an inappropriate empiric regimen within that therapeutic window time. So what does this mean? This means that a blood culture service in a clinical microbiology department has to work overtime. It's not just timely, you need to work overtime. We need to borrow 36 hours and put it in 24 hours. That's how we need to work. So we just formed an algorithm in our laboratory. If a blood culture flags up positive, and on the gram, we gram every blood culture, it says GNBs. We put up a rapid antimicrobial susceptibility testing, or RAST, as I've already told you, read it at 4, 6 and 8 hours. And then within this time, if it's a carbapenem resistant gram-negative on RAST, we put up a meropenem MIC. Now why am I telling you that? That is because your meropenem clinical breakpoint is 2, right? Whereas UCAST tells us that if it is between 2 and 8, you can still combine meropenem plus colistin and treat a patient. So which means you need a meropenem MIC and document it to be more than 256 before you're able to do anything. Broth microdilution colistin, don't wait for tomorrow to come and then you will do a BMD colistin. No. Everything has to happen all at the same time. Tigecycline MICs, because what if it's an Acinetobacter? So then you need colistin plus tigecycline and a sulbactam containing one. A carbapenemase gene detection has to be put up along with final susceptibility and identification reactions. If the gene detected is an OXA48, you can get away by just using ceftazidime avibactam. With an MIC, a synergy testing may not be required. If it's one of those other two, then you will need to do a synergy testing, work out an FICI calculation, fractional inhibitory concentration index, which will tell you whether this combination is going to be synergistic, additive, indifferent, or antagonistic. And it's very, very useful, mind you, when you are dealing with this kind of a combination. Ceftazidime avibactam plus aztreonam is used like water in our ICUs. There has to be some control. And how do you achieve that proper AMS control without losing your patients, without arguing or losing an argument with your with a pediatric ICU consultant or a neonatologist, is saying this is the laboratory direction, but then it's got to happen in an overtimely manner. Otherwise, it doesn't make sense. The clinical lab has to function like this. It must be 24/7 service. Gone are the days when we could lock up our laboratories at 4 o'clock in the evening. The department is shut and there will be one E-lab somewhere near the postmortem room, and then you send all your blood cultures over there. They will lie over there. The next day morning, at around 9:30 after breakfast, we will see what can be done about all those specimens. No longer can we function in this country. Even in India, we can't function like that in today's world. It needs to have dedicated staff. One must be timely, accurate, precise. Accessibility is extremely important. Don't put off your phone and say, I don't take phone calls from the hospital. We have to. If we need to save our patients, we definitely have to. If we need to talk to our clinicians and impress upon them that what they have actually started empirically may not be useful or beneficial to patients, then we have to. You got to be accessible, otherwise it's of no use. They will say, anyway, you can't be contacted, so what difference does it make to us? We'll do what we want. Consultant cover. Don't try and brush it off on, this is for the seniors in the audience, don't try to put it on your postgraduates and say, they will do all the work and I will take a happy Mr. Sweet holiday and stay at home. No, we can't. A consultant cover for antibiotic management and infection control is the supreme need of the day and the hour. Yes, thank you so much, ladies and gentlemen. This is just a snapshot of our bacteriology.
Hello. Sir, thank you for a wonderful lecture on blood cultures. So she gave a general idea about AMS, and now you have pinpointed on blood cultures, and it was that classification into the 4 types of window, therapeutic window. I think you should have dwelt a little more on that, because can you just elaborate a little on that 4 windows?
Can we have the slides once again? Madam wants a little more onto it. Sure. What I wanted to say is there is something called as a therapeutic window. Now this therapeutic window is a new concept. It's available. If anybody is interested, just go to the Royal College of Pathologists UK website. You go to SMI UK. Okay, SMI UK. It's a set of SOPs. And there you will find bacteriology, virology, all sorts of things being classified. You go to clinical scenario management. All right, syndromic approach. Yeah, syndromic approach. You click onto that and you click onto sepsis and bacteremia. You will get this. And it's really wonderful, because after having this, how do I get to those slides? I'm so sorry. 1 minute. Specifically that, push it. No, it was after synergy testing. Theranostics. So it is this is the therapeutic window. It's basically defined as a period in time where both the patient and the infection gets successfully treated. Now, if this therapeutic which means the infection may be treated and the patient gets treated. That was scenario 1. Both the infection and the patient don't get treated, that is scenario 2. The infection gets treated, but the therapeutic window has been so short that you have not been able to push in your results within that time. That's where the patient passed away. That's scenario 3. The therapeutic window is short, but your service has been so effective that that we conquered the infection as well as the patient. That is scenario number 4. So how big is the window is extremely important, because once you cross this window, the pro-inflammatory cytokine cascade starts off. IL-6, IL-1, TNF-alpha. Now all these are out of the realms of our clinical laboratory because they are pretty expensive, unless you have a postgraduate student thesis or unless you have an ICMR grant. These are the things. We still do an IL-6, and you can combine it with ferritin levels from biochemistry. This is something. The ferritin levels go skyrocketing high, the IL-6 goes skyrocketing high, and this should be done at a time when you have said, yes, use ceftazidime avibactam plus aztreonam, and still your clinician says, I have used all this, there is a marginal improvement where the patient is not doing fine. And then you know that this therapeutic window has been so short, you have just treated the infection, and it is anybody's guess what is going to happen to that patient. Because the pro-inflammatory cytokine cascade has already taken over. The next thing will be end organ damage, MODS, multi-organ dysfunction syndrome. All that starts off, and once that cascade goes, it has to settle on its own. Till then, what will you do? Give supportive therapy, give blood transfusions, give platelet transfusions, and fold your hands in prayer to the Almighty God. That's all that you can do in these cases. So this is what I meant about scenario 1, where you have, there are infections like pyelonephritis, enteric fever, cholecystitis, plain bladder infection, urinary bladder infections, where your therapeutic window is huge. That is the period where you can treat the infection and the patient. So it gives you that much amount of time to achieve this. In scenario 2, your period is very, very short. That's because they come up in a state of septic shock, gram-negative or gram-positive. And within this, an early appropriate decision has to be taken within 12 hours. Here I've been generous by putting 24 to 48 hours, but then within 12 hours, you need to achieve that hit hard, and hit correctly. If all these 3 things don't happen, that patient dies. That infection never gets treated and that patient will die. Yes? And in the third case, again you have initial improper empiric therapy. For a gram-positive, you've given gram-negative cover. So now a very intelligent thing is give some gram-positive cover, give some gram-negative cover, and cover for a yeast also. but then every time it doesn't work. Okay, you will give meropenem, vancomycin, and you have, you may even add colistin, and then you will also give fluconazole. What if it's in a BRE? Right? So that means everything goes out of the window. What if it's a VRE, infective endocarditis? You do get those, VRE enterophisium, and then this patient goes into a state of septic shock. And then how do you manage those cases? Because you haven't given that patient daptomycin, you haven't thought of giving linezolid, you haven't given any of those. So anyway, that cytokine storm will take over and kill the patient with sepsis and septic shock. The last one is where the therapeutic window is short, but we have been able to achieve with a good blood culture service. This is the patient's luck, the physician's luck, and of course, a lot of input and luck from microbiology. This is what I wanted to say.
So much, sir. Any questions? I don't know if we have time.
Yeah, actually, we're short of time.
Just one quick question. So when you get a blood culture positive, that, like you said, could be due to some other organism like CMV or wherein you don't see an organism. Do you report such blood cultures to your clinicians? Like it's been flagged positive, but I'm not seeing anything, or do we just go silent on it? Because many a times we don't inform. So I'm keen to know, what do you tell the clinician in a situation?
At least phone and find out clinical details. From that, you can glean a lot of information, because we do get these false positive flag offs from the BACTEC or the BACT alert, even when there is hyperleukocytosis. If the WBC count is 75, 80,000, even those actively dividing polymorphs can use up all the oxygen and liberate carbon dioxide. So even that gets detected as a positive culture without any organism sitting over there. So that's one of the reasons why if you have, say, leukemia, a patient with leukemia where you have a WBC count of 1 lakh with blast forms, you can get a false positive flag off. So clinical details might help you. If they talk about a sore throat which has gone bad and then now gone into a state of septic shock, this year we have seen so many mycoplasma sepsis. So we know probably it's mycoplasma, and if it's a cell wall deficient organism, how on earth will you see it on a grams? It's not going to be there. It will be there, but not detected. So it becomes useful to give either levofloxacin or azithromycin.
Okay. Thank you, sir.
Good morning, ladies and gentlemen. First of all, I would like to thank the organizers for giving me this wonderful opportunity, and today I am honored as well as privileged to share this platform with two eminent senior personalities in microbiology. Thank you, Kavita ma'am, and thank you, Ayya sir, for the elaborative knowledge first. So, a quick wrap on a very minimal experience from my personal thing. See, the blood culture contamination is one of the main points that every microbiologist must look into in every aspect. The first and foremost thing is, as sir rightly mentioned, what is a correct indication that you are sending a blood culture for a patient? The studies show that many of the indications that a clinician points to is a fever or leukocytosis. Getting a negative blood culture, it is an unnecessary drain for the patient regarding the cost, the treatment part, as well as the duration of antibiotic therapy. So having a blood culture drawn for a right indication, you have a patient clinically indicated for blood culture. The second most important pre-analytical step, the preparation of your skin preparation. The automated systems that are in the process that we are dealing with, they don't have that system to distinguish between a pathogen or a contaminant. So how you decontaminate your skin before taking a blood culture plays a crucial role. Because in most of the centers, whether big or small hospitals, 5 to 15% is a positivity rate, and about 60% goes with a contamination. So how you can see that block line varies. The next step is combining the conventional blood cultures with your rapid molecular system, BioFire BCID. It definitely has a robust impact on the effective antimicrobial therapy, as well as the length of patient hospitalized and the cost for the patient. And these two combined with a robust antimicrobial stewardship program, as Dr. Rohit has rightly mentioned, with the support for the clinician, that can bring a big impact or a fruitful impact for the patient who is admitted in your hospital. Thank you so much.
Thank you to our chairpersons and speaker. We would like to invite Dr. Kavita Raja ma'am and Dr. Rachna Babu ma'am to present a memento to our speaker, Dr. Ranganathan Nair sir. Thank you everyone. To honor our chairpersons, I invite Dr. Pushpa K. Ma'am, Professor, Government Medical College, Thrissur, to present the mementos. First, we have Dr. Kavita Raja ma'am. Next, we have Dr. Rachna Babu ma'am.
Of Stewardship, linking diagnostics with AMSP by Dr. B. Anil Kumar sir. I kindly invite the chairpersons, Dr. Chitra Valsan ma'am, Professor Microbiology, Jubilee Mission MC, Thrissur. She has more than 25 years of experience and is Vice President, ACM Kerala Chapter, and has authored 29 publications. Next we have Dr. B. Gulsan Nair sir, Professor Microbiology, Malabar Medical College Hospital, Kozhikode, with 9 years of experience. He has set up the only PCR lab in Lakshadweep during COVID-19 pandemic. He is also Infection Control Officer and part of AMS Committee, Quality and Safety Committee.
So, good morning all. It's my privilege to introduce Dr. Anil Kumar sir, such an eminent microbiologist, a renowned person to all. He's presently the professor and head of Department of Microbiology at Amrita Institute of Medical Sciences, Kochi, and having an experience of more than 18 years. His main areas of interest include diagnosis and treatment of infectious diseases, antimicrobial stewardship, infection control, characterizing antimicrobial resistance, multi-drug resistant tuberculosis, NTM, and emerging fungal infections, diarrhoefilariasis, angiostrongyliosis, and zoonotic infections. He is also a fellow of European Confederation of Medical Mycology, fellow of Infectious Disease Society of America, and he has published in more than 62 important journals, which also include the prestigious Lancet Infectious Diseases. And he has got more than over 200 publications, which also include more than 126 international publications. And he has presented more than 140 lectures. Welcome, sir.
Thank you, madam, for that kind introduction. It was prepared by me also only. Slide. Looks very complicated. ACM, thank you for inviting. It's always a pleasure to address this august gathering of learned microbiologists. And Satyajit specifically for inviting me for this lecture. After two wonderful lectures, This bar is set very high. Rohita did an excellent job. Ranganathan Saiya enlightened us a lot. I'll try to entertain you a bit. So, this is my institute. This is the diagnostic stewardship and the antimicrobial stewardship together. You must be knowing everything, but I won't go into the details. I'll be dwelling on the diagnostic aspect. Diagnostic stewardship means right test, right patient, right diagnosis, right therapeutic decision, and microbiologist is the person in contact. So microbiologist runs the show and you have to deal with the lab. But antibiotic stewardship pertains with right treatment, right drug, dosage, duration, de-escalations, and the ID physician is the person that you are interacting, or the clinician you are interacting, or your clinical pharmacist if you are fortunate enough. And it is a skill, it's a person-to-person contact, and you have to gain that skill to convey that particular decision to the clinician to make the change in treatment. So, and what is the objective? The objective of diagnostic stewardship is to optimize the use of tests. We use optimum tests, the test performs well, and you reduce the diagnostic errors. And the antibiotic stewardship aims at improving the outcomes of the patient by giving the right drug, reduce EMR, and reduce hospital stay. Both put together basically causes optimization of the drug as well as the test, and cost effectiveness is something that you can achieve. But that is not the primary aim of diagnostic stewardship and antibiotic stewardship. The primary aim is to bring out quality of the test. So if you increase the value of the test by improving the quality and the cost, that is what you have to achieve. Diagnostic stewardship may ask you to go for a very expensive test because the outcomes would be really better. So the cost is not a factor that should be taken into consideration. So this is how we order a test. A patient comes in, the clinician sits there, and with all due respect to the clinician, it's just something that's a joke. But most of the time, we just order a test just because we like to order that particular test. You should place your attention to the nose aspect and the finger where it is going. So he's just picking his nose and ordering a test. Because most of the test is ordered because it is available in the system, we don't give a consideration to the pre-test probability, how the test would come positive in this patient or not. We don't order a test keeping in the patient into the picture, the clinical signs and symptoms, and then we end up in a big problem if it comes positive. If it comes positive, mostly it is a false positive, it's a colonization, and it results in antibiotic treatment, longer stay, longer adverse events, and many things goes wrong. So that's why we are talking about how to order a test. That's the first step. Ordering the test is the most important aspect. So most often my clinician call me from the ER saying that, Anil, I'm going to discharge this patient and you have given urine culture positive, what to do? The tone is such that they are telling me that I have given UTI to that particular patient. You have sent that urine culture. I didn't send that culture. If it was indicated, you should have sent it. So that's how it happens in my hospital. Revisiting the slide again, this is a young lady, 23-year-old lady, comes from Delhi with high-grade fever. He goes to an excellent local doctor. The local doctor orders a very excellent test, comes positive, and also the blood culture is also sent. Immediately within 5 days, she gets a diagnosis of brucellosis. The culture is also positive, and she is being treated with gentamicin and doxycycline. Okay, so a wonderful physician who is diagnosing within 5 days a brucellosis, and you see a very excellent microbiology report with plenty of antibiotics and plenty of details in it. So we'll be visiting this particular report in the end, how this test ordering affected the patient. So diagnostic stewardship has got a pre-analytic, analytic and post-analytic part. The pre-analytic interventions, I'll just go to the pre-analytic. Pre-analytic is the before you'd order the test, what interventions, I'll give you a few examples. The most important part of the pre-analytic is the specimen. This particular study shows that if you send a very nice specimen, the yield is very good. So if you send an expectorated sputum or induced sputum, the yield is 51%. But if you send a nasopharyngeal swab or a pharyngeal secretion, the yield is abysmally low. So it is just to tell you that specimen should be the correct. It should be pus, it could be urine, it could be most common specimen is urine. Most common specimen is respiratory tract because it is very easy to achieve. So you have to choose the right sample. This is an example for C difficile testing. C difficile testing, you may not be doing that many, but you should understand that C difficile testing should be done in certain category of patients. Now, it should fulfill the criteria. First thing is that he should be having diarrhea. The patient should not say he is having diarrhea. You should know that he is having a diarrhea. The patient will say many things. So patient should have a diarrhea, and diarrhea should fulfill the criteria 3 stools. Count the stools properly. 3 stools within 24 hours, more than 3 stools, then only think it is diarrhea. Don't go by the patient's word. Then you think, ask him whether you are taking any laxative or not, whether you are taking an oral contrast was given or not. Both of them can cause diarrhea. If that is ruled out, then you find out whether a C. difficile has already been sent within 7 days. If it is within 7 days it has been sent, don't send it. Don't send the stool to the lab for testing. It will give you false test. And by the time you order the test, if the patient is feeling fine, the bowel is good, don't order the test. So if you order the test, it's all, then it goes down, it will come, depends on the test that you use. If you use a very sensitive test, it can come false positive. This is a pre-analytic for C. difficile. Just an example, because 20% of the hospitalized patients are colonized and only 1 or 2% will have the infection. So you will get 20% positive and you will end up treating 20% of the patients. So this is another example where we have a multiplex PCR for GI pathogens. An excellent test, I would say. 22 different targets, 5 viruses, you have 4 parasites, intestinal parasites, and all bacteria that you can cause gastroenteritis. A very good test, but it should be ordered very carefully because it has got multiple pathogens. So if you order that, it should be not ordered for a patient who is having a self-limiting diarrhea, less than 7 days of duration, doesn't have any warning signs, doesn't have abdominal pain, fever, dysentery or anything. Don't order this test, it will mislead you. Now order this test only if the patient is having warning signs, patient is having diarrhea for more than 7 days, it's immunocompromised, then only there is a value. It's almost 10 to 15,000 rupees. Spend this money, otherwise don't use this test. And if you think the patient is having an hospital-associated diarrhea, don't use this test. Go for a C. difficile testing, but provided you fulfill the previous criteria of C. difficile testing. Only then you order the test. So that's how you order a particular test depending on the patient's signs and symptoms. Blindly ordering the test will give you many positives because enteropathogenic E. coli and enteroaggregative E. coli will be positive for most of your patients, and though nobody knows what is the clinical significance of picking up those bacteria. Then you can call for consultations. Okay, people can call microbiologists for consultation. When you're using a high-end test, it's better to ask the clinician, microbiologist, what to do, because it gives you a proper guidance whether it will work or not. Like BioFire, BCID panels and GI panels, these are all 16,000 rupees. So you can't just test in any specimen. We also advise whole genome sequencing for non-tuberculous mycobacteria or MPM. So all these things should be consulted and then ordered. If a patient is having meningitis, encephalitis, some people would like to order a multiplex PCR. Call the clinician and ask what he wants, and then you tell him which panel to be chosen, whether it's a bacterial, viral or panencephalitis. Then you have an eosinophilic meningitis. If you ask me, somebody calls me with eosinophilic meningitis, I would say go for an angiostrongyloid PCR. We have it, we'll give it a report within 1 day and you can come to a diagnosis. So it depends on what kind of meningitis the patient is having. Now, if a clinician is seeing a patient with a deep-seated abscess, with diabetes mellitus and a CRF, think of melioidosis. Tell the microbiologist, look for melioidosis. Only then they'll get, because they'll keep the plates for more than at least 7 days and find out whether the Burkholderia pseudomyelin morphology is there or not. Then, if you are suspecting PJP, pneumocystis carinii, then if you don't have a PCR, then a high level of LDH and beta-D-glucan can be used as a surrogate marker provided the radiological picture is consistent with the PCV pneumonia. So those things can be discussed with the clinician, and even if you don't have a test, a surrogate marker can be used. Now, galactomannan is used for aspergillus, because galactomannan can be used for blastomycosis, histoplasmosis and talaromycosis because it cross-reacts with that antigen. So if somebody says, I think of histoplasmosis, but I don't have a histoplasma antigen, do a galactomannan, cross-reacts. It can pick up the histoplasma, it can pick up talaromycosis or blastomycosis. So those things can be communicated to the clinician if the clinician calls the microbiologist and microbiologist gives the input, and that test can be used judiciously. The analytic intervention is during the testing. So you can refuse testing. You can decide not to test urine if there is no pyuria. Don't culture the urine. You can refuse to test a C. difficile in the stool. Now, stool means, C. difficile means diarrhea. So when you see the stool in the container, it should be watery. It should be watery and it should take the shape of the container. If that doesn't happen, don't do the C. difficile testing. It's useless. So that's sort of a decision you can take in the lab itself. The patient will save money. You will also save the patient by being treated unnecessarily. Then you can also restrict testing of CSF for multiplex PCR panels. So many people are very fond of ordering multiplex PCR panels. So if the patient is not having pleocytosis in the CSF, there is no point in going for a PCR. It won't give you, and it may come false positive for something that will lead to a problem. So you can look at the pleocytosis in an immunocompetent patient and then decide whether he needs a PCR or not. Then you can do a rapid diagnostic, the direct susceptibility you can deploy a rapid PCR to identify. You can do carbapenemase testing. The CLSI 2005 says that you identify the carbapenemase gene, that is very good. So you can deploy that if you have that available. So you can improve your lab. You can add new diagnostic testings. You can use rapid ID like Malditop, BioFire. You can do a carbapenemase testing using a lateral flow assay that is easily available. It's cheap. And you can do a MEC PCR. Whatever is available or can be introduced to improve the rapid ID and susceptibility, you can integrate in the lab and improve the diagnostic yield. So you should understand my molecular tests are very good, but it should be having proper testing. So there are three levels: pre-analytic, analytic and post-analytic. Pre-analytic is you don't order the test unless and until you think that at least 2 targets in that multiplex PCR is a possibility. The pre-test probability should be high, at least for 2 organisms in that multiplex PCR. Otherwise, don't try to order such multiplex PCRs. And also again, the pre-analytic sample collection is very important. It should be pristine. It should be very sterile. If it is not sterile, many things will come positive. And you have analytic part. You do the test assay in such a manner that you don't give false positives, false negatives. And post-analytic, if you think certain reports which are positive has to be hidden, hide it. Like if you do a GI multiplex PCR panel, C difficile is always there. Nobody asks for C difficile, hide the C difficile unless the reporting is not good. If the consultant suspects C difficile, only then you can report C difficile, otherwise you can hide the C difficile. So this molecular tests are very good in the sense that they have a very good benefit in reducing the time for appropriate therapy, reducing the length of stay, reducing the mortality, provided you have a stewardship. Somebody who can read the molecular test, make sense of it and tell them that this is significant, this is not significant. Only then the mortality risk is reduced significantly. Otherwise, it doesn't help much in reducing the mortality. So always try to have a clinician or a microbiologist to interpret the molecular test to the clinician who is treating the patient. So you see, this is the analytic stewardship where you don't culture the urine if pus is not there. If pus is not there, you don't culture, reduce cultures, reduce bacteriuria, reduce antibiotic use. That is the response. So look at this particular gentleman, 77-year-old gentleman who is having a benign prostatic hypertrophy with an indwelling catheter, and he's having altered sensorium, and he's been recently started on a beta blocker. So he comes to the hospital, gets admitted, and altered sensorium, urine is sent for culture. And according to your criteria, urine doesn't have much of pus cells, I won't culture it, you don't culture. And then since you don't culture, you don't have a positive culture. And then you see why he's having delirium. You see the beta blocker is being given, you associate the delirium to the beta blocker, you stop the beta blocker, manage the patient, he goes home, fine. He is cured of his delirium. So beta blocker was responsible. But same patient, if you don't have this reflex culture criteria, you invariably culture this urine in spite of the fact that it doesn't have pus cells. What will happen? You will surely grow E. coli in significant numbers, which is a catheterized patient. Then you end up treating this patient with ciprofloxacin. Ciprofloxacin will worsen the delirium again, and then he will develop a diarrhea. Then he'll have a C. diff sent. C. diff is also positive. Then he'll have a respiratory arrest. Then he'll go to ventilation, ICU, and ultimately to a long-term care facility just because you cultured the urine. That you should understand. So this is the C. diff criteria. You can use the C. diff criteria in your lab itself. It's very easy. Look at the stool, if it is watery or not. If it is watery, means it takes the shape of the container. Do a C. diff, otherwise don't do a C. diff, throw it away. This is the Bristol chart, type 7 should be the criteria. So if you reject such samples, then this particular study said the utilization of the tests went down. Significantly the test was utilized lesser incidence of hospital onset C. diff infections and lesser use of vancomycin. By just doing putting one criteria that you don't process any samples which doesn't look like diarrhea, which the patient is having laxative or not. So if you look at the refusals, you see 9% of the patient had a laxative. If you go and check whether the patient is having laxative. If he is having laxative, don't test it. If he is having oral contrast, don't test it. And 7% were cancelled because the stool didn't look like diarrhea. So have a look at the stool and then only do a testing. post-analytic intervention you can report in such a manner that it can be more convincing. Like, rather than telling that it's a normal flora, tell them that it's no MRSA and no Pseudomonas. So they won't start those anti-MRSA and anti-Pseudomonas drugs. Or rather than reporting that it's asymptomatic bacteriuria, they may think it's a colonizer, don't give the bacteria, don't give the susceptibility, ask the clinician to call. So then they are very reluctant to call, so they won't call you. Then you give a positive culture. Now, people are reluctant to call me, but they are very happy to call Rohita, that's a different thing. But if you have a positive culture, then you say that treat only if it's symptomatic, cystitis, pyelonephritis, or pregnancy, or you have an indwelling catheter, or you have doing a procedure, treat it, otherwise don't treat it if the patient is not symptomatic. C. difficile positive, toxin is negative, it's a colonization. Most of us do ELISA. You do a GDH positive and toxin is negative. I'll tell the doctor to clinically correlate, because ELISA is not very sensitive method to find the toxin. If the patient is clinically consistent with C. difficile, go ahead and treat it, because you have to do a PCR to find out whether it's a toxinic strain or not. If it is not available, then you better treat the patient. And Candida, anywhere that in respiratory, in urine is always a colonizer. If you want, you can tell the clinician, call faster diagnosis. Again, a blood culture. Growing yeast, we do a Gram-Sin, we find budding yeast cells, and the biofire tells you it's Candida parapsilosis and tropicalis both together. So we are busy digging out, finding out where is the tropicalis, we didn't find any tropicalis, we found only parapsilosis. Then we read the literature, found that it cross-reacts. There is no tropicalis anywhere. The primers cross-react with tropicalis and parapsilosis, gives you a false report saying that both are present in there. Then this is a prosthetic joint infection, TKR, septic arthritis after joint replacement, and they send a joint infection panel that is 17,000 rupees. So they invest 17,000 rupees and I give a negative report. And then I do a culture and find out there is a coagulase negative stuff. So you should always remember what the test is having and what the test doesn't have. The joint infection panel doesn't have coagulase negative stuff. And coagulase negative stuff is the most common cause of joint infection in prosthetic joints, 30%. It is not there. So always tell your clinicians that if you are sending a joint infection panel, coagulase negative stuff cannot be picked up, which can be a cause of your infection. So it's a false negative. Then this is a blood culture showing gram-positive cocci, and we did a biofire. Biofire gives you Enterococcus faecium. It also tells Van A, Van B positive. So there is gene for vancomycin resistant. But when we do the Vitek, it is sensitive. Vancomycin sensitive, ticoplanin sensitive. After 3 days, a blood culture, patient was on ticoplanin. After 3 days, the patient's blood was repeated. It's Grus Enterococcus faecium. Again, we do the PCR, we find Enterococcus faecium, Van A, Van B positive. But this time, it is resistant to ticoplanin and vancomycin. What happened was, the drug induced the resistance, expression of the gene occurred. So there is a phenomena called as vancomycin variable Enterococcus. Vancomycin variable Enterococcus and Enterococcus faecium, where it will be sensitive initially, have the gene. So we learned that if you get Van A, Van B, forget vancomycin, forget ticoplanin, better to go for some alternative. The patient was given linezolid and ticoplanin. TBR. So this particular patient, gentleman, a diabetic with chronic renal failure, is planning for renal transplant, and the nephrologist has to evaluate and certify for renal transplant. So by mistake, he says that I had TB 7 years ago. That finishes everything. The clinician wants to rule out tuberculosis now. He had TB 7 years ago, I want to rule out tuberculosis. He sends a gene expert comes, trace positive. There is no clinical evidence of TB, no X-ray evidence, nothing. Trace positive. After 9, he's deferred. Go home, let the TB resolve, let's see. We said that it could not be TB, clinically he's not having TB. After 9 months, he comes back again the nephrologist says, do a gene expert. It's again trace positive. Now you see, this is the graph of 9 months between, an identical graph. There is some TB DNA in his mouth somewhere lurking around and giving positive for a PCR. So don't order a test if it's not clinically indicated, because some people are treating their fears. The nephrologist said that I am facing a case where one of my patients developed TB after transplant. So he keeps ordering gene export for every patient who's coming for clearance for. If he had gone to a government setup and used the normal gene expert, he would have been negative. Just because he came to our place where ultra is used, it came positive. So I had advised him go to a government hospital and get tested, it will be negative. So WGS also is sent. You should understand that NTM is a big problem, and NTM you should know the name of the species to get a treatment right. Unless and until you don't know the name of the species, it is not, you can't treat him right. So we see a lot of Mycobacterium abscess. Abscess is the most notorious for clarithromycin resistance. Clarithromycin is the backbone of treatment for NTM infections. So what we used to do is Sanger sequencing. Sanger sequencing never tells you the subspecies. You should know abscess is a complex with Mycobacterium abscess, Mycobacterium massilensis, Mycobacterium boleti. And Mycobacterium abscess and Mycobacterium boleti have got an ERM gene. That means they are inducibly resistant to clarithromycin. So you have to know the species. So we ask the clinician to order a whole genome sequencing where we can identify the subspecies and also find mutations for clarithromycin resistance. So this helps a lot in treating these patients by not using clarithromycin upfront because it would lead to a failure. And even WGS for TB also we order on selective cases. If the patient is having rifampicin resistant, you have an isolate, send for WGS because you can know whether it's a pre-XDR or not. Not for every patient. You have to pick and choose. The clinician has to ask. Then we will give them an option which test can be used. So the relationship between stewardship, the diagnostic and antibiotic stewardship is diagnostic stewardship begins on the day one when the patient is shown. What test to be selected, what sample to be collected, how to be tested, how to interpret it. And antibiotic stewardship begins with prescribing empirical therapy, then definitive therapy, then stopping the therapy, de-escalating. So it's more or less like a husband-wife. Okay. And husband-wife going for a long road trip. It's a dangerous thing, huh? Going for a long road trip, 6 to 8 hours together in a car. So you can imagine, diagnostic stewardship is the wife who is planning the road trip. Antibiotic stewardship is the husband who is going to drive the car. Both have to have good synergy. They should be talking to each other, listening to each other. Only then the work gets done. And then they should know that they are interdependent. One cannot work in silos. You have to be interdependent. Both work together gives you good response. So this is after a very successful road trip. Both are exhausted. The diagnostic stewardship is exhausted after giving a lot of advice. The antibiotic stewardship is also exhausted driving the car. So what happened to the test? The initial test, 23-year-old girl. So that girl came to our ER with high-grade fever, with a diagnosis of brucella on gentamicin and doxycycline. Now you see the report. Report says it's a coliform, it's a brucella. It gives you 10-15 antibiotics that cannot be used for brucellosis at all. It gives you diameters for the disc. It tells you that it is an organism which is catalase positive and urease negative. It cannot happen. Brucella is urease positive. So this is the worst kind of microbiology report you can see, and the clinician was treating the patient based on this report. And an IgM brucella also was positive for this patient. So patient was admitted in our place. We did a brucella IgM because it was considered to be brucella. IgM was positive, just above the cutoff. And then we did a SAT, it was negative. We did a Vidal, which is positive. We did a salmonella antibody, which was positive. We grew a blood culture for gram negative was positive. We did a biofire, which was salmonella positive. We did a Vitek, which identified a salmonella typhi. It was a case of enteric fever. So the crux of the thing is what test you opt in the first day. Brucella is the most notorious test to come false positive. I would never advise brucella IgM to be done in any patient unless and until you have a strong suspicion. So this guy ordered a brucella IgM which was falsely positive. The lab did the brucella IgM and the microbiologist sitting there was skewed or towards the brucella IgM positivity, saw gram negative in the blood, interpreted that it could be brucella because brucella IgM is positive, gave a brucella report, not verifying what organism is. So the patient was being treated wrongly because of a wrong IgM report, wrong culture report. He was a classical case of enteric fever. Unfortunately, it was a child of an orthopedic surgeon. So, how to select a test? It's the last slide. Test. Remember, ordering a diagnostic laboratory test is like picking your nose in full public view. You must first consider what you will do if you find something. So order a test only if you know what you will do with the test. Otherwise, don't order the test. If it comes positive, then you're in a soup. Thank you.
Thank you.
Make up. There is a reference there. It's not my quote.
Thank you so much, sir, for this wonderful talk, bridging diagnostic and antimicrobial stewardship and bridging the lab and the ward. And I have had the fortune and the privilege of having him as my guru when I was a PG student. And almost every time I see him, I would find him on the phone with a clinician. And for all the PG students who are sitting here, including mine, you need to talk to the clinician. Most of this thing, the clinical details will not be present on the requisition forms. All of you have seen the requisition forms. You know how well or otherwise it is entered. You will not find many of the clinical details there. The only way that you can find them is either the clinician calls you or you call the clinician. The clinician will not call you until and unless they learn to trust you and rely on your reports. So initially, you make the push. You call the clinician. That is how you get to this stage. The sir is an epitome of clinical microbiology, and you all should aim for that. All the PGs here, please. The field is the stage open for questions.
The most
queries.
common indication for urinary culture in my hospital is headache. Headache is written, you don't know whose headache, the doctor's headache, the patient's headache, or they are giving me headache. So that's how the request form is filled most often.
A wonderful talk in his usual typical fashion, sir.
Any questions?
Questions, queries, suggestions? All right, if there are none, then we can move forward. Thank you so much, sir, for this wonderful talk. Thank you, sir.
Thank you, sir. May I please request the chairpersons, Dr. Chitra Wilson ma'am and Dr. Gulshan Nair, sir, to present the memento to the speaker, Dr. V. Anil Kumar, sir. Thank you, everyone. Next, to honor our chairpersons, we would like to invite Dr. Chitra Jayaprakash ma'am, HOD Microbiology, MOSC Medical College, Kolonjeri. To begin with, we have Dr. Chitra Wilson ma'am. Next, we have Dr. Gulshan Nair, sir.
Thank you, MES Medical College, to give away the certificates to the chairs and speakers of the first two sessions. First, we have Dr. Anila A. Matthews ma'am. Next, we have Dr. Jasmine K. Ema. Next, our dearest speaker, Dr. Rohita Chandra ma'am. Next, Dr. Kavita Rajan ma'am. And finally, Dr. Rachna Babu ma'am.
Thank you, everyone. We would
In southern India. Nehru Group was established in 1968 with a mission to nurture and ignite the spirit of young minds. P.K. Das Institute proudly bears the name of its visionary founder, the late Sri P.K. Dasa, an academician, industrialist and philanthropist whose ideals continue to guide us. With great pride, we also state that recently our Department of Laboratory Medicine, including microbiology, has been successfully accredited by NABL. It is a very big step to ensure that both accuracy and precision are maintained for every report released from our laboratory for evidence-based patient care.
We shall begin the ceremony with a prayer. May I request everyone to please rise for the prayer.
कुन्देन्दु तुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्कर प्रभृतिभिर्देवैः सदा पूजिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्मविचारसारपरमा आद्यां जगद्वापिनीं वीणापुस्तकधारिणीमभयदा जाढ्यान्धकारापहा
thank you, everyone. Kindly be seated. Invite the dignitaries to proceed for the lighting of the lamp, symbolizing the light of knowledge and learning.
Dr. R. Satyajit Sir, Secretary, ACM Kerala Chapter, Deputy Medical Superintendent and Associate Professor, Department of Microbiology, Pikedas Institute of Medical Sciences.
A very good afternoon, everyone. We have already begun today's academic session with great insight, and it is now my privilege to formally welcome all of you for the inauguration of National CME on Diagnostic and Therapeutic Stewardship. On behalf of the Department of Microbiology, Pikedas Institute of Medical Science, and the Academy of Clinical Microbiologists, I extend a warm and respectful welcome to all present. The ACM Kerala chapter, established just a year ago, was founded with the vision of professionally connecting and networking clinical microbiologists across the state while strengthening academic collaboration. ACM Kerala chapter is proud to be the first registered microbiology society in the state of Kerala. As a young organization, we have taken our first steady steps, organizing meaningful academic initiatives, both online as well as offline. We sincerely hope that this academy continues to grow, expand its reach, and scale greater heights in the years ahead in the field of clinical microbiology. Pikedas Institute of Medical Science is an NMC-approved institution with an intake of 250 MBBS seats and a 1,050-bedded teaching hospital. We are NABH entry-level accredited and NABL accredited, and we offer more than 25 MD, MS postgraduate programs across various clinical specialties. Pikedas Institute of Medical Science has always stood for academic excellence, clinical quality, and progressive vision. It is an institution built on compassion, commitment, and continuous improvement. With a strong emphasis on quality medical education and patient-centric care, Pikedas Institute of Medical Science has created a vibrant academic environment, one that continues to nurture meaningful initiatives such as today's CME. Pikedas Institute with this spirit of academic collaboration and institutional excellence, it is my honor to welcome the esteemed dignitaries who have graced this occasion with their presence. We deeply welcome, in absentia, our Chairman and Managing Trustee of Nehru Group of Institution, Honorable Advocate Dr. P. Krishnadas, who also serves as the Honorary Trade Commissioner of Mauritius in India. His unwavering encouragement, pursuit of excellence, and constant motivation continue to inspire our institution's growth and achievements. We welcome and are privileged to have with us our Director, Dr. R.C. Krishnakumar Sir, whose leadership and vision have shaped the academic and scientific spirit of Pikedas Institute of Medical Science. Sir, your vision and unwavering support remain a source of strength and inspiration for all of us. We are also privileged to have with us Dr. Kavita Raja, President of the ACM National Body. Madam's visionary leadership and commitment to strengthening clinical microbiology at the national level have inspired professionals across the country. Madam, your presence today is a great honor for us. We are equally honored to welcome Dr. Pushpa, President of ACM Kerala Chapter. As the guiding force behind the state chapter, her dedication, enthusiasm, and relentless efforts have played a significant role in uniting microbiologists across Kerala and nurturing academic collaboration. Madam, we are grateful for your leadership and delighted to have you with us today. We are also delighted to welcome Dr. Mangayar Karsi, Secretary of ACM National Body. Her dedicated organizational leadership has greatly strengthened ACM's growth across the country. Madam, we are grateful for your presence today. We also acknowledge our principal, Dr. Satish Prabhu, for his constant guidance and encouragement in all our academic endeavors. His leadership continues to elevate the standards of our institution. It's also our pleasure to welcome the HOD of Department of Microbiology at Pikedas Institute of Medical Science, Dr. Ravi Sir, in this August gathering. A special note of appreciation to our distinguished speakers and session chairs, whose expertise and insights will enrich today's discussion and learning. We also acknowledge all faculty members, postgraduates, and delegates who have joined us today. Your presence and participation give true meaning to this CME. As we begin, let us engage wholeheartedly and carry forward a shared commitment to strengthening diagnostic and therapeutic stewardship for better patient outcomes. Thank you once again, and wishing you all a deeply enriching academic experience. Thank you.
Respected Dr. Krishna Kumar, Director of Operations, PK Das Institute, Dr. Satish Prabhu, Principal of PK Das Institute, Head of Department of Microbiology, Dr. Ravi, Dr. V. Mangayaka Rishi, Secretary of Academy of Clinical Microbiologists, Dr. Satyajit, dear friends, colleagues, students, and faculty members, a warm welcome to this National CME of Academy of Clinical Microbiologists. As a president for the last 3 years and as a founder member of the Academy of Clinical Microbiologists, I would like to put on record the fact that clinical microbiology has been growing by leaps and bounds. There has been such a lot of progress not only within India but also outside, that is at the international level. People are looking into infectious diseases in a totally different way. They have realized the importance of infectious diseases long before COVID. That is why we have the CLSI, UCAST, and so many guidelines, so many associations are there all over the world which are giving us guidelines and methods of doing things in a proper way. And it is only now in India that we have realized the importance of following certain protocols, following certain guidelines for proper treatment of the patient. It is not just a doctor-patient relationship. It is the patient who is being treated by a team of doctors. It is not an individual thing. At the patient level, they still think that it is this doctor or that doctor who has treated us and made us better. But we know very well now that no doctor works alone. It's not only his clinical team. We have to build the laboratory team also. Pathologists, clinical microbiologists, biochemists, all work together for the betterment of the patient. So my only message in this presidential address to all of you is that as clinical microbiologists, we should always put the patient first. We always think of a sample. It's a sample, it's a urine sample. This sample gave this result. No, it's not that. When you get a sample, for example, a blood sample, you should think of the patient who is sitting there in his bed or being very sick. So if you phone up, you will find that your patient, you will get a mental picture of the patient. When you look at the request form, you know how old the patient is, male or female, and then what is actually happening to that patient, you can phone up and find out. Only after you get all this, you look at your microbiology sample. That is my biggest advice to you. First, you get a background idea of the patient. Then you take up the request form and start reading one by one what is the sample, when it was taken. Then you go to your result, how you are going to give the result. That will make a total change in your reporting. Don't start from your report first and then go back to the patient. So that is one message. Another thing I would want to say is that microbiologists also cannot work alone. They cannot be a single microbiologist sitting in a lab. Maybe in a medical college you have 10 or 12 microbiologists, but in a corporate hospital there will be only one person. But that is, you are not alone. That is what the Academy of Clinical Microbiologists, that is the message we have to give to each and every microbiologist sitting here. I know there are people from medical colleges, there are people from standalone labs, there are people from corporate hospitals, there are people from private clinics, smaller clinics like. So all these people, we have to come together under the flag of ACM. It's not just for getting together and having some fun. It should be on a monthly basis. So that is my next endeavor, that all of us should get together on a monthly basis. You have seen the cases, Rohita, Anil, even Dr. Iyer, they have all showed us how we are struggling with the diagnosis. We are not seeing the patient directly, but we have to give advice on such a patient. So how can we do it all alone, especially when we have experience? Like we senior persons have, it is okay, we can do it. But what about the others who have just joined a hospital? He or she is the infection control officer, has a lot of responsibilities in the hospital. That alone feeling should not be there if that person is a member of the ACM. Why? How can we do that? That should be our focus. How can we do that? They are all part of a community, and this community is going to help you do your job better. That is how we will reach the patients everywhere. We will not concern with only our patient, our medical college, our hospital. That should not be the aim of ACM. We should have a comprehensive thing, and we should learn together. So some few things that we heard today are absolutely new to us. We have never heard of all these things. I'm sure in the last 3 lectures you must have heard at least 2 or 3 new things that you have never heard of before. Why haven't you heard of it before? Because you have not talked to anybody. You have not talked to another microbiologist. You are talking to clinicians maybe. But have you talked to somebody in another hospital? That is not happening nowadays. So what I want the office bearers of ACM to the next step should be a collaborative thing. That is, we should all be meeting together. We should all be discussing our cases, and not only the cases that we have been very good at and the patient has gone happy and healthy. Not only those cases, but places where we have stumbled, where we had made wrong diagnosis, where we were little slow in reporting. How we can help to become more accurate and more fast. By taking the advice of others only we can do that. Others with more experience. So, and even those who are working parallelly with us, if only we talk together we can do that. So I would like Kerala chapter also to organize such things. It's a monthly thing, and all those who want to present cases, we will just give out a circular in our ACM group that all those who want to present cases can present cases. This is the link, and then we will all come online and we can have one by one the cases, or maybe a series of cases, and then we can discuss how that could have been done. So we can take 4 or 5 cases for each online session of 1 hour or something, and all the others can listen in, because listening also, when you listen, even if you don't present, when you listen you gain a lot. But this CME happens only once in 6 months, and that too you may not be able to go for the CME. But for an online thing, I think that should be the focus now, from now onwards, so that all of us microbiologists remain connected with each other. What are the specialized investigations available? Where are they available? How we can contact that person? All these things have to happen. And like Dr. Iyer sir was just discussing, from that point we can make focal groups, we can make small groups, pediatric group, oncology group. So those groups will focus on their specialties, and we can have more interactions online, and from that group we can have more activities. So that is going to be our focus in our meeting also. And thank you very much for inviting me and giving me this opportunity to speak. Thank you very much, sir.
Thank you, ma'am, for your inspiring words.
We now invite our chief guest, Dr. R.C. Krishna Kumar sir, Director of Operations, PKDMS, to speak a few words.
Respected President of today's function, the National President of ACM, Dr. Kavita Raja, respected President of ACM Kerala Chapter, Dr. Pushpa, Secretary ACM, respected Dr. Mangiyar Karasi, respected Principal, of Pikedas Institute of Medical Sciences, Dr. Satish G. Prabhu, our dear Dr. Devichandran, HOD Microbiology and organizing chairman of this CME, the major brain behind today's CME and the organizing secretary, Associate Professor and Deputy Medical Superintendent of P.K. Das Institute of Medical Sciences, Dr. R. Satyajit, respected senior faculty members, beloved juniors, dear students, a very warm good morning to you all. I'm extremely happy to stand before you representing P.K. Das Institute of Medical Sciences. And it gives me immense pride and joy to welcome you to this National Conference on Diagnostic and Therapeutic Stewardship. Hosting this gathering of brilliant minds in microbiology, infectious diseases, and clinical sciences is a moment of great honor for all of us here. The theme of this conference, Diagnostic and Therapeutic Stewardship, is not just academically relevant. It is representing national and international priority. Responsible diagnostics and rational therapeutics form the foundation of safe, effective, and sustainable patient care, as we all know. At a time when antimicrobial resistance and a lack of newer antibiotics threatens global health, our collective commitment to stewardship is more crucial than ever. As the host institution, we are delighted to provide a platform where ideas can grow, collaborations can flourish, and innovations can emerge. Stewardship is ultimately a culture, and gatherings like this strengthen that culture and move us forward to more judicious diagnostics and therapeutics. And as Madam has rightly mentioned, this should be the beginning of an online, ongoing program for sharing your ideas, sharing your concerns, and sharing your problems. I think that will definitely carry forward the purpose of this meeting. On behalf of P.K. Das Institute of Medical Sciences, I extend my warmest congratulations and best wishes for a meaningful, productive, and inspiring conference. Thank you all from the bottom of my heart.
Thank you, sir, for your motivating words and presence. May I invite Dr. Pushpa K. Ma'am, President, ACM Kerala State Chapter, to deliver the keynote address.
Respected dignitaries on end of the dais, esteemed faculty members, dear colleagues and participants, very good morning to all of you. It is my immense pleasure to address you all in this CME program, which discuss on the most important topic of current relevance. We already had listened to 3 brainstorming sessions by esteemed faculty members. That is therapeutics, diagnostic and therapeutic stewardship. This topic is truly defines the quality and safety of modern health science. Today, we stand at the crossroads of medical advancement and microbiological evolution. And day by day, we are being reminded that it is high time to strictly stick on to the responsibility to use our antibiotics wisely and judiciously. The classic concept, the tragedy of the commons, I think most of you have heard that. It is best applied to the rising antimicrobial resistance in the community. That is, when an individual uses a shared resources for their own immediate benefit, it destroys the resource for everyone. That is the tragedy of commons. A clinician can easily say, I am using this antibiotic and my individual patient is getting better quickly. And the tragedy here is the collective harm. Antibiotics loses effectiveness for everyone. That is what is happening currently. And even with ongoing sessions of awareness programs, seminars, webinars, etc., still we come across the fact that the reserved drugs like meropenem, linezolid, etc., are being used lavishly as the first-line treatment choice by many of the doctors. Sometimes even as prophylactic drugs, these are being used. In this context, the diagnostic and therapeutic stewardships are not just medical strategies, they are of ethical mandates. So let us remember that the fight against AMR cannot be silent. There is continuing need for us to raise our collective voice for antimicrobial stewardship louder and stronger than ever before. Now, when we have formed our ACM Kerala chapter, the main objective was to bring a collective networking between clinical microbiologists all over Kerala to share the academic updates and to equip and enforce the team to bring out the best of diagnostic and therapeutic stewardship practices as possible within the available circumstances they work. That is the only thing we can offer. We always come across issues of overburdened patients, overburdened diagnostic testing, etc. And we are actually envied of Rohita. Many of us were talking like she is handling a particular group of clinicians, so it may be easy. And for my medical college setup, it is quite difficult. So we are, even though we are hardly trying for that, we find it slightly difficult. We have conducted webinars on monthly basis and 2 CMEs, and this is the second one. And we wholeheartedly take Kavita Madam's advice. We will try to do that continuing clinico-microbiological interactive sessions as far as possible, Madam. I wish all success to this endeavor and express my gratitude to the P.K. Das Institute of Medical Science, the Director Board, the Principal, the Organizing Committee, the Department of Microbiology for arranging this wonderful program so nicely, and my thanks are extended to the faculty members, delegates and participants. Thank you very much.
Thank you, ma'am, for your insightful thoughts.
May I now invite Dr. Satish G. Prabhusar, Principal, P.K. Das Institute of Medical Sciences, to offer his felicitation.
A warm good morning to all. Respected Advocate Dr. P. Krishnadas, Chancellor of P.K. Das deemed to be University and Managing Trustee of NGI in his absence, Dr. R.C. Krishnakumar, Director, Operations of P.K. Das Institute of Medical Science, Dr. Kavita Raja, President, ACM, Dr. Pushpa K, President of ACM Kerala Chapter, Dr. V. Mangayakarasi, Secretary, ACM, Dr. Dr. Ravichandran, HOD Microbiology and Organizing Chairman of CME, Dr. Satyajit, the chief man behind this CME, and our Associate Professor, the Department of Microbiology, who have put in their effort and time in organizing this CME, all the other senior faculty members in the audience, my own fellow colleagues, and faculty from other institutions, some of whom I know. Welcome on my behalf and on behalf of the institution. The theme of this CMA is diagnostic and therapeutic stewardship. From whatever I have learned or whatever I have read, stewardship refers to taking the right decision at the right time, the right person, and in the right manner. Being a surgeon, a practicing surgeon, I find that we are really afraid of stewardship. The reasons are many. The thing is, we employ antibiotics. Whenever a term like stewardship comes to us, we are really afraid. എന്താണാവോ പറയാൻ പോകുന്നത്? I don't know what they are going to say. And if this is also being, if they say don't use this, don't use that, don't use this, and you use this, that's a reality. And partly from the practicing point it is true. But now I am very happy that many places, because of programs like this and because of the positive attitude of the microbiologists, a sense of awareness has been created among the surgeons, especially the surgeons, physicians next, and all others later. And as rightly pointed out by the opening speaker in her presentation address, Dr. Kavita Raja, Madam has rightly pointed out that you should not be taken away by the success that you reach, but you should also be concerned about the stumbles, the problems that which the failing cases encounter. And that is precisely where I feel that stewardship holds a key, so that the best result is given to the patient. And if you ask me, is it the best result? No, definitely not. The optimum, because this keeps on changing. During our college days, there were only 3 antibiotics, and it was easy to use it. Ampicillin, gentamicin, and to cover the anaerobes, metronidazole. Things were easy. Blissful ignorance. And I am sure that this CME will be an eye-opener to all who attend this program, this CME. It will also be a forum to share the views and create awareness and dispel the darkness from each and everyone. I wish a great success. Do enjoy the hospitality of PK Das, the Vallunadan cuisine, right? Satyajit has taken all the troubles to dish out the best, and I am sure that, and I am very happy that we were able, as an institution, we were able to host a CME from the paramedical sciences. About 2 weeks back, we had a state conference on surgery, and I am very happy that we are able to hold another one within a period of 1 month. Once again, wish you all the best, all great success to this CME. Bye.
Thank you, sir. May I now invite Dr. V. Mangyakasi Ma'am, National Secretary, ACM, and Professor and HOD Department of Microbiology, Faculty in Charge, AIMS, Madurai.
Respected administrators, the Chancellor of PK Das Medical Institution, the Director of PK Das Institution, and the Principal and other administrators from PK Das Institution, the President of ACM, Dr. Kavita Raja Madam, and the Kerala Chapter ACM, Dr. Pushpa, and the Senior Professors, and the ACM, Dr. Ranganathan Iyer Sir, and other professors, and the dear delegates. A very good morning, all of you. It's an honor for me and pleasure for me to participate in this great occasion. Actually, we all from National Institution, All India Institution. I have seen many speakers from various institutions, including the National Institute of JIPMER and other institutions. So it's a platform the PK Das Institution created to join national institutions to the state universities and state institutions to talk about the antimicrobial stewardship. It's a very important. This is the platform to join with the clinicians and collaborate with the clinicians. We have to invite all the clinicians in future programs. And here see I am many women, the women power here. So they are all, many women are now the medical superintendents. So just now madam told that even Satyajit also a medical superintendent here. So all the microbiologists have the opportunity to become a medical superintendent of the institutions to take up this antibiotic stewardship and make a guidelines. And one thing why we need to collaborate with the clinicians, definitely for from sample collection to therapy and other thing, but also very importantly the de-escalation therapy and the transition therapy, how they are switching over from empirical therapy to the appropriate narrow spectrum therapy. That is very, very important. So we have to go to the clinical area and to see the therapy, how they are following the antimicrobial, our antibiotic report and other things. So this has to be published, and each and every medical college to create the guidelines and share in this type of the platform. That is my request. So thank you for this wonderful opportunity given by the platform created by the PK Das Medical Institutions and the great administrators. And I appreciate Dr. Satyajit and his team who are all in the organizing this such wonderful CME. So I appreciate, and my wishes to success for this program. Thank you so much.
Dr. Kavita Rajan ma'am, and Dr. V. Mangia Kirsti ma'am, ACM National Secretary.
வணக்கம் வணக்கம் நமஸ்காரம் குட் மார்னிங் പറയணும் குட் ആഫ്റ്റർനൂൺ പറയணும் சார் good afternoon everyone. Finally we are coming to the end of inaugural function. It's my privilege on behalf of Department of Microbiology, PK Das Institute of Medical Sciences, and the Academy of Clinical Microbiologists to extend our heartfelt thanks to all who made this day a reality. We are deeply honored by gracious presence of our all dignitaries. We are especially grateful to our chairman, Dr. P. Krishnadas sir, in his absence. Our sincere thanks to our beloved director sir, R.C. Krishnakumar sir, and we express our heartfelt gratitude to our respected principal sir. We express our deepest gratitude to management of PK Das Institute of Medical Sciences. We thank the Academy of Clinical Microbiologists, especially Dr. Kavita Raja madam and Mangekar si madam, State President Dr. Pushpa madam, and our own Satyajit. And a warm thank you to all our distinguished speakers, panelists, session chair and moderators, and PG students. Our appreciation also goes to the organizing committee of our ACM and PK Das Institute of Medical Sciences. We are grateful to our industry partners, BioMerio, Metropolis, Malbio, High Stacks Analytics, and DDRC. To all our delegates, thank you for your enthusiasm. Behind the scene, our volunteers, especially our student volunteers, technical team, HR department, IT department, supporting staff, transport and cleaning, and decorative staffs. I hope that we carry forward the insights gained today to strengthen our diagnostic and therapeutic stewardship and translate knowledge into the better patient care. Thank you all once again. Looking forward to meeting you at further events. Nandri, Namaskaram, Jai Hind.
So it's my honor to introduce Dr. Professor Nizat. So currently he is having extramural funding, and he is a principal investigator of 2 crores of fund and co-principal of principal investigator of 16 crores of fund. So his research area of interest is neonatal sepsis, nutrition and growth of preterm infants. And also he has conducted many workshops in research methodology, and he has given a training to all the educators, Microsoft Excel, Stata or graphics for publication and communication, and skills for faculties and trainees. So may I welcome Nizat sir to deliver his lecture. Thank you.
Thank you. Very kind introduction. It's not on my CV, but I'm actually a local guy. I think I'm more local than most of the people here. I was born maybe 4 kilometers from here, Seventh Day Adventist Hospital. I'm from Chaplasheri, very near. I went to high school in, I used to pass in front of this place on my way to Thrissur Medical College and back. This place didn't exist at that time. So I'm a very local person. It's not mentioned on, and in case you're wondering who invited the village idiot for this talk, that's Dr. Chitra Valsan. She's sitting right there. So you can complain to her after this if I don't meet your standards. But really, that's probably not the reason. I work very closely with microbiology and especially my friend Apurba Shastri. At any given time, we have a couple of research projects going on. And neonatology is one of the departments that's most compliant with the HICP's, Hospital Infection Control and Prevention Committee's policies as well. So I get invited to some of the microbiology talks now and then, although I'm 100% a clinician. One of those evil clinicians that you've been hearing about in the last few sessions. So I think, so let's see if this works. I have no commercial interests to disclose. I have multiple research projects related to sepsis and antimicrobial resistance. I have a few slides from Dr. Apurba Shastri, my friend, related to HICP, and I'll mention that when I come to it. I think I don't need to tell you about JIPMER, so I'll skip that part. We are a national institute. Right now, I think about 2,500 beds. It's a new building has been commissioned. 60 of those beds are in the NICU. So I'm a neonatologist. I have the smallest customers in the hospital. And I think Dr. Iyer was mentioning how neonatologists panic when you ask for 3-4 ml of blood. So to put it in perspective for the residents and trainees here, if you have a 600-grammer baby, that baby's total blood volume is 60 ml, right? So if you have a soaked gauze pad during a procedure, that baby is in shock. For perspective, the cup of tea that you drank some time ago was probably 150 ml, the paper cup. So 60 ml, you can imagine how much that's the total blood volume we are talking about. So if pathology says that the PTA, PTT blood sample is clotted, we get heartache. That's 1.8 ml gone right there. So we have about 10,000 live births a year. These are all real photos from my unit. And I think for the most part, I'll be talking from my own experience and our own research work. In fact, all these slides only contain that. NICU has been hand hygiene champions in JIPMER since, actually we started hand hygiene audits before NHICC existed, and we have been hand hygiene champions every year for the last 10 years or so. Usually we are first or second in the monthly rankings, sometimes a bit worse. Typically compliance is in the 90% range. So that's, by the way, nurses and families mothers doing huddle in the morning when we also listen to their problems, but we also do hand hygiene together. That's done once per shift in addition to the usual 5 moments. So just from our own work, I'm going to try and show you again for the trainees predominantly how big the crisis of antimicrobial resistance is, and maybe we'll briefly talk about how children are different. They are Homo sapiens, they are the same species, but there are some important differences for neonates and children. And what maybe the core components I'll briefly touch upon, and the microbiologist's role. I don't need to preach to the choir here, but still maybe for the students. So this is the first article that I wanted to talk to you about. Our contribution was pretty minimal. They had a few million records in this global analysis, and out of that 400 were neonates from JIPMER. And I think otherwise also to the paper my contribution was pretty minimal, but this was a landmark paper, and this mapped antimicrobial resistance across the world. Even for countries for whom data were not available because of sophisticated techniques, they could map it and estimate the antimicrobial resistance if they had it for neighboring countries. And this is the magnitude of the problem. About 5 million deaths associated with it. That means the patient died with an antimicrobial resistant organism, and 1.3 million deaths attributable to it, which means that even if they didn't have antimicrobial resistance, they would have, many of them would have still died, but at least 1.3 million extra deaths because the organisms were insensitive. And that was just 1 year. So you can imagine that how many million lives are lost every single year because of this. And this problem is only getting worse. So right now I think the numbers will be much worse than that. And I'm only going to show one image from that, and you can see this information here. Carbapenem resistance is about more than 80% in India. Canada, you can see, is in blue. They have less than 5% or maybe 5 to 10% antimicrobial resistance for Acinetobacter, and we have more than 80%. And we have other studies to look at it. This was a global study about 11 countries and 19 sites that we did. JIPMER was one of the larger centers. Looking at we looked at the patterns of antibiotic use, but also the pathogens, antimicrobial resistance, and their link to mortality. This was laying the groundwork for a randomized trial of new novel antibiotic regimens that we are going to start in March probably. That's again going to be a global RCT. This is a complicated graph, an alluvial diagram showing which antibiotics. On the left you see the initial regimen based on the WHO classification, access, watch, and reserve antibiotics. So the bottommost part, the interesting thing is very often the initial antibiotic, 2% of children, the initial antibiotics were in the reserve class. So that means they were getting started on something like colistin or linezolid as the first line of antibiotics. That's the key takeaway point from that. So that part, the group 5, some of the babies were getting actually started on even the reserve antibiotic as first line. We also looked at our own data from our center, and this was with Apurba as usual. So we actually found that 55% of all our BSIs were MDR. And this kind of coincides with the national rates, about 80% of Acinetobacter, which is the most antimicrobial resistant organism, and then Klebsiella and less so E. coli. And mortality rate tends to be around 40% if it's MDR, slightly less if it is antibiotic sensitive. But you might be thinking that's a tertiary care center, so we also looked at district hospitals. This was published just earlier this year, multi-drug resistant sepsis in special newborn care units. These are district level units. So we had 5 from across India, 4 from the 4 sites, south, north, east, and west, and 1 from central India. And the results were not very different. This is again a busy slide, and I'm not going to go into the details, but the middle bar in each cluster for each organism, the middle bar is carbapenem resistance. And you can see in the last one, Acinetobacter, the middle bar is about 75%. I think the laser pointer is not working, so you will just have to look at the middle bar there. That's 75%. And the last bar is multi-drug resistance. That's also very high across the board for even Klebsiella, E. coli, and other gram-negative. So So for children, just to place this in context, for children you know that it's a more sensitive issue. Children are brought to you with URI, now it's viral season, there's a lot of flu going on. Plus other respiratory infections, RSV and other viral infections. They are brought sometimes with high fever and they look toxic even if it's a viral infection sometimes, and parents are quite agitated. There's a lot of pressure on clinicians to start antibiotics, and in fact 20-30% of OPD visits end up with an antibiotic prescription, and much more if they are admitted. In addition, there are some other differences. You already know that this is a developing individual and the organ systems are also developing. So that makes the pharmacokinetics and pharmacodynamics very different. So this makes our antibiotic management very different. Even inside the NICU, we have different levels of dosing, for example, for different babies, depending on the gestational age, day of life, birth weight and other things. So it can be very challenging, and partly because we don't have any standardized pediatric formulations and we have to rely on the weight as a proxy very often, and we have right now very limited access or very delayed access to drug level monitoring. So if you want to do vancomycin levels, amikacin levels, either it's not available or the turnaround time is so high that it becomes useless to decide whether to, the duration of the interval, for example, for amikacin, you can decide based on the TDM, but the report doesn't come back in time. It may take a day or two sometimes. The impact of on the microbiome is again an increasing area of focus. Like how does, microbiome has been blamed for many things now, from inflammatory bowel disease to dementia to diabetes to chocolate craving. So we don't know the effect fully yet of what antibiotics will do to these organisms if they are exposed early. We do have data from neonates saying that it's affected, but what is the long-term impact is what we don't know. Does it cause more allergies? Does it predispose them to diabetes? We don't know that. And then, of course, a diagnostic difficulty. When I wanted to take pediatrics, my friend said, don't do that. It's like veterinary medicine. They won't tell you anything. It's very difficult to diagnose anything. That is not entirely true. Children are excellent communicators, but there is still some diagnostic difficulty because of non-specific signs and symptoms. They have a few common symptoms. Neonates, for example, get hypothermic, and that is a symptom of many things, unfortunately. The core elements are the same. So pediatric ASP is not very different from adult in that sense. The leadership has to commit to the resources. Fortunately for us in JIPMER, that has worked out very well, and they have a nice antimicrobial stewardship program, but it has taken significant work from Apurba and the microbiology team to get it established and to get the nurses, for example, 10 or 12 hospital infection control nurses, and support from the clinicians. And then you have to designate who does what, and like the other speakers mentioned, this works mainly through WhatsApp, but you still have to decide what the residents can do, what the residents can do, what the hospital infection control fellow does, what the microbiologist does, what the consultants in neonatology and other departments will do. That takes some time to establish. So maturation of the ASP takes time. It takes many years. And then implementation of the guidelines. It's one thing to have a guideline, and getting it to actually work on the ground is very difficult unless you have buy-in from clinicians. Again, takes time and convincing. It's a little easier in an academic institution, that I can tell you. Tracking and reporting, WhatsApp is great, but you still have to, this is a two-way process, so just putting the reports in WhatsApp won't do. There is going to be some communication back and forth. And continuous training. Nurses are a floating population, residents change all the time, and even consultants change over time. And this has been a challenge, but so far they've had to manage to get a core nucleus of hospital infection control nurses who are more or less stayed constant, and for the most part consultants are constant. So we actually have managed to get this working on somewhat of a reasonable basis. So I don't need to tell you what the role of the microbiologist is. Traditionally antibiogram, but now they have the rapid diagnostics. In our setting, that's predominantly what microbiology handles is procalcitonin, things like that. We also have quantitative CRP and other things. and more recently BioFire is available. So molecular diagnostics, they have some, and for viral and other things, they have many other things, but I'm mainly looking at this from a bacterial sepsis, bloodstream infection in neonates perspective. So, but we are again very conducive with that. You know, we know the cost and you know, false negatives and false positives. I have never ordered a BioFire test in my life, yet to start. So, and they do selective reporting. So if it's sensitive to meropenem, but also sensitive to ciprofloxacin, they may not report the meropenem. Cheat us a little, try us to get start. And if we need it, like say if it's meningitis, for example, where ciprofloxacin is not a great choice, and we ask them, they will often tell us. And of course, managing the team. This has been a lot of Apurba's work, I think, over the last few years. This is our antibiogram for last year, I think, and about 3,000 isolates in all, 2,300 gram negative and about 700 gram positive. And this is for the whole hospital, and this gets sent to us every year. And he also splits this up into, for example, pediatric and neonatal and trauma and other things, and sends the separate antibiograms also. So this is very useful. In addition, we maybe when we have a problem, we think there is a change in the pattern of organisms in the unit, we do our own, like we collect the data from microbiology and make our own antibiograms for say the last 4 or 5 months, and use that to decide on our antibiotic policy. The turnaround time has been pretty good now. Every time I go to the microbiology lab, they seem to get some new equipment, and it's not just the equipment, it's the people behind it that's actually made this possible. Typically, all our positive cultures come back, 95% of our positive cultures come back within 12 hours or 16 hours at the most, and only a few after that. So, and it's communicated to us very quickly. Currently, the burst performing part is us getting the bottles to them. That takes sometimes 3-4 hours, depending on when the, you know, when a person is available to carry this. The chute system has still not been established in Jipmer. The turnaround time is very, very good now, and that's all thanks to the microbiology team. In India, I would say there are multiple challenges to having a good antimicrobial stewardship program. One is our prescription for viral infections. That is very difficult to you know, get a handle on. There is over-the-counter access to antibiotics still continuing. Schedule H drugs, you can still get it over the counter in most places, I think. The government is making an effort, but I don't think at the ground level things have changed a lot. Manpower issues are a problem, and I'm guessing this will be worse in private settings, getting dedicated, for example, hospital infection control nurses to run a program when you cannot show any tangible benefits from it, economic or otherwise. It's going to be a little hard, but we, at least in academic settings, we definitely should have that. We also, like I said, have dose optimization issues because of multiple problems. But what works is, one, we have antibiotic policies, and especially in a teaching institution like this, or in, or nowadays in any large hospital, you should be able to get people to stick to their own guidelines. It may not be the national guidelines or international guidelines, it may be a hospital guideline, but getting people to stick to it is key to, you know, managing antibiotic use. De-escalation works wonderfully well, and that has worked for us partly because of pressure from, but this has for the most part come from the clinician side, you know, with the switch to narrow spectrum antibiotic or switch from IV to oral, and especially in some things like neonatology, this push has been very strong. And now recently we have had much more literature also, including one large multicentric study showing that shorter course of antibiotics works as well as a longer course, 14-day course, 7 days instead of 14 days in some kinds of neonatal sepsis. So that can also cut down the duration of antibiotics. These are all going to change guidelines in the next year or so. And rapid diagnostics are useful, but as long as you have the will to use it sensibly. Otherwise, you will end up with a lot of false positives and a lot of over treatment and some false negatives also. I think Dr. Iyer showed that data already. And data sharing networks are important. If you look at your own data, it is going to be a very skewed thing, and there will be too much fluctuation. Like this 6 months it will be something, next 6 months it will be something. I think this is the way to go, and that is what we have been doing in most of the studies that I showed you. Shorter duration, definitely. And prospective audit and feedback surprisingly works. It takes manpower, but when we have DM, clinical immunology residents, clinical pharmacology residents rotating with us, or a microbiology fellow rotating with us, resident rotating with us, or a hospital infection control fellow rotating with us, we do this in kind of the ideal way, and we've seen it work in a Canadian setting also. This actually works surprisingly well. What Apurva has been doing in our unit and others right now is pathogen-directed antimicrobial stewardship audit rounds, and they actually, this was relatively recent, I think maybe 2-3 years now, and this is the kind of the workflow for that. They look at the blood culture, and then there is a communication with the clinical team, exactly what the other speakers were talking about, and the initial advice given, but they are also checking the compliance and charting the compliance. So I didn't know about this, that they are actually looking at the data on our compliance behind our backs, and this is their Excel sheet, and I just got this a few days ago from him. And this is kind of the compliance right now. Pretty good, I think, 93% overall compliance. That is in the last few months. And they actually have detailed for each step what is the percentage of compliance. So for de-escalation, you can see it's not so great, 50% compliance or something so far. And they also use a paper form for that. So back to your role, data is the foundation. So think of everything as data. And look at, share it with others, and try to do it as a research project if possible, so you can educate others also, you can publish it, you can tell others also. And I think multiple people before me have said, be a consultant, don't just report the results, communicate with people, and the patient is at the other end of the sample, so you have to keep that patient in mind, in our case the baby. Educate and collaborate. This is really collaborative work, and it has been very useful for both sides. It's been useful for microbiologists, and it's been very good for us and our patients. So this is our hospital infection control team. I work very closely with, I know all these nurses by name, and of course Apurva is a good friend. And he wanted to invite you. So this is free advertisement for him. I should charge him for this. So in February he's having a workshop. So thank you. These are my babies and some of my team.
Thank you so much, sir, for this enriching session. Just in the neonatal point of view, I want to ask you, what is the role of procalcitonin in early onset sepsis? Any role, any JIPMER ideas based on that?
I mean, we ourselves haven't looked into the role of procalcitonin, but the Neopin's trial has developed a nomogram. Although it's predominantly Western, it somewhat works similarly in our setting. So they have a nomogram to interpret the procalcitonin depending on the hour of life at which you do it. But we haven't been using it. One procalcitonin is expensive, about 1,000 rupees per test. I know the cost of most of these tests. CRP would be much cheaper, and you can also interpret it in a time-dependent way if you do it. Second point is that there is some turnaround time, but you cannot wait for that to start antibiotic. So in very selected cases, there may be a role when it's borderline whether to start based on risk factors or not, and you really can wait. In that case, maybe. So we have been using it very selectively, very, very occasionally. But there is a published nomogram for the interpretation of the value, time dependent.
Thank you so much, sir.
Thank you, Dr. Nishat.
Thank you.
Almost you covered and told about the responsibility of microbiologists and the responsibility of the clinicians. And of course, what you've shown, everything is for the National Institute. They are having a good system. So the compliance is, it's not
better.
Better.
Not just being a national institute, I think being a teaching hospital helps.
Teaching hospital.
we generally have to, there is some pressure to practice what you preach.
So there is a good
So,
system.
yeah.
So our worry is about the gaps and other thing will be in the community, that the private practitioners, and so you told that collaboration and education. So and also
Yeah.
you well trained and many conducting workshops and communication skills for faculty.
Right.
What about the local practitioners, whether
Yes.
you're giving any training
Yes.
to transit this system from National Institute or like other medical institution, well-established medical institutions, to the private practitioners?
Yes. So not very consistently and not focused on antimicrobial use, I'm afraid. But for example, the district hospital study that I showed actually evolved from the fact that I was mentoring a district hospital in Kadalur. They have 6 pediatricians there. Tamil Nadu, like Kerala, has an excellent healthcare system. And in fact, in some ways, a better government funded healthcare system than ours, I think. And I was going there, taking classes regularly, mentoring them, and then as part of this project, we were mentoring that NICU, taking their blood culture samples to JIPMER and testing it there and getting them the reports. And it's a two-way process. They would often ask us about what to do about antibiotics also. So they get more confidence to stop antibiotics early when it's not indicated. Some hand-holding is required. But unfortunately, I don't think that INIs alone, the Institutes of National Importance alone, can do that training part. There is a lot of focus on oxygen use, for example, through facility-based newborn care and other government programs. It is.
That's very important,
Yeah.
Madam, the public awareness and the community participation for making this antibiotic stewardship. Any other questions from audience? It's open for discussion. No, then thank you very
Thank
much
you.
for your wonderful.
Thank you. Thank you for inviting.
Thank you, sir. May I please request the chairpersons to present the memento to our dear speaker.
Next, we would like to request Dr. Kavita Raja ma'am to present the mementos to the chairpersons, Dr. Mangai Karasi ma'am and Dr. Vidya Shankari ma'am.
So, antimicrobial stewardship is often perceived as a vast, complex domain. But interestingly, most of the meaningful gains comes from simple, consistent actions. The low harvesting fruits, which are quite easy to implement, but with high impact. And to speak on this topic, may I invite Dr. Neto George, Assistant Professor Infectious Diseases, GMC Kottayam, with whom I had the privilege of working closely and implementing some of these simple yet powerful tools in our institution. Dr. Neto has got expertise in infectious disease in critical care, in infectious diseases in transplant, as well as in antimicrobial stewardship. And there are several publications to his credit. So, to harvest the low-hanging fruits of stewardship, no better than Dr. Neto. Over to you.
So, thanks Sonia Madam for the
kind introduction. Thanks to my undergraduate teacher Chitra Valsan madam and Dr. Satyajit for inviting me for this talk. So without wasting time, I'll start. For the next 20-25 minutes. I'll be discussing about few practical things. That's the low-hanging fruits in antimicrobial stewardship. So why did this low-hanging fruit concept come? It is simply because actually all these stewardship concepts came from the USA. But the problem is just like what is happening in India also. Everyone tells stewardship. You have to employ stewardship for JC accreditation. Now NABH is coming up with this. But no hospital is ready to spend a lot of fund or recruit more people for stewardship. So practically what we can do is whatever funds is available, by standing within the whatever facilities are available, we will have to do. So one flowery name has been put for that. That is a low-hanging fruits. Okay, we'll move. So what is low-hanging fruit? That's the most obtainable or feasible model. Few resources and less effort. Actually, it is not less effort. We have to put more effort. But they should apply to all the settings, and there should be significant financial savings. So this paper has been put in the Clinical Infectious Disease Journal back in the year 2012. Is low-hanging fruit worth picking for antimicrobial stewardship program? And from this day in 2012, we have been using this term low-hanging fruits. So what is the main reason for antimicrobial resistance? The main reason is it is the use of antibiotics. So wherever we need to use ceftriaxone, we go for piperacillin tazobactam. Wherever we need piptas, we give meropenem. Wherever we need meropenem, we give colistin. And eventually all this has led to antimicrobial resistance. So the usual mistakes in any prescriptions are clinician don't send cultures, a lot of unnecessary prescription. Whenever you prescribe the broad spectrum antibiotics, there are a lot of dosing errors, poor choices, ignorance of PKPD, and delayed de-escalation. All these do happen. Okay. So the rights we have already spoken, right antibiotic to the right patient and the right time, right dose, right route, and right duration. And when you try implementing AMS, there are a lot of difficulties. So there is a lot of resistance from clinician. They try to use a broad spectrum antibiotic. Culture positivity rates are dismal in some institution. Now with the newer technologies, it's improving. And funding is always a big issue. And there is an unawareness about the hospital flora between the clinicians who are working in the same hospital. So who can implement this? An ID specialist, clinical microbiologist, clinical pharmacologist. Everyone can, anybody can implement, can be a antibiotic steward. So for being an antibiotic steward, actually you should be thick-skinned, because a lot of time, whenever any microbiologist or an ID physician try to become an antibiotic steward, you will face a lot of backstabbing from the clinician, I would say. And I'm a clinician, but many times we feel so that we are a bit harsh towards a microbiologist, at least in some aspects. Okay. But anyway, whatever hardships you get, you should be ever smiling. So that's a dictum in antibiotic stewardship. So there are core elements. So CDC has put up a lot of things. So whenever you move to antibiotic stewardship, I am supposed to talk about the low-hanging fruit. First thing is hospital leadership commitment. So you go to the hospital management, okay, you as a clinical microbiologist who is an antibiotic steward or an ID physician, you go and tell, okay, for this NABH accreditation, I need antibiotic stewardship. Within 5 minutes, you will get the letter, okay, this hospital is ready for starting stewardship, okay. You will get that commitment letter, but from that point, the next thing they will tell, okay, the finance department in this hospital is not going to give you any extra fund. You can go ahead with whatever is possible. Okay, so accountability, drug expertise, tracking, reporting, all these things are to be done within the next few months. And so, first thing is to form an antibiotic stewardship committee, and always for any program, there should be a single lead. So in hospitals where ID physicians are there, they can become the lead. If ID physician is not there, because we are like a sparse population, very few ID physicians are there, So always the clinical microbiologist become the antibiotic stewardship team lead. And the first thing is the hospital should have a written antibiotic policy. And from this we move forward. There should be an infection prevention and control committee. Somebody should monitor the data on antibiotic consumption and appropriateness, and proper trainings has to be conducted. Culture of cultures, Anil sir has already spoken about this diagnostic stewardship tip, but despite this, still some labs do receive Foley's catheter tips, central line tips, urine samples from urobags, etc. So, however, as Anil sir spoke in morning, don't treat the cultures, you should treat the disease. Okay, asymptomatic culture positivities, you just ignore, except in maybe special scenarios. So, okay, so coming to our topic today, low-hanging fruits. So, low-hanging fruits are from the lab side, from the pharmacy side, and from the clinician side. From the lab side, what are the easily attainable targets? The lab report should be dispensed promptly. Critical values should be alerted. There should be cascade reporting. And for specific multi-drug resistant organism, alert should be given immediately. So what alerts should the microbiologist send? Sepsis alert, gram stain alert, identification alert, drug sensitivity alert, CRBSA alert, turnaround time. You should inform in how much time you will get the report. And for multi-drug resistant organism, infection control alert, whether contact precaution, airborne precaution, what is to be done. All these alerts can be sent by the microbiologist, and this is very simple. This happens over a WhatsApp message, over a phone. So that's a low-hanging fruit. From the pharmacy side, there are a lot of things that could be done. Surgical antibiotic prophylaxis, automatic stop orders, restrict antibiotic alert, drug interaction alert, redundancy alert, antibiotics more than 7 days, there should be a stop order, narrow the spectrum, possible IV to all such. All these alerts can be sent by the pharmacy, but how much the clinician accept this is up to the clinician. So now from the clinician side, what all things can be taken as a low-hanging fruit. For giving any antibiotic, there should be an indication. So it should be mandatory that this indication for giving the antibiotic has to be documented. Say you are having an influenza and you are giving azithromycin. That's not an indication. Okay. So whenever this writing of the indication comes, and if you have a specific form for that, if the indication is written as a viral pneumonia, the antibiotic has no role. Okay. So the first time the clinician writes, second time writes, but when he writes third time, okay, am I doing right? The clinician will just think again. Okay, they will think that I am doing something wrong, and gradually this misuse of antibiotic will stop. So it has to be documented in the case file, and every time you can go by the hospital antibiotic policy to comply with which antibiotic has to be given. This is a term that has been spoken about a lot in antibiotic stewardship, prospective audit and feedback. The term is complex, but it is just you identify which antibiotic is best and talk to the clinician, and you just see whatever changes can be made in the antibiotic and in the antibiotic that is being given. So basically that is the concept of prospective audit and feedback. So there has been concepts of retrospective audits also. So a regular rounds, if it is being done, if by an ID physician with the culture positivity report, I have been doing this with Dr. Sonia and our clinical microbiology, clinical pharmacology team at Rajagiri Hospital, maybe 3-4 years back. But it works well. Okay, once you see the reports and talk to the different clinician, most of the time they agree. It is not a very difficult task. Only thing you have to speak in a proper manner. And the ID physician takes rounds and suggests the changes, and for reserve antibiotics I will come to that part. This is a very difficult thing, formulary restriction. So whenever a clinician is, a physician is planning to prescribe meropenem, and suddenly the lab tells, okay, you need to ask a microbiologist, or you need to get an authorization from the ID physician to get this permission for using this. This does not go well with any clinician, simply because it hurts the ego somewhere. Okay. So for prescribing something, I have studied till MD or DM, and now asking somebody else whether I should give this antibiotic, that doesn't sound well. So these formulary restrictions most of the time does not work out properly. But at least for the high-end antibiotics, this can be kept. So there has been good formulary restriction. For example, this is from the Winchester Hospital. So what they have done is ceftazidime restrict. For giving ceftazidime, they have put some criteria. For ciprofloxacin, proven gram-negative infection. Meropenem, only if it is resistant to all other organisms. So these kind of written indications, if it is there, it is easier to implement formulary restriction. Reserve antibiotic policy. This is very good step for antibiotic stewardship. You chart in a list like linezolid, colistin and ceftazidime avibactam, and even if the clinician is willing to give, is planning to give, he should be given all the freedom to give the first dose or the doses for the initial 24 hours. But after 24 hours, if this medicine is to be dispensed from the pharmacy, it should require a concurrence from the ID physician or the microbiologist. So this will reduce the use of antibiotics to a large extent in most hospitals. And even computerized systems can be used for the same. Another low-hanging fruit, just avoid the redundant coverage. One very common is any pneumonia case, any hospital-acquired pneumonia, all the patients will get piperacillin tazobactam along with metronidazole, which is not needed because Piptas has an excellent anaerobic coverage. So this is one common thing. For atypical activity, many times some people do give levofloxacin along with azithromycin or levofloxacin with doxycycline for atypical pneumonia. For gram-negative, it is like an overkill. You give Piptas and you just give some amikacin or gentamicin along with it. Again, 2 gram-negative coverage is not needed. So all these kind of redundant coverage can be fine-tuned. Regarding test dose of antibiotic, this is another low-hanging fruit because a lot of our patients are being wrongly labeled as drug allergic. So you ask to give amoxicillin, they will tell, okay, I have been penicillin allergic since my childhood. If you call his mother his or her mother and ask whether what was the allergy that was documented, okay, when 5 years back, when this child took when he was 5 years, now he might be 20 or 25 years. When he was 5 years, he just vomited after taking amoxicillin, and that has been documented as allergy throughout life. And the hard part is that most of our antibiotics are beta-lactams, which we commonly use. And when some clinicians, when you tell that it is amoxicillin allergy, some people tell, okay, ceftriaxone also we will include with beta-lactam, we won't give ceftriaxone. So some people tell, okay, you give only ciprofloxacin for this patient. So these kind of stuff keeps happening nowadays. So wrongly labeling allergy is again a problem nowadays, and allergy delabeling is a low-hanging fruit. So 10% of our population are penicillin allergy, but actually only 1% is truly allergic. Now this concept of antibiotic course, okay, this has almost had its day already. Now the custom is coming that you give a very short course. The shorter is sweeter. That is a newer concept that is coming up. So the duration of therapy shorter the better, and it is not like you keep on giving antibiotic to prevent reinfection. That concept is not working out. So long courses do create resistance, and nowadays this is the stipulated criteria. For community acquired pneumonia, the dosing can be as low as 3 days. For pyelonephritis, it can be as low as 5 days. For bacterial sinusitis, lowest dose is 5 days. Osteomyelitis, minimum of 6 weeks. So these kind of minimum stipulated durations are there. So beyond that, giving, if the patient is clinically improving, giving a 7-day course or 10-day course is not justified. And shortening the course is definitely a low-hanging fruit in stewardship. So this person, Brad Spellberg, has been writing lots of literature in Twitter. He has been doing a lot of studies. So this is from his. So nowadays, this is the minimum stipulated duration of most antibiotics. So for pyelonephritis, it is only 5 to 7 days. Only places where it does not work is in implant-related infections in orthopedics. So where what they mention is you have to give antibiotics for at least 12 weeks in many cases. So the low-dose trials have not worked out well in these kind of cases. Those are exception. And all the other cases, that side, what I have mentioned on the other side, short duration, that works really well. Surgical prophylaxis is another place another low-hanging fruit, because most of the surgeons tend to continue their antibiotics for 48 hours or 5 days like that. But actually what is needed is only a single dose of preoperative antibiotic. So you lower the antibiotic doses, there is only less risk of Clostridium difficile. Cefazolin and cefuroxime are really good choices for surgical prophylaxis. There is no need to give Piptas or to give meropenem prior to any surgeries for prophylaxis. For any surgeries up to 4 hours, only a single dose of antibiotic is needed. Next low hanging fruit is IV to oral conversion. So whenever you have a good oral equivalent, an oral drug with a good bioavailability, always try to de-escalate. The only thing is the patient should be able to take orally, and he should not be having any malabsorption syndrome. These are the only criteria for this IV to oral switch. Unfortunately, we are at a problem because in India we have a lot of resistant gram-negative organism, and hardly I would say that the only oral antibiotic that is available for at least reasonable equivalence would be oral minocycline tablets. Rest of the time we are back to injections. So this is IV to oral. Nowadays it is said even in osteomyelitis, infective endocarditis, pneumonia, all these cases you can do away with. You can just escape by giving, you can treat the patient by giving oral antibiotics. So there have been quite some trials in this aspect, and almost all the trials have proven good equivalence between IV and oral. Timely de-escalation of the antibiotics. See, for the clinical scenario, use aware classification. So the lowest one, if you have an access antibiotic, just de-escalate to that. And if not, you go for a watch antibiotic, and always do the renal and hepatic dose adjustments. So aware, I guess everyone is aware about aware, access, watch and reserve category. So it is like a lot of our commonly used beta-lactam antibiotics, whatever I have highlighted are the common among the access group. So metronidazole, amoxicillin, clindamycin, all these are access group of antibiotics. Whereas our commonly used azithromycin is actually a watch group antibiotic. And most of the carbapenems, piperacillin, tazobactam, minocycline, all these are watch group antibiotics. You have quite some reserve antibiotics like linezolid, daptomycin, ceftazidime, avibactam, colistin, etc. And there are some combinations that are not recommended also. Fortunately or unfortunately, rather, a lot of these are finding places in our hospital formulary. So this should not be encouraged. Okay, so we have cefixime, ofloxacin, Ciplox TZ. All these are actually not recommended medications. So when to escalate an antibiotic, it is antibiotic stewardship does not mean that you should always cut short the antibiotic. If it is needed, you should escalate the antibiotic. So you see for the clinical response at 48 hours, if the patient is not responding, it should not work. You should escalate the antibiotic. It is not like you cut short the antibiotic but patient died. That does not sound good. Okay. So always choose the best agent based on the antibiotic susceptibility. One big question to the clinical microbiologist is whether this organism is a colonizer or whether it is a pathogen. Neither the clinician nor the microbiologist will be able to tell that with 100% surety. It entirely depends upon the clinical picture and what organism you have isolated. So if the clinical picture is consistent, you treat, otherwise you label it as a colonizer. Always, I would say that this has already been practiced by most microbiologists. They report the intrinsic resistance, but however, some simpler practice for those for the antibiotic stewards are. For Pseudomonas, you think that ceftriaxone is intrinsically resistant. For Burkholderia, colistin is intrinsically resistant. At least these few catch points should go to the clinician so that they don't give this antibiotic when these particular bacteria are isolated. This is one concept in for the pharmacist and the nurses, that is batch dosing of costly antibiotics. So if a costly antibiotic is being prescribed, it is like if there are 5 patients in the ward who is getting caspofungin, it is better to dose everyone together. Okay, so that because as this problem especially comes with pediatric patients where they need low dose. It is supposed that all this costly antibiotic, you are not supposed to keep this antibiotic in the fridge, keep reusing that. Okay. So one time the vial is opened, it is best that the vial is completed in one go. Okay. So that is batch dosing of antibiotic, which avoids drug wastage. Antibiotic timeouts, these kind of concepts are already there where in places where stewardship is being employed. So after 5 days, the antibiotic will be automatically stopped by the as an order when if it is digitalized. So and there are provisions for reviewing whether the antibiotic you are giving is correct every 48 hours. Reminders can be sent to the clinician whether the antibiotic is proper. So all these are low-hanging fruits. So now, previously all these were based on accreditation. So most of these things were only for the private hospital. But now Kerala government has come up in a big way. Dr. Hira and all has been working on it day in and day out. So they have come up with the state level antibiogram by the CASNET. They have Karsa program, antibiotic literacy Kerala campaign, which is avoiding antibiotic free and which is creating antibiotic free food and water, avoiding this in veterinary, that is Operation Vet Biotic, antibiotic smart hospital initiative. So a lot of initiatives are coming up from government side, and hopefully from a governmental side also the antibiotic stewardship will be taken up will be ensured in most hospitals. So the pillars of antibiotic stewardship include prevention of infection, access to health services, timely accurate diagnosis, and appropriate quality assured treatment. So this is the criteria for antibiotic smart hospital. This has been published by members, people from Trivandrum Medical College, including Dr. Hira and Dr. Aravind. So they have put up the guidelines for primary level care, secondary level and tertiary level, and which can be easily practiced. So the basic level activities that could be done as low hanging fruits are a single person, in one hospital only one person. It is not like too many cooks spoil the broth. So only one person should be the lead antibiotic steward, and antibiotic awareness campaigns can be conducted. There should be facility level drug formulary, evidence based treatment guideline, and regarding the guideline there should be adequate training. So to wind up, this is the chart that is been devised by Trivandrum Medical College regarding antibiotic stewardship, how utilizing most of the low hanging fruit. So if you can see the first one, they have written the indication, they have written the dose, duration, date of start, and tentative stop date also. Whenever you start an antibiotic, you just mention the stop date also, okay, so that it can be stopped, and if you want to review, you can have a review and continue the antibiotic. And whether it can be stopped, whether the IV can be switched to oral, whether there is a possibility of substitution of the antibiotic, switch from reserve to a watch category drug. All these have been mentioned in the flow in this form, and the government is ensuring that more hospitals are following this kind of chart so that antibiotic stewardship is ensured. Thank you. The task is quite difficult like this, but if you follow the low hanging fruits, at least you can work up in some way. Okay, thank you.
Any questions from the audience? So maybe I'll ask. Okay, sir, according to you, in a government setup, what stands between us and these long-hanging fruits?
Okay, so for the low-hanging fruit, one is the staff pattern is always a problem. The staff would be less. So even now, it is like clinical pharmacologists are an extinct community in governmental setup. Okay, we are, it is not there. So we don't have clinical pharmacists to collect the data. Antibiotic stewardship is all about data. Okay, you first need the data, as sir has been showing from JIPMER. The first thing is data, and from data you build on. Okay, but for collecting data, it is not like the existing people are not sufficient. So that's a big roadblock. And many times there is a deep-rooted notions from some clinician. Okay, this antibiotic only works well. So when we start an initiative, it is difficult. But what I feel is when you keep these kind of charts, like for giving antibiotic, So once these charts come up, and when there are, so in governmental setting, the biggest problem is you can put in a chart always. Who fills the chart is a problem. Okay, only if there is a house surgeon or there is a postgraduate student or maybe some assistant professor, these are the people who will fill the chart. Okay, there will be 100 patients and there will be only one person to fill the chart, and this person has to write treatment orders also. So these kind of roadblocks do happen, but at least with the kind of efforts that has been coming, I think, I feel for time being it is really prospective.
Okay, thank you. Now, sir had already spoken about Dr. Brad Spellberg. He is actually an international person who is working on antimicrobial stewardship. So he is himself a clinician, and I would like to borrow his words. Antibiotics are very potent psychoactive drugs. Okay, they are very good anxiolytics because they act on the prescriber than on the patient. So basically, antibiotics are like anxiolytic drugs for the prescriber. And when we are dependent on an anxiolytic drug, we often become dependent on it. So it is like we are up against addictive persons, like they are having an addiction towards antibiotics, and we are dealing with the de-addiction process. So they will scream, they will fight, they will mock us in public. All sorts of such activities will go on, but you should not leave the rope, because the burden of AMR is too high and it will fall on our future and our future generations. Thank you.
Thank you, Dr. Netto, for that excellent, insightful presentation, clearly reminding us that AMS doesn't require any grand intervention, but just timely, practical action and consistent efforts. But still, though we are saying it's a low-hanging fruit, the resources might be low, the budget also might be low, but the effort from us, the microbiologist and the ID physician, is always on the higher side, because we always need to be proactive and we need to be persistent and also prompt in our responses. Prompt means at times we need to give daily reminders to actually improve the system. So low-hanging fruit, probably budget-wise, but quite high for us effort-wise. Thank you.
Thank you, everyone. May followed by Dr. Hira Hassan ma'am.
We now have the general
Directly incorporating the bylaws of the Kerala chapter as an annexure to serve as a model or SOP for new chapters. The discussion on the current status of the Tamil Nadu chapter, a proposal for conducting frequent online meetings to discuss association activities, and presentation of audit report by treasurer. On behalf of treasurer, I will read that. Then any other matter from the members. So now I will read the auditing of the current assets. So we are having the balance of from SBA. We are having the account in the SBA. So now we have SBA total amount asset is current asset is 2,91,004.47 paisa. So the fixed deposit we are having 1,90,500, and another fixed deposit 2,05,284, and another fixed deposit of SBA 2,05,284. So totally we have 8,92,072.47. So this is the total amount we are having after the expenditure of various activities. So now I will hand over the mic to Madam. Next agenda, I have a mic.
as a...
So we had proposed by email to hold the next triennial conference at Hyderabad. The main purpose being twofold. First thing is so that, you know, every time it's not a meeting in Kerala. That's one. I have nothing against coming to Kerala. I'm a proper Palakkad here, so I'm fine with coming to Kerala. But then I think the ACM needs to go out of the state, and it should have increased visibility, enhanced visibility in other states as well. Then only it becomes a proper national body. It will grow as a national body with all its aims and objectives. So with this, I thought holding, if we hold the triennial conference in 2026, sometime in August or September in Hyderabad, we could also look at the possibility of forming a Telangana Andhra Pradesh combined state chapter for the ACM. Just as we have a TAPC of the IAMM, we could also have a TAPC chapter of the ACM. And once in a while, we could definitely have a CME and some online discussions as well. So with this in mind, I had emailed, and Dr. Rakesh Sehgal has agreed. And I think in principle, he has also phoned Dr. Mangedkarsi, though sir has not been able to come to this meeting for personal reasons. But she's also confirmed that there was a phone call, and he's agreed to this. So very soon, within about 15 days or so, we'll fix up the dates, because there are some festivals which come up in August, and we also Onam is one. Yes, Onam is one. I was also thinking of, you know, certain things like Nariyal Purnima. There is Varalakshmi Vridam, which we do, and then there are some others like Janmashtami. There is a Ganpati festival that comes up at that time. So, and then you also have to look at parallel things that happen, like SITSCON, for instance. Everybody goes for SITSCON. So, now, let's not try and clash the dates, so that everybody will be able to attend everything. That's the thing. So, we'll just try and look at the calendar and fix up a date and get back to Madam, and then they will put it up on the ACM website.
Thank you very much, sir. Thank you. Let me just put on record I'm very thankful to him. So the next conference is fixed.
Welcome everyone.
Next Tricon, fixed in Hyderabad.
So all of you are welcome to Hyderabad, and we look forward to seeing all of you in large numbers. And please come up with your papers and presentations and everything. Do you want me to finish with the journal also at the same time? Yes. Okay. Reading up about the journal? Yeah. So that it's all done in one go. Okay, now about the Journal of the Academy of Clinical Microbiologists. The last two issues of the journal has been fairly good, with a good amount of submissions, particularly this year. It's much better than the year before last. Last year also was very good. And the January to June issue had 8 articles published, consisting of 1 review article, 3 original articles, 1 brief research communication, and 2 case reports. So that made it 8. And the December issue, which is coming in now, that has about 7 manuscripts that are accepted. There is 1 drug review which is accepted. There is 1 special article which anyway is a part of the ACM. We always have a special article published in the JACM. So that's coming up in the December issue because it got late for the June issue. 1 review article, 1 original article, and 3 case reports. Now, we do get a lot of case reports, but then my sincere request to everyone is, in fact, I went and clicked some photographs of the case reports which are presented over there as posters during tea time, and I'm planning to write to them, requesting them to convert all those things as manuscripts and submit it to the JACM. But in addition to that, it would really be wonderful if we could have original articles, if somebody could also write systematic reviews or meta-analysis, because we are desperately trying to get this journal indexed. And it's like a vicious circle. Because your journal is not indexed, people don't submit manuscripts because they need it in indexed journals to get promotions. And because those manuscripts don't come, the journal doesn't get indexed. So there's a lot of, it's something like a cat and a mouse game, and we need to break this cat and a mouse game at some point or the other. So it is up to everyone. It's everyone's contribution that we look forward to. I've also been contacting some of my other friends who may not be members of the ACM, that's fine. But then when we when we send manuscripts to the journal, please remember at least one person out of the entire co-author crowd should be an ACM member, and at least one of the authors must be a medical microbiologist, an MD microbiologist. We prefer more and more MD and DNB microbiology people submitting articles to this thing.
So you mean that at least one person should be member, or at least an MD person in microbiology?
No, one person should be a member because that is what was the take right from the beginning. But we are sort of relaxing it.
Then that person will be MD automatically.
Yeah, automatically that person will be an MD microbiology. Recently, why I'm saying this is recently we've been getting some 2-3 manuscripts which we have had to turn down, from botany colleges and zoology colleges and biotechnology colleges. Manuscripts are good. They are all on PCR and gene sequencing and all that. It looks wonderful. And then when you click on authors affiliated, it's all from Arts and Science College. So it's a little difficult to accept those because it doesn't, the journal is very strict. It will take in only clinical microbiology subjects. So then there are some who take out some plant extract and put it into uropathogenic E. coli and things like that. It's very difficult to accept those kind of things, plant juices and animal juices and things like that. So please, we can't be accepting those. So this is as far as the journal. Please contribute manuscripts in large numbers. Please contribute manuscripts.
Recently, I have seen that national and international forums, they are asking for the publications under associations. So this will be definitely useful for you for your future careers.
Yes.
I think as a ACM member, your first duty should be to your own association. It all rest come later only. So let us together, let it be a concerted effort to get it indexed. So if we can get maximum number of manuscripts in this 1 or 2 year period, we will give it for indexing, and once it's indexed, we can, we have a additional journal in India. Now we have only IAMM, which is a microbiology journal. Otherwise we have to depend on other journals, like I think there are some like critical care medicine and surgery and other kinds of journals we have to depend. Only 2 are there and only one of that is indexed. So let us make it a concerted effort. Whenever you get a good case or you think a few cases, see last 1 year I have got so many cases of meningitis. So do some analysis on that and then you can just give it. Take care of your promotions. Don't forget your promotions. But after that, I am sure that you can make at least, especially all the medical colleges with more than 1,000 beds and all, no, you will surely have so many cases in your case records and all that, and you can easily make articles just for giving to JACM. For that you write articles. You decide that I am a member and I have to get it indexed. And start writing one article from one person, one member will make it indexed in no time. Because there are 400 members.
If you have data on 4 topics, 3 can be obtained. You use 3 data topics for your promotions and other things. But then at least 1 can be reserved for this.
Should be a real effort from your side. Otherwise it will not happen. We need the cooperation from each and every member.
And it's not just medical colleges, even privates, everybody can contribute, please.
Corporate hospitals, I think they have the best chance of doing it.
Everything is wonderful. There's no problem.
Election, I'll just tell you how it is held. That is, there are some posts like president post. So the next vice president will automatically become president. So there's no need of election for that post. However, there are two vice presidents, and when one vice president becomes president, one post for vice president will become vacant. So we have to hold election for that post. Now that person will become president after 6 years only. 3 plus 3, 6 years. So 3 years is the period for the post. So if you are a middle level person, after 6 years you can be president of ACM if you become vice president now. So you can apply for that post, and if there are more than one person, then we'll have to have a proper election. If there's only one person, that person automatically becomes vice president. Just like that for secretary. Now Elathamalin is joint secretary, so you will automatically become secretary unless you say that you are not willing to be. Of course, you can say that if you're under pressure doing a lot of jobs and you say that you don't want to be, of course that is accepted. Then you will need an election for the secretary post also. Just like that, for joint secretary post, there will be election. Like that, for editor, associate editors, and all that, there will be, all these posts will be open for election, and this will be sent, I think maybe next year by February, March, we can start the process. So we will be sending a notification to everyone, and you can opt or you can volunteer to become any one of these posts, and you can send back. There will be a form and you can just fill it, and if we can upload it online and all, we can make some arrangement like that. That will be easier. So we'll have to work with our website people, and if we can upload it, so that process will start now. So that is about the election.
So the next is the chapters, madam. So recently we discussed about opening of the Tamil Nadu chapter along with the Pondicherry, but better we will do it separately also, madam. Tamil Nadu chapter and another one is the Pondicherry chapter, Puducherry chapter. That is actually we will decide after being, by the time we will do all the activities and we will have the members and we will announce. So first is the Kerala chapter, the next subsequently all.
So your SOP is there, because we already, Satyajit has made a beautiful bylaws are there. So from that you can start. He can send it to you, and you can get people from there to Dr. Jayalakshmi madam also. What is your input on that?
So,
madam is very busy. I'm very sorry, but
so
you have some students and all, no? You get them to start.
So, thank you very much for saying that I'm very busy. No, I amn't. So, so for the PG program we initiated, but in my institution we have to go through a lot of signatures. The process is long, but once it is finalized, it's through. But when it was almost getting done, then there was a delay. Then ma'am said, can we ask somebody else to do? So there was a small gap. So probably by December we will schedule out, we will send it out. By Jan, I think Jan, Feb, March, 3 months we can have every alternate weeks we will have PG discussion programs for 1 hour, 1.5 hours, which has been approved by my institution for conducting, because we need to get an approval because I work elsewhere, and though it is beyond the working hours, but I still need to. So that will be done. So if there are any specific topics that the PGs would want or interested, you might even send it to me, individually. I can share my number. So we will organize in such a way that the PGs who finish should be ready to practice. Either they are in teaching institution to start to teach medical students clinical microbiology, or work in corporate hospitals to start to do clinical microbiology practice and start to be part of the clinical rounds and things like that. They cannot be sitting at the desk and stay comfortable that I took this job for timeline or times based, etc. So also they need to know a little bit of quality. They need to know that whether they are going to be working in an institution which is already accredited, or they should be helping an organization to get accredited. NMC is now mandating every medical college to be accredited by NABH and NABL. So it is important that every PG student who walks out of our campuses are fully ready to be out. They can be trained further in whatever they would want, but when they leave, there should be some set standards. I think we should do that. So please share your topic thoughts and then send it across. Whatever we can organize towards, as a group or a coordinate, we can do that. Either for that 1 day or 1 month, we could focus it on specifics so that they learn good microbiology, which is important. No, send topics also, we will identify. Yeah. We can identify speakers, could be anybody from the country and abroad. Send topics, whatever you think the postgraduates needs to know. We also have a list of topics. We will take everybody's input, okay, so that it is beneficial for everybody. And it has to be relevant for a postgraduate who walks out of our campuses. That's a concern. Because I do have now an SR who's from a very reputed medical college, but has no clue of anything. So it's very sad. You know, we think that this is from a medical college, very reputed. I'm not even talking about central institutes which does not have certain requirements for us. You know, the NABL, NABH is not a mandate for central institute. I'm not even talking about quality or NABH, NABL standards, nothing. I'm just talking about the basic interpretation, clinical interpretation, you know, speaking to the clinicians appropriately, you know, timely report, escalating higher up, speaking to them about the antibiotics, nothing, you know. It's not there. So I think we should equip them with that.
Thank you, madam. Actually, this is coming under academic activities under ACM. So already you all know that we have conducted under PG Chandigarh and Tamil Nadu also conducted. So even the private colleges and the institution can participate. If the member are there, you can initiate these academic initiatives. You can also participate. We are distributing the certificates to the speakers and also to the participants. So you can also initiate. If you want to share about the details, we will share. The private practitioners or the private institutions also can participate in this academic activity.
And anybody who wants to speak also can give their names. Anybody who is willing to give their, you know, names for specific topics, definitely most welcome. Right? It's by us for our own future generation of students. So I think there is nothing like, okay, we only these people have to do. Of course, there are a lot in the country and lot within our spaces that we know. We could use all of them. Yeah.
It is already we discussed about the CME and all. So now we will close the
What I said in my speech, I think that we have to give to the Kerala chapter. About the case discussions, yeah, monthly case discussions, Dr. Satyajit, about the monthly case discussions, that also I think we will put in the minutes that we will have monthly case discussions. Anybody who wants to present any case, they can just present and whoever is there will talk about it and we will discuss about it. So it is not that nobody will turn up or this person has to come or that person has to come. Whoever finds time at that point of time, just join. So every month maybe you fix a date, 20th of every month or something like that. This will be on, just give the link. Whoever is organizing just has to give the link and get people to participate. Just see how many will participate. So I think a core group has to be made who will do this work. So they will be, all the case, those who are going to present will give the names to that core group and they will arrange the link and they will there's nothing much to do. So you just remain as a core group. You will get from everyone that yes, I am presenting one case, I am presenting. If nobody is presenting, you send a circular to everyone. Please give the names who is there. To the HODs you can send, or some prominent people you know you can send. And then you get the names and you just conduct it. So monthly if we can just get together and let it be a part of the ACM activity. So this will be there throughout the year. So if we can do that, if you can get some core group to do that, we can start.
Thank you so much. I ask the Joint Secretary to give the vote of thanks.
Yeah. So the other thing which we thought we would begin now is form small working groups in various fields of clinical microbiology. So I just thought, I said that I would take the onus and start off pediatric infections. Since I work in a hospital group which is largely with obs-gynec and pediatrics, so probably either obstetric infections or pediatric infections, because pediatric infections is too huge. It's almost like internal medicine infections. So maybe we could start with something like obstetric infections. That is unusual, nobody really works on those. And then slowly we could move on to neonatal, to pediatric nephrology, pediatric cardiology. We have all of that. So we could form these small concentrated working groups and then present those at the CME programs, or present those list of cases, how many cases have happened. You could even get publications out of those. It becomes useful as case reports. And we could slowly form consensus documents. We could slowly form guideline documents where you have so many of one particular type. Then that we could form something like a guidance for members who are faced with a similar problem in the group. This is the idea of forming those working groups, essentially. Yeah, we would try and make an obstetric infections group within the next 2 to 3 months. That is possible. And then we will circulate it to all the office bearers, and from there it will come to all the members. Yeah, there's a lot. PAM is something which quite prevalent over here. Yeah, I see even a lot of dirophilariasis being reported. There were at least about 4 posters out of the entire lot. So I thought of obstetric infections, which will include everything.
Have other like respiratory
Yeah.
infections like that we can make.
We can make smaller groups. Right. Vote of thanks.
Good afternoon to all. I thank our President Kavita Raja ma'am, Secretary Mangai Kasi ma'am, Vice President Jayalakshmi ma'am, and our internship Anand sir for kindly presiding over this meeting. I thank President and Secretary of the Kerala chapter of ACM who kindly made all the arrangements for this meeting, and I thank all the members. Despite their lunchtime, they are very patiently waiting and listening to the meeting. Thank you.
Resistance of antibiotic is also high in our countries. So we are at a major risk of death due to AMR, or antimicrobial resistant organism, causing infections in all of us. So what if you cannot have antibiotics? Why don't we prepare more antibiotics? No new antibiotics are in the market, not anymore in the pipeline, because whatever comes in a decade or two, they are lost because of various factors. So none of these antibiotics that's in the market would be available for a long period of time or forever. So you lose them to the resistant mechanism. So no new drugs, and bugs are all becoming more resistant. So there is nothing except what we can do with what's in our hands. So we have this in our arsenal, which is the antimicrobial stewardship program. When you say a stewardship program, steward is somebody who takes care. Okay, so this is a coordinated program that promotes appropriate use of antimicrobials. It's not looking about the antibiotics, it's looking at antimicrobials, includes antifungal, antiviral, antiparasitic drugs, improve the patient outcomes, reduce microbial resistance, decrease spread of infection caused by these organisms. So this is a collective effort, and it's found that this is one of the best tool to reduce antimicrobial resistance globally. Okay, so this has been there for years now and more popular now, and it has been mandated in most institutions and healthcare facility, whether you are part of an accrediting body or if you are part of a teaching institution or an academic institution. It has been mandated as a part of instituting good practices in all healthcare facilities. So what is the goal of these antimicrobial stewardship program? It needs to work with the healthcare practitioners to prescribe the 5 Ds of antimicrobial therapy, which is the right diagnosis made and the right drug prescribed, which is a narrow spectrum of antibiotic chosen, in the right dose appropriate to the weight of the patient, to the clinical condition of the patient, to the duration that is recommended for it, not beyond 24 hours for certain, not beyond a week or three days for certain patients, and de-escalate whenever you have an evidence that an antibiotic which is much lesser in its group is susceptible and can be easily given to a patient orally rather than keeping the patient for longer with an IV or an injectable antibiotic. Now the program looks at preventing antimicrobial overuse, misuse and abuse, both in patients, in the wards or in the community or in the OPDs. And also it looks at those in the agricultural industry. Why are we worried about those in the agricultural industry? More than 70% of what is prepared or what is produced is being used amongst animal feeds. So you are having antibiotics prepared in larger quantities used for other fields or other sectors. So you need to have a collective effort in handling this. You need to reduce antibiotic related adverse effects. It could be focused at looking at some of them outgrowing when they are intrinsically resistant as well, to minimize the resistance, because you don't want one drug to be continuously used for a long time and lose its susceptibility, and also reduce the healthcare cost, because if patients get infected in a healthcare system with a drug resistant organism, if there are not good infection prevention practices, then they are going to be infected for long, taking antibiotics for long, for which they would have been tested for long, and they stay in the hospital setting for long, and there is an additional cost of paying for the consultants as well as the nursing care. So all of these can add cost to the patient. So it's important to focus on the type of antibiotics being prescribed also. This is the WHO's aware group of antibiotics: access, watch and reserve. Access are those which are easily available to use and prescribe, less known to be resistant. The other is a watch group, more prone for resistance and need to be used at a lower levels. The reserve is a high-end antibiotics when none work. Ideally, our access group should be more than 60% of prescription. More than 60% of our prescription should be access group of antibiotics, but studies across the country shows more than 50 to 60% of antibiotics being prescribed in the watch rather than the access. But we stand in a state where it's being brought down, so there is more access prescribed currently in Kerala than other states in the country. So you look at the implementation strategies for antimicrobial stewardship. There are primary and secondary strategies. The primary strategies try to look at two important aspects. One is upfront looking at pre-authorization and formulary restriction. So you make a list of formulary. All your high-end or restricted antibiotics are not made freely available for everybody's prescription. Only those who can approve it will be allowed to prescribe such an antibiotic, or those who prescribe has to get an approval within 24 to 48 hours depending on the drug and the process in the institution. Then is your back-end strategy, where you do an auditing on the type of antibiotic used for the various clinical conditions and give them as a feedback to the person concerned. So auditing and feedback is a back-end approach. So the first front-end approach is pre-authorization and restriction. The back-end approach is giving a auditing and feedback, and you also look at the IV to oral switch as early as possible, sending antibiotic, starting an antibiotic only after you send a sample for culture. So there should be this culture of starting or sending a sample for culture, which should be there in the system, and there should be a review of the therapy that's happening, ideally in a form called as an antibiotic form, which should be in the case file of patients, which is easy to review. But there is this integrated stewardship approach which kind of looks at three things. One is your antimicrobial stewardship program, what we've been speaking about. The other is a diagnostic stewardship program where you're choosing to see what is the right diagnostic that you would do for the right clinical condition of a patient at the right time. And also we call this as an integrated stewardship program, which includes also effective infection control practices. So in the diagnostic stewardship program, you will see at the end of your slide here. So you see the diagnostic stewardship where you have the right test done on a right patient at the right time. Where in antimicrobial stewardship, you are doing a right interpretation for the clinical condition, choosing the right antibiotic and starting them at the right time, which is the key thing. However, in the diagnostic stewardship, what is important is looking at what is you're looking at the diagnostic tool or a test that need to be done, which needs to be as appropriate and as rapid as it should be, And based on the diagnosis and therapy, you start on a patient and you look at what is the best way to handle these patients with the antibiotic. Now, if you would look at these clinical testing decision and interpretation chart here, you need to look at each test, pre-test probability based on the prevalence of these infections in the system. So it's important for each of our clinicians or clinical microbiologists to know what is the pre-test probability for this particular test estimation that you do. Then before, you have to inform about the test performance character, what is the sensitivity and susceptibility for these particular tests. And there should be a specific test ordering form where you list the indications or decision support for testing. Then also give some positive nudges or encouragements on where some things can be modified. Frame the results appropriately so that it gives a clinical judgment for the patient to do, for the clinician to make out of it, and reduce or ease the access to test in the electronic health record becomes easy for somebody. They don't have to wait for a hard copy to reach anybody. It's immediately available in a electronic health record form, and recommending expert consultations or giving expert opinion or comments and interpretations are key for any of the tests that is ordered. Specimen collection should be done appropriately, transported appropriately. It should be it should be an acceptable sample. So there should be a defined criteria for accepting and rejecting sample, and optimize the transportation time and the way it has to be transported to the laboratory. And when tests are performed, there should be tests done in a sequence, also reflex testing. For example, if you're doing a gene expert and you find to be positive for TB and your RIF is susceptible, okay, it's not resistant, still you would want to give a reflex testing for other drugs, antitubercular drugs, because it is not a must that rifampicin resistant always is INH resistant also. So you may have those susceptible still being resistant for INH alone or the other drugs. So you need to do some reflex testing. That's one of the examples. And when you do a test reporting, you need to give decision support for interpretation, then also positive nudges for adding more tests or asking them for more tests, etc. Frame the result, and you have to do selective reporting. Don't report every antibiotic that you are seeing susceptible, because it tempts the clinician to start antibiotics that may not be really required. So it is important that you choose the right ones. This is looking at a framework where what are the different types of stakeholders who may be involved in here. This is called as the 5P framework for optimizing antimicrobial decision making. This is only about decision making. So you have a program support, then you have the preserve, then you have the practical, and then population health and precision. So you have the clinician at the center. So you have in the program support, you will see enhanced antibiotic use and reduced duration of both overall and broad spectrum antibiotic, because any antimicrobial stewardship program is focusing and bringing to a narrow spectrum antibiotic usage. Okay, so it has to be close to that. Better diagnosis and reduction in onward transmission of infectious diseases. It's important to identify infectious diseases at the earliest, because you just don't want to just treat them, but also you need to isolate them so that it doesn't spread to the others. Improve clinical outcomes, including mortality and reduce hospital length of stay. Because if you identify earlier, you start therapy earlier, if you approximate the antibiotic well, then the patient outcomes are better, so they do not need to stay in the hospital for longer. So it reduces the length of stay as well as the cost of care in these patients. So this is how the last one, which is the economic efficiencies, increase cost effectiveness, choosing the right test, and then reduce hospital cost. So it's important to choose the right test, and you always need to do risk benefit analysis to see if this is so very expensive, what is the benefit out of that I would get. If the benefit outweighs the cost, I think it is always worthwhile to look for it. So this is the IDSA giving the antimicrobial stewardship program in 2016. In 2016, in one of the documents here, it would say in one of this evidence summary that it mentions, the use of rapid molecular molecular assays and mass spectrometry to identify bacterial species, and susceptibility in blood cultures has been associated with statistical significant improvement in time to initiation of appropriate antibiotic therapy, rates of recurrent infection, mortality, length of stay, and hospital stays. This is something identified in 2016 that molecular tests will be very, very useful to stay. But in that particular document, it does not say as the most important recommendation at all. It is in the least of its order of its recommendation. However, with years of progress and with technology being available to many people now, it is definitely worthwhile to use these for testing. So there are more studies. This is a 2024 study on blood cultures where it looks at using molecular methods in this meta-analysis study and find it to be more useful. Now, why molecular approach? Why not do just the routine microbiology and be very happy about whatever antimicrobial stewardship program that we do? Remember, these molecular tests can identify organism of interest. Unsuspected, unheard, fastidious organism also get detected. Sometimes these organisms, these fastidious organisms go undiagnosed or underdiagnosed because we never thought of it and we never thought we could look for it also. There may be co-infections which we missed out on a routine. So when you treat one infection, the other might kill a patient or deteriorate the patient. And clinical decisions are useful whenever you're trying to look at certain gene resistant type. Okay, OXA48 type, CTXM resistance that you see. Okay, so you are looking for specific gene types, and these gene types need specific antibiotic therapy. So your gene identification also helps in choosing. So therefore, you are going to help a clinician in the decision making. So reducing antimicrobial resistance looks at multiple things. Detection is one of them, and surveillance is the other. In surveillance, when you start to look for, sometimes you see there is a change in the trend. The genotypes have changed, the variants have changed. So all of these will help us to predict the infections in the future, or tell the number of organisms that may be positive in the future as well. So this way, this molecular approach definitely helps. Now, what are the different types of molecular testings that are available for routine antimicrobial resistance, which may be used for antimicrobial stewardship program? I'm not looking at everything. There are so much more. I'm just going to broadly classify based on some articles that I have reviewed. One is our JCM 2024 document on implementing molecular infectious disease diagnosis, building a diagnostic stewardship program here. And the other is rapid diagnostic test and use of in antimicrobial stewardship itself as a meta-analysis. So one is very popular, the syndromic multiplex PCR panel, where it can look for bacteria, viral, fungal, protozoa. Patient with meningitis, encephalitis, take the CSF, send it sample. Whatever is positive will be available for you to report in 1 to 2 hours. So it's very, very easy. It can stop antibiotics when you know the condition is viral. The second is a bloodstream rapid molecular, where you look for the ID. It will tell you this is Klebsiella pneumoniae, susceptible or resistant also. Tells the type of gene that is resistant. The KPC, NDMs are all, or the OXA types are identified. So if it's a Staph aureus, it identifies MEK-A or not. So it kind of helps you to identify, and this is useful for antimicrobial stewardship for a targeted therapy. You can stop certain antibiotic because such a resistant gene is not there. The other is your point of care antigen testing based on molecular test, of course, where you have multiplex respiratory panels available, or some of these tests which are available even in 2 minutes to 15 minutes. There are some tests which can give you positivity for certain viral infections. I think COVID is something that taught us a lot. And I had the privilege of seeing the technology over months, because I used to do the assessments for few labs, and from the initial time of my assessment during COVID time to the time that I closed my assessment for COVID, I had seen the technology grow leaps and bounds week after week. From a test that used to go for 4 hours to 6 hours, When the time I would almost the end of COVID, we had tests which used to go in 2 minutes if it's positive, 10 to 15 minutes if it is negative. So that's the technology that we are seeing, and it's so easy, and it's a point of care test available at a doctor's clinic where you just have to add the sample and then look for these tests. And this is very, very useful for and prevent inappropriate prescribing for these patients. Okay. Of course, the other would be the whole genome sequencing. So would it be generally used for antimicrobial stewardship? No, it's not as such you are going to use an antimicrobial stewardship program with NGS, but NGS can help in the program. So that's the thing. You are not going to say, my hospital, I want to have an AMS program and I need NGS. No, I have an NGS and I'm going to use my NGS and use it for the benefit where I club it with my AMS for better output. So increasing valuable for complex infections. It's more useful for outbreak infections. When you collect multiple samples from different areas in an ICU, for example, a neonatal ICU, you have samples collected and you find they are similar, then it is easy for you to make a treatment diagnosis and isolations, protocols, etc. Similarly, when you see them totally different, it gives you absolute clue that you are looking at something different and you start to address. So your approach to itself will change. Just because you see a clustering of organism does not mean it's always an outbreak, and that would be very, very useful for us to do. However, it is more for research or reference centers or in very specific clinical scenarios where you would want to prove or disprove. This, of course, is a standard microbiological laboratory workflow that we look at here. Of course, this is not always seen in every lab, but this is what you will see where you have, suppose you have a blood culture turned positive. Immediately what you do is when it flags positive, you do a gram stain, you look for the organism, and then you also do a culture, then identify the organism and do a susceptibility. So you have 4 days at least for you to report a sample. Just imagine if you did have a molecular diagnostic workflow, then when it flags positive, immediately you put the sample into a molecular panel for detection. If you did have a specific blood culture ID, panel, and you will find them to be positive, then you can start to treat. So this is within the 1 and 2 days you will get your report, and if you also have some specifics to look for resistance, it adds value to this. So it's a very, very useful thing, and this is one of the studies that have shown here. Okay, because we know in sepsis we need to start antibiotic as early as an hour, because every time lost is tissue lost as well. So here you will see that on a routine, what it takes to that of when it is passed through a molecular pathway, a standard testing process takes about minimum of 3 days for it to report. However, your molecular methods would take much lesser, so the time taken is different, and therefore so much of tissue is preserved in this patient, and that's very, very important in a patient with sepsis. Same here with the meningitis. When you have tested, you have multiple methods of doing, diagnosing meningitis, whether depending on what lab are we working at and what facilities we are supported with. There are laboratories we can take a sample and within minutes, or sorry, not minutes, in an hour or 2 can tell you the organism specific. So I was just speaking to one of the experts in one lab recently, and he said, "Madam, we did have a chikungunya in the CSF, and it is very rare, and people didn't want to believe it, and we had to collect the sample again to prove it again. But we give it in 1 to 2 hours time." So that's the technology some of them are blessed with. I think that's useful, and thanks to such a technology, and that's so useful for a patient where his treatment gets benefited by that diagnosis. So if you have identified, you're looking at an organism and you're focused on certain things, because we are always looking at a gram stain, Ziehl-Neelsen stain, and negative stain for India ink, but we are not able to identify the viruses by this. So what are we stop there. Okay, this is not possible beyond us at a routine lab, a molecular test. So prioritizing certain specimens and infections to certain techniques is worth its effort. Okay. So where would you see further? Okay, so if you see a respiratory panel, particularly in the critical care units, it's documented, it's a consensus opinion that they have given that it's required for them to do a respiratory viral PCR panel, and if you have them positive for any one of these viral panels and negative for a bacteria, there is no need for an antibiotic that needs to be given, and you probably need to give an antiviral depending on the clinical condition of the patient. Similarly, when you have a blood culture positive and you have a blood KPC or a carbapenemase gene positive, then again you need to escalate it for a CRE, infection control practices, etc., contact precautions that you would give. So this is very, very specific again. Suppose you do a urine PCR for an E. coli with CTXM, ESBL gene seen, and the patient is on a ceftriaxone as an empirical therapy as per the hospital's policy. This is not going to work, so it is useful to switch from ceftriaxone to ertapenem in this particular patient population. Staph aureus identified with from blood cultures. If you see the molecular IDs, before you have your ASTs here, then you may be able to switch from vancomycin to a simpler susceptible for a methicillin susceptible Staphylococcus aureus, because it's a MEC-A negative. So this molecular test definitely helps in stopping antibiotics. Okay, a multiplex GI PCR when done, and you look for, because they also look for the toxins. C. difficile toxin ABC is looked along with the other GI parameters or pathogens. So very rarely you will see a norovirus where you need to have an infection control practices in place. So because most often we think it is a C. difficile patient in the ICU was on an antibiotic, so you think, oh, he has a C. difficile infection. However, may be negative for a C. difficile and he's positive for something else. So important is stop the fluoroquinolone and start to have infection prevention practices specific to a noroviral infections. So that's important. This is next-gen sequencing. Okay, I'm not going to teach you or tell you about what is next-gen sequencing. That's a process where you break the target DNA and then the nucleic acid is extracted, the sequencing is done, and you use bioinformatic analysis for analyzing the gene. So you do a whole gene sequencing from the pure isolate from organism grown, or you can also do from the clinical samples directly. You can do what is called as metagenomic sequencing. That is, you don't have to isolate from the specimen, you just look directly. It has a lot of benefits. One, it has a high resolution pathogen identification, identify organisms very well. It detects the genes and the mutations that's very unique for it. It looks at clonal and transmission analysis specific to that particular type of organism. It does the epidemiological mapping of the antimicrobial spread and also predicts future resistant trends also. So all of these are possible with your the next-gen sequencing. So where do we apply next-gen sequencing in AMS? So one, whenever you have a culture negative endocarditis, you know there is an organism but you don't know what that is. So you can have metagenomic NGS in such patients. Probably these are studies which I have just taken these from studies which has proved NGS proved identification where antibiotic got approximated based on the results. Okay, so this is an ICU ESBL Klebsiella outbreak. Okay, they were totally unrelated when they did a whole genome sequencing. So we didn't have to do anything. You didn't have to start on a carbapenem here. Okay, rapid detection of bedaquiline resistance in MDR TB. Okay, and then plasma metagenomic NGS while identifying cytomegalovirus viremia, particularly in patients who are immunocompromised or those who are transplant recipients, where you didn't have to continue any antibiotic in these patients. All they needed was a specific antiviral. Then also is the WGS guided therapy for Acinetobacter. You specifically look for an OXA or ARM gene where you specifically look for the carbapenem resistant or specific resistance for these patients. So the next what you look for is how do we escalate and de-escalate. So these are studies, again, this is an Indian study done from Apollo Hospital, Chennai, and it was released in 2024, which gave some insights on how these rapid detection molecular tests have been useful in choosing antibiotics as well as de-escalation. It helps in treatment optimization. Remember, we always choose probably a broader for empirical, but your therapy should be focused at hitting the organism, so it's a very narrow spectrum that you look at. De-escalation should be done on that same day which was done in the study. These findings are from the study only. Kind of improved patient outcomes and also reduce the cost of care. So these are the findings from the article to say it has really helped in these patients. So this is again another study. This is from the critical care, which was again released in 2024, August. So this is the guidelines of antibiotic prescription in critically ill patients, where molecular diagnostics was considered as a gold standard for viral respiratory infections. But however, it looked at different specimen types. Choosing the right specimen is important, and it has to be a specific patient population also for which this has to be done. Early and accurate diagnosis is required for looking at the type of pathogen in all of these patients, because for some you need to give a specific antiviral drug, and also you need to have specific infection control measures being instituted in them as well. So what is the impact of these molecular diagnostic tests in the AMS or antimicrobial stewardship program as such? Reducing the time for optimal therapy. When do you say optimal therapy? That is, you start an empirical therapy after you have sent a sample for culture. Once your sample have been tested and the reports have come, and based on that you do a specific optimal therapy, that would be 24 to 48 hours, which means it's early. You are matching the drug and bug to the best possible within 24 to 48 hours or lesser. So that's what happens. Then early choice of a narrow spectrum of antibiotic happens in 25 to 60% of the cases. These are various studies collated and given as a meta-analysis in one of the papers. And reduce mortality specific more often to sepsis patients and meningitis patients. It has been found to reduce 15 to 30% in these cases, because you identify earlier and hit the bug earlier. So there has been better outcome in these patients. The length of stay in general for a hospital stay is 1 to 4 days lesser, and in an ICU stay less than 1 to 2 days. And escalation to carbapenems and reserve drugs are reduced, which means high-end antibiotic. Actually, there is, I don't know, I'm sure everybody knows this. Kerala brought down the usage of carbapenem 10% totally across Kerala. That was presented the last year, 2024. I'm sure it's much lesser now. I'm talking about the 2024, where the usage of carbapenems across Kerala was lesser by 10%, which is a big number. Just not one hospital, one somebody, etc. It's a big effort, but what these drugs have a impact is going to be very, very big. And we will lose them also with increased usage of these antibiotics. So if you escalate properly, then you can reduce usage by 30 to 40%. And adverse drug reactions in terms of developing resistance, in seeing them abnormal presentations would come down to 30 to 50%. So these are certain metrics. When you say metrics, we call capture of, how do you see them performing well or not. So there are process, action, and outcome metrics. The process metrics are time from specimen onwards, time from results to what happened, time from result to antibiotic change. All of these have been reduced. So whether it is an automated alert that has been initiated, or an action metrics, that is actionability that has been initiated, okay, or an antimicrobial change that has been brought about in 80% and more of these cases, or an outcome where you're looking in days of therapy or defined daily dosings, which has been useful for us to see, and the number of patients who are developing C. difficile infections. It doesn't come without limitations, of course. The turnaround time for a NGS specific would be a little longer than other molecular tests that you would see. Probably a multiplex syndromic test assay would come in 2 hours to 6 hours time, but you will see the NGS taking at least 2 to 3 days. And it requires cost and also bioinformatics expertise, somebody who can interpret it well, or an equipment that does it very well. And all that you see, all the gene that is seen, does not mean it is getting expressed. Maybe it is not phenotypically presented also. And what it also detects is commensal. So it is the clinical acumen of a clinician and the clinical microbiologist who is going to look at these reports that makes a sense of these reports also. Then requires strong lineage with the clinical team, because you need to discuss with the clinicians to consider whether what is going to be right and wrong. Now, these are called as the reports that we see with antibiotics is called as the molecular antibiogram, just like what you have the phenotypic antibiogram that you see with Kirby-Bowers or a test that you do. You will see that, and you need to have selected diagnostic specific pathways. You need to say, this is how I'm going to do, this is what I am going to choose. So you cannot randomly choose a molecular test because they are expensive. It's a collective effort. Like I told you, there are multiple stakeholders who are involved in the process itself. So you need to have principles of diagnostic stewardship very well addressed in molecular testing specifically. I don't know if you can see this picture in detail, but this is just to show you that every test that we take as a molecular test for identifying infections in our hospitals, we need to choose based on the risk-benefit analysis that you would do, looking at the pre-test probabilities of these test reports, and the sensitivity, susceptibility, and the load of positivities in the population that you are addressing, and looking at the availability of the test within your own facility for you to make sense of it, and you have the expertise for somebody to interpret the test. So all of that makes a collective decision for this, and this also is the same. However, I'll try to put it in simpler terms of the same which was discussed in ACM, ASM, okay. So in the Journal of Clinical Microbiology again in 2024, this is one of the studies here which kind of looks at approaches to developing and implementing molecular diagnostic stewardship for infectious diseases. So there is a subcommittee report which came up with identify high priority molecular microbiology testing that needs utilization assessment, because you cannot use everything at every lab, and it is not going to be viable. Select appropriate diagnostic stewardship interventions specific, the right test and right sample, and in a patient appropriateness should be standardized, and monitor the impact. It's very important to do an audit and find out what happened to the process that you initiated. So if you look at the flow in the diagnostic stewardship, first you always look at right test for the right patient at the right time. So you avoid over testing so that you will prevent false positive. Just asking everybody's test is not going to help. So anybody asking for the test should be sure that the test is justified. So that's important, because your diagnostic stewardship and antimicrobial stewardship together brings about this benefit. Second is pathways and pre-agreed action should be done, where we need to create algorithms which is responses for common test reports. Like if it is positive for this and this biomarker is positive, then we will stop antibiotics. If this is negative, then we will do this. If it is positive for this and I will send it for a PCR assay and I find a MEK gene, I will treat it or continue with vancomycin. If it is negative, I will stop vancomycin. So this clinical pathway and a diagnostic, this is the diagnostic pathway that should be clearly written down on do's and don'ts of my next step of action. What should I do? If this is positive, what is my next step? What do I do? So that it becomes uniform, whether I request or my another consultant asks for, it would be the same. And all of these should be embedded in our electronic health record, because it becomes easy for us to give stop orders for drugs. Once you find that such an organism is not there, or organism present is not drug resistant, then you can give a stop order or de-escalation order. Rapid notification should be given whenever you identify certain organisms. So automated lab alert should be there to the AMS team. And also you have to have a protocolized stewardship recommendation should be there either by communicating by phone and documenting or by an EMR that you do. And then these resistant genes should be identified and documented. Best outcomes are when stewardships are acted upon. The last one is about, of course, the audit and feedbacks that you give. So you need to monitor the key metrics that I spoke to you about, the process and outcome metrics along with the actionable metrics. You audit certain cases, give prescribers adequate feedback, refine your algorithm. When you make an algorithm for your diagnostic stewardship, when you have said, okay, I will do this for a patient presented like this, after sending the sample, patient starts on an empirical antibiotic, testing done, molecular test done, found this organism, stopped this antibiotic, not found organism, nothing to do, then this organism with susceptible gene or resistant gene, looking for that. So everything has to be written down, and when you audit and find, you will know where you have faulted, so it can help you restructure your algorithms as well. So with that, I come to the end. It's very important. These NGS, they are very expensive. Molecular tests are definitely challenging, but microbiologists currently, all of them are very competent in handling molecular labs. They all are equipped with molecular labs. It is best to use some of the molecular tests. You don't have to use all of them. Some of them which is beneficial for your own hospital setup, specific to critical care patients samples or an outbreak situation, but you should have a plan in place for any infection that you would want where a molecular test may be required. So you need to be using this for timely detection because it detects much earlier. In hours it will identify, it does not take days, and it can differentiate between the susceptible and the resistant, and the strain to strain variations are identified. So it kind of helps you. So the second is diagnostic pathways have to be very clearly defined so that you can utilize it better, or therefore or effective utilization of this. And clinical benefits are consistently greater whenever you have effective antimicrobial stewardship program in place. Alone, diagnostic stewardship will not work. You need to have your diagnostic stewardship working along with an antimicrobial stewardship for this to work. Otherwise, alone they don't work. Yeah. And this is India. We all bleed blue, whether it is men in blue or women in blue. All of us, we bleed blue for cricket. And this is Kerala, the model that has taught the entire country on antimicrobial stewardship, and a dream that was realized for everybody to know that it is possible to have it in each of our setups. And of course, when it goes to the, when it is 18th of November onwards, a lot of our buildings go blue. We all dress up blue. But I think more it should be on how we prescribe, how we convert our knowledge into actual practice, how we teach and train our MBBS students, our clinical pharmacist students, allied health students, our technical staff on best practices of prescribing or testing or handling clinical cases or patients. Okay, this is the WAV 2025 theme, Act Now, Protect Our Present and Secure Our Future. Thank you very much, all of you, for your patient listening. If there are any questions specific, I'll be most willing to take.
Thank you, ma'am. Thank you for giving a very nice overview on the application of genomics in stewardship practices. As we know, genomics is a very powerful tool, and with great power comes great responsibility. How judiciously we use these genomics tests, how we interpret them, and how do we act upon them makes the actual difference. Thank you for giving very data-driven insights.
Thank you.
Any questions from the audience?
Now we find that this NGS, it is not so rare. So many private labs, I mean, labs which don't even have culture facilities, they'll just start off with NGS alone, and they don't have anybody else, only that molecular person will be there, and that person will be giving the report. Not even a proper lab technician will be there. So how can we, madam, how we can control such a this kind of what do you call it, abnormal kind of reporting that has now started with NGS?
Okay. So as of now, like ma'am mentioned, NGS is available only for certain centers, and they've been used also more for pathological or oncological studies than for microbiological studies. That's what I see. Okay. It is done for microbiology as well. They are also looking at critical care as focused in some hospitals. Specifically, they do send, or more for research. If there is a PhD scholar doing a research, they're doing on NGS. They see NGS as a scope for research only, not for an everyday application. It is going to become much easier and available for all. Standardization is a concern, and the more you interact with your team is how you can get. But there are labs which are getting accredited for NGS with quality-based testing process. It is very expensive for them also to do that. So a lot of laboratories don't go for a quality checks, etc. So the quality is also a concern in these laboratories. So, so using certain technologies which have minimal requirement for clarification that's required is the key. There are some labs which are doing fantastically well with NGS, so we can just identify them and send it to them alone. So it is based on test performed in specific teams who are qualified and competent. Currently, everybody who's having are not so competent to do that.
So what we find is that clinicians directly send to them.
Yes.
We are not even asked about it. They just go directly. So how we can control the growth of such places? That is what has to be looked into next. Like Clinical Establishment Act says that only doctors can sign like that. So, but for this there is no control.
That is also because they are not giving it as a clinical report. They are giving it as a laboratory report from a clinical laboratory, but not as a clinical report itself. So the report comes as a sample organism or tested, or more for a tissue, for a molecular pathology like that. So definitely a concern. So there are people who go for some trainings. They think that if you go for a 6 months training, you become an expert. So it is dependent on. There are a lot of people who are brilliant with hands-on technique. They have their finis, and they have very good bioinformatics knowledge. So they are able to tell you, and they bring it to a simpler form for people to understand also. Because for us to understand that report also needs a little bit of our knowledge upgrade. So we need to be upskilled in our knowledge also for us to understand the report.
So I think this was an apt topic to close the session, molecular session, and Madam was very precise, very descriptive and enlightening. The topic was very enlightening.
Thank you.
So,
Thank you so much.
thank you.
Thank you, ma'am. May I please invite the chairpersons to present a memento to our speaker, Dr. Jayalakshmi, ma'am. Moving on, I invite Dr. Divya Suguna Jaikar, ma'am, to present the mementos to the chairperson, Dr. Ellen Tamilan, sir. And Dr. Adra R. Menon, ma'am. I invite Dr. Chitra Jayaprakash ma'am, HOD Microbiology, MOSC Medical College, Kolanjeri.
Next, Dr. Shabina MB ma'am, Professor, Government Medical College, Thrissur. Finally, Dr. Rajendra Gudisa sir, AIMS, Jammu.
A different topic. When we talk about primary amoebic meningoencephalitis, the summer time, that brings to our mind the games that we play in water. Now this time, the summer has taken out all the pleasure of water games. That is because of a lethal but rare infection of the central nervous system caused by the amoeba, causing amoebic encephalitis. So since the report of Nipah, outbreak of Nipah, the State Health Department has undertaken reporting and investigation of encephalitis cases, acute encephalitis cases, and we have been reporting encephalitis cases from Kozhikode. We have an eminent panelist among us. I would like to invite first my dear HOD, Dr. Anita. Please come. Anita PM from Kozhikode Medical College. She's an eminent microbiologist, as you all know, a very efficient teacher. Please come.
Taking over from Mini Ma'am, we have an esteemed set of panelists with us. Our next member is also a microbiologist from AIMS Mangalagiri, Andhra Pradesh. I invite Dr. A. Mohan Kumar, who is the Associate Professor from Clinical Microbiology, to take the stage. In AIMS Mangalagiri, he is in charge of parasitology as well as the HIC department, and also the principal investigator in VRDL. Our third panelist is here to provide an insight into the therapeutic aspects of amoebic encephalitis syndrome. We have a member from our host institute, that is Dr. Davis Manuel, the consultant neurologist. I invite you, sir, to share your wisdom with us. And our final panelist is from Government Medical College, Palakkad, Dr. Shilu. She is the professor and head of Department of Community Medicine, to give an insight into the public health as well as the IPC aspects of this disease. Thank you so much, ma'am, for your participation. Over to you, Mini ma'am.
So now let's share the experiences or the knowledge from the experts of their respective field. My first question is to Dr. Shilu. Dr. Shilu, please provide an overview on the amoebic encephalitis syndrome and its epidemiology.
Yes, thank you. Thank you to the organizers for inviting me for this panel discussion, first of all, and thank you, madam, for the question. So I think most of you are already aware of primary amoebic encephalitis as well as granulomatous amoebic encephalitis. Looking at the global scenario, we've had almost 400 cases up till date. And over the last year, and we have been reporting many cases from Kerala. So there are increased number of cases since last year. And this year we've had around 69 cases and 9 deaths. And last year the case total was around 36 with 19 deaths. And 19 deaths this year and 9 deaths last year. And in Palakkad, so far we have had 5 cases and 2 deaths from these 5 cases. Coming to the main cause of PAM, or primary amoebic meningoencephalitis, is Naegleria fowleri, and this is a thermophilic free-living amoeba, and this is found mainly in freshwater ponds, which are usually not chlorinated, and it is stagnant freshwater, and pools that have not been chlorinated. And the incubation period for this is usually around 1 to 14 days, and the mortality is quite high with the 98%. And granulomatous amoebic encephalitis is mainly caused by acanthamoeba as well as Balamuthia and some of the rarer species like Sapinia. And the incubation period varies from few weeks to months, and these infections tend to be more of chronic subacute infections as compared to Naegleria, which are more of acute fulminant infections. And the mortality rate in case of GAE, that is granulomatous amoebic encephalitis, tend to be around 90%. And usually in case these amoeba are also found in freshwater, stagnant freshwater, as well as in soil. And they are more universally spread as compared to the Naegleria. So they are also present in dust particles. And there is no seasonal pattern for GAE, whereas PAM usually appears in the summer months. So we have more cases in Kerala during the summer months as well as immediately after the monsoon season when the temperatures are quite high. So this is, and even for the countries, you have predilection for PAM cases more in the warmer countries, whereas GA occurs in the warm countries as well as some in the cooler climates as well. So this is basically about the epidemiology.
Thank you, Sheila ma'am. So the recent presentations of amoebic encephalitis have had widely disparate cohorts, meaning from infants of 3 months to even geriatric populations. So Dr. Davis, if you could just elaborate on some of the pathognomonic signs we should look for, which will either give GAE or PAM diagnosis.
Thank you, ma'am. So from a clinical point of view, the primary amoebic meningoencephalitis is quite different from the granulomatous one. So primary, you have a very rapidly progressive meningitis, which very closely mimics that of a bacterial meningitis. So there is no specific clinical marker to distinguish between a primary amoebic meningoencephalitis and acute pyogenic meningoencephalitis. Because of the very rapid clinical course, you cannot really wait for some specific signs to evolve. So any patient presenting with an acute meningoencephalitis, you will have to consider Naegleria as a differential diagnosis, especially in our current situation in Kerala. Having said that, this regarding Naegleria, because it enters through the nasal cavity, so any history of exposure to a fresh water source in the last few days, it's usually within 1 to 9 days. They say the median period is around 5 days. So any recent exposure to fresh water source or any ritualistic thing involving the nasal cavity, like ritualistic ablution purposes or other things, can also be considered as a risk factor. Then if the patient already has some trauma, there is any nasal bone fracture, or the patient has a condition called CSF rhinorrhea, where there is a break in the cribriform plate usually. Such patients especially are at a high risk. But again, this need not be present in all the patients. They can have primary even without such predisposing factors. One of the few clinical clues that might be helpful is what we usually observe is that the ICP is very high. So sometimes the MRI, we had only one case in our institute. So in that patient, the MRI showed features of what they had reported as just idiopathic intracranial hypertension, but it was basically raised ICP features. So if there is raised ICP features which is very unexpected in patient presenting with fever and meningeal signs. That is one thing to suspect primary. Then regarding the CSF picture, again it is very similar to that of pyogenic meningitis. There will be elevated neutrophils, large cell counts. CSF glucose is usually very low. CSF protein is usually high. So that picture again is very similar to that of pyogenic meningitis. So any patient with acute bacterial, acute CNS infection, you have to ask for a wet mount preparation in current situation to rule out megallaria. Coming to the other one, granulomatous clinical presentation will be very different. That is, that will be, again, it is a meningoencephalitis, though there will be again headache, altered sensorium, sometimes seizures and all those things. But the course will be much more slow. It will be usually weeks to months. So most close differential diagnosis will be that of TB. TB meningitis will be the close DD. Again, CSF picture is going to be the same. There's lymphocytes are more common, but sometimes you also get neutrophils. High cell count, low blood sugar, high protein, all these are usually again common. These raised ICP features are also seen in granulomatous amoebic encephalitis also. So both have a disproportionately high raised ICP either in imaging or when you do the CSF tap, the opening pressure tends to be very high, much higher than what is usually seen in bacterial meningitis. And in this granulomatous one, if the disease has taken a few weeks time, usually the imaging MRI will show meningeal thickening. There will be leptomeningeal enhancement if you do a contrast MRI. And there can also be sometimes lesions. This granulomatous one can have either single or multifocal lesions, which are usually contrast enhancing in MRI. So MRI might give some clue, but again, it is somewhat very similar to that of TB. So unless you do specific tests to rule out amoeba, you may likely to miss the diagnosis.
So thank you, Dr. Davis. Along with the clinical diagnosis, that is, we need to have a confirmatory diagnosis, that is looking at the CSF. What is my question is to Dr. Anita, that is, what is the real diagnostic routine testing that we do right from the sample collection to the reporting? Let me tell you. And Dr. Anita is very meticulous in examining the CSF and so particular and very diligent that she dwells into the CSF, she dwells into each and every sample that comes to a laboratory. And a definite diagnosis is a definite, and there is no doubt about it. We all relate, and as most of you all know, very efficient. Okay, Anita.
Thanks to ACM for the opportunity and good afternoon all. So we have been having a few cases of amoebic meningitis since 2024. Okay, we had the first case in May 2024. After that, we have been testing every CSF sample with a wet mount preparation, whether the clinician asks or not. So initially, the wet mount were taken only when the clinician asked for a wet mount preparation, but now we do wet mount for all cases of CSF. And what is important is the time to testing. So we have good collaboration with the medicine department, and they inform us that they have a probable case and the sample is sent, and within a matter of half an hour to 1 hour, not later than 1 hour, we have to be looking at the CSF wet mount. That is the most important aspect in picking up these cases. And to a certain extent, we can also say whether it is probably acanthamoeba or probably Naegleria from the morphological forms that we see. Of course, establishing the diagnosis and confirmation requires molecular testing. So we first do a wet mount examination, and sometimes we go ahead, if something is not clear, we also go ahead with some of the staining techniques like the Lugol-Sidon staining, the methylene blue staining, GIMSA staining, and hematoxylin staining. Okay, and then we proceed with culture. Now, we don't have the molecular testing, it is just being standardized. What we do is for molecular testing, we send the samples to either PH Lab Trivandrum or to PGI Chandigarh. So we have been sending most of our samples to PGI Chandigarh, and once we get a molecular confirmation from there, it is taken as a completely confirmed case. Otherwise, we take it as there are two entities as far as Kerala guidelines are concerned, the microbiologically confirmed and the molecular confirmed. That's how they call it. So when it's only the wet mount, they start treatment with it. That's when we report the wet mount, the clinician, we discuss with the clinician, and if there is a probability of infection, the treatment is immediately started. The cocktail treatment that they give, the 5-drug regime, they start the treatment with the medicines, and then we send the sample for PCR and we get a PCR report. So they don't wait for a PCR report to start treatment, because PCR takes some time, because if it is from PH lab, it takes around 1 week or more. If from PGI, it even takes around 2 weeks time. So we don't wait for the PCR report, but we start with the microscopy report itself, not waiting for the molecular confirmation. I have a few videos, so if I can show it to them. Show it to you all. So these are the different methods I was talking about, the 3 methods that we usually resort to, the wet mount, the culture and the molecular techniques. And wet mount, as I said, is most important to test it at the earliest. So this is the cyst form. This pointer is not working. I hope the double layer is clear. The double layered cyst wall, and you have a polygonal or a hexagonal snape inside, and you have a nucleus too. If you look carefully, you will see the nucleus also. That's the methylene blue stain, and that's the Acanthamoeba trophozoite and hematoxylin stain. In the center part, you can see a larger nucleus, and then there are few clear areas, they are the contractile vacuoles. And you look carefully, you will see the spike-like acanthopodia in the periphery. Okay, so that's the stained preparation. Now this is the video of, I'm sorry. This is the trophozoite and that's the cyst forms. The pointer is not there, so I don't know if it's clear. If you look here, is it clear? So you will see the trophozoite form. The trophozoite has got white contractile vacuoles. You will see them appearing and disappearing. And in the center, you also have a nucleus which is not very clear. You can see the acanthopodia. And can you appreciate the change in shape? Yes, that's the trophozoite of Acanthamoeba. And those are the cysts. The typical cysts, you see the double layer. The outer layer is somewhat haggard. The inner one will be polygonal or stellate. But you also see cysts which are round on the inner side. And in our experience, what we see is that we see more of cyst forms which are round in shape and not the characteristic polygonal or the stellate forms. Okay, so this is the trophozoite. Now this is a wet mount from a culture. This culture wet mount is actually much more easier to detect than the actual CSF wet mount that we see. I'll show you one of the wet mounts of which we get. This is the trophozoite. Now if you look at this is the wet mount of a CSF sample. If you look initially, you just feel it is pustules or even some of them may look like macrophages. But you look carefully, you will see the spiky acanthopodia. Each cell has got a spiky acanthopodia, and you can see that round cyst forms also. And you look a little more carefully, you can see that each one of them is moving. Okay, you will see the extension and retraction of the acanthopodia. Okay.
May I please?
Okay, there's some announcement to make.
May I please request Dr. Vijay and Dr. Rake to please proceed downstairs immediately to the ground floor reception.
No, this is wet mount, ma'am. CSF wet mount, not culture. This is CSF wet mount. So many, yeah. We had one case, all of them are trophozoites of Acanthamoeba. Actually, this case was from a patient from Gulf, madam. He succumbed in a matter of 2 days, and his CSF was studded with so many trophozoites. But in most of the cases, we see just one form like that in per field. If you look at that form there, near the arrow, you can see the acanthopodia. And if you look carefully, taking some time, you will see that there is change in shape also. You will see the nucleus, you will see the contractile vacuoles also. So usually we get to see only one or two in one wet mount preparation. Wet mount preparation means in one field. But this was an unusual. No, we don't centrifuge. They say you can centrifuge at very low speed like 250 G, but we don't generally do it because the trophozoans may tend to get denatured. So we don't do that. So that's the form which we usually come across, and the cyst form on top. You don't generally see the typical polygonal ones, but they are the ones. And even if you look at them for some time, you will see them putting out thin structures, thin thread-like structures, and it is said that it is probably that they are sensing whether the environment is conducive enough to change to the trophozoite form. So it's very interesting to see those forms. So once we come to see the trophozoite and the cyst forms like this, we report to the clinician that it is almost 100% likely to be amoebic meningoencephalitis, and they straight away start with the treatment. So that's what they do for amoeba cases. Now this is a Naegleria case. Actually this video is from that of a case from MES Medical College. You can see there's slight difference in the Naegleria forms. You see that not the size, ma'am. You can see the pseudopodia that are put forth are sinus, somewhat lobus, round kind of pseudopodia, whereas for acanthamoeba you have spiky thorn-like ones. So that is one important difference, and the motility of Naegleria actually remains much longer than the acanthamoeba. If you see a wet mount, you are not likely to see motility of acanthamoeba if you keep it like that for 1 or more than 1 hour. You will not get to see at all. You will only feel it is any other normal cell, either a neutrophil or a macrophage. But if you keep Naegleria, sometimes there is a possibility of seeing we have seen the Naegleria motility on the next day also. So sometimes it is possible to see with Naegleria but not with acanthamoeba. So no ma'am, you have the smaller ones also, there is difference in size. Only thing, the pseudopodia are very characteristic and the motility is much more, and it will be directional movement. This is a case of worm amoeba vermiformis we had in 2024. You will see again that these structures are slightly different from the ones that have been shown earlier. Here you see that the pseudopodia is more tubular. You will see it appearing. You will have long tubular structures coming up. The worm amoeba and the Balamuthia, it is difficult to differentiate. It cannot do it in a wet mount, and even in molecular diagnosis you have some amount of cross-reactivity between Balamuthia and worm amoeba. But this case we actually got it as worm amoeba vermiformis PCR positive. So you can see the pseudopodia, it is much more tubular. So this is the kind of pictures we generally see. Most of our cases are acanthamoeba, and we have had 14 cases of confirmed acanthamoeba, 1 case as free-living amoeba, and we have had 4 cases of Naegleria fowleri. Actually 3 of them are Naegleria fowleri, and 1 case is supposed to be Naegleria non-fowleri. And it is said that no case has been reported so far of Naegleria non-fowleri being pathogenic to humans. So it has been kept for whole genome sequencing, and only once it is confirmed, then it will be published. So as of now, we have 3 confirmed cases of Naegleria fowleri and 1 case of Naegleria non-fowleri. Balamuthia we have not had. Even in Trivandrum, they have not had any case of Balamuthia. So these are the things we generally do. We have the wet mount microscopy done immediately on receipt of the sample, and then we proceed with the culture. We are into standardization of the molecular method, so we have not started reporting for the samples as yet, but we send to PH lab or to PGI Chandigarh for confirmation. We also do workup with other tests, that is we proceed with the bacterial culture, and we have the biofire also as part of the acute encephalitis syndrome workup, and we also go for mycology culture, everything else. So we have had cases where the clinician had suspected a fungal infection, and it turned out to be a case of acanthamoeba meningioencephalitis. So it is important that we look at every case of CSF and not just those that are clinically suspicious, and most importantly, it has to be done at the earliest. Thank you.
Thank you, Anjana, for that extensive analysis into the diagnostic protocol. It is actually quite essential to all the labs in Kerala at present. But considering diagnosing in patients is simply not enough, actually, because we know it comes from the environment. Dr. Mohan, if you could just elaborate on whether environmental surveillance of water bodies in general would play a role, and what would be the process if we are going about it.
So, another topic about environmental surveillance. So, one side we are saying don't do routine surveillance in the environment in the hospital, and the other side, this kind of terrific scenarios are happening, and patients are dying just like that before even diagnosing the case. So, we cannot just say no for an environmental surveillance. In Western countries, also in other countries, they do. When a patient is confirmed to be positive, they go to their house and around the surrounding places, they go to their water bodies and test, and then be aware of the surroundings. That's what is happening. So even in our country, a lot of studies have happened about environmental surveillance, and they have found out a lot of free living amoebas being alive in these fresh waters and ponds and lakes. So at some point of time, definitely we should actively look for even that, because the way how it's going and how the number of cases are increasing, we are definitely in a situation where we should look for environmental surveillance also. But the purpose should be clear. The purpose is not to just eradicate and remove that amoeba from the water, which is highly impossible. It's not going to happen. The purpose is to be aware and not to involve in recreational activities and things in those kind of ponds, and that kind of awareness should be there. So for that purpose, maybe, yes.
So the management protocol, Dr. Davis, could you please tell on the management protocol of AE has been under scrutiny for its immediate cocktail mixes of drugs, and what would be the factors to consider while choosing the antimicrobials and duration of treatment?
Regarding the treatment aspect, there are no standardized guidelines, because the number of cases so far has been reported worldwide is not a very large number to conduct any randomized control trial or something of that sort. So what is usually done is a cocktail of drugs. The one important thing, especially in Naegleria, is to start the treatment as early as possible. So it has a very high mortality rate, said to be around 95 to 98%. So the whatever few cases that has survived are basically the ones which it was diagnosed at a very early stage and treatment was initiated at a very early stage. So it's very important to start the treatment, as madam said, without waiting for further PCR confirmation. Once you get the wet mount positive, you have to start treatment. Amphotericin B is one of the main drugs used. They recommend the plain form of amphotericin B, not the liposomal form, which has lesser side effects. The plain amphotericin B is said to be more active against Naegleria. It is given along with other drugs. Traditionally, the drugs that were used were some of the azole group. Fluconazole was the one mainly used. Nowadays, posaconazole is also being used. Along with it, they also give rifampicin and azithromycin. The newer drug, as you might be knowing, is miltefosine. So the survival rate which we recently got in Kerala is said to be around 25%. That is around 75% mortality. From above 90, it has come down to around 75%. And they say this availability of miltefosine has an important role to in that. Apart from specific treatment, it is also important that, just as I said, regarding the clinical features, the raised intracranial pressure is one of the main complications which lead to coma and then to death. So tackling the raised ICP through the its usual management. Patients will usually be intubated and ventilated. Usually they advise hyperventilation plus the usual treatment, steroids, mannitol, plus if needed surgical maneuvers, lumbar extraventricular drainage, and sometimes even decompression craniectomy is advised. For the granulomatous form, amphotericin B is not usually a part of the protocol. Instead, the other drugs are still used. And the miltefosine is there, the antifungals, azoles are there, rifampicin is there, plus sulfonamides are usually used. The trimethoprim sulfamethoxazole and pentamidine is also used. So slightly different cocktail for granulomatous one, and this usually is given for a prolonged period because it's a subacute to chronic cases.
Thank you, sir, for that fine discussion. Actually, it is continuously being updated by the number of cases that we are facing. So, a lot of data is available on the management, but I think public and also we as clinicians are still unaware of how to exactly tackle the infection prevention and control. Everybody just says, okay, superclorination is enough. So, Dr. Shilu, if you could just elaborate on the IPC aspects.
For the clinicians, actually, this also, acanthamoeba is quite commonly found even in clinical settings since it's more universal in nature. So, as far as clinicians are concerned, it's you need to observe infection control practices. So, routine hand hygiene, use of personal protective equipments, also use of sterile distilled water where humidifiers or such equipments which require water that needs to be changed regularly, as well as using sterile distilled water. And care should be taken also not to handle the specimens directly, and release of aerosols. So that is also because it can be present in the dust, also in aerosol generating procedures. So that should be taken care of, and CSF specimens should be handled in under biosafety level 2. And most of the medical equipments require disinfection after use, so that has to be, as per standard procedure, that has to be disinfected. And ensuring that staff are regularly trained and updated on infection control practices will also help to prevent these infections in hospital settings. Actually, there was a case where this patient, she actually consulted a dentist. So this was somewhere abroad, and she contracted acanthamoeba keratitis after going to a dental clinic. So even the water that they use for procedures in dialysis units or dental procedures, so that also needs infection control practices have to be followed in every setting. So that is mainly for the hospital care setup, and as far as public are concerned, they need to avoid stagnant water, swimming as well as diving into waters that are usually not cleaned or not properly maintained or not chlorinated pools. And this amoeba, especially Naegleria, it enters by forceful entry, water entry. So if they are swimming in such pools, they need to keep their heads above water, or make sure that water doesn't get in through their noses. And so you can use a nose clip, that is what is advised if you're going into such pools. And these pools or domestic water tanks also need to be chlorinated on a regular basis. Sometimes it's not feasible to chlorinate large water bodies that and it's not maybe on a sustainable level. It may not be, can't do it for a longer period of time, but maybe having signages that prevent people entering these pools which are not usually used, because these, especially during the summer months where these amoeba proliferate, and people tend to use these water bodies because of behavioral risks, also risk exposure is there. So so it's better to have chlorinated, routine chlorination of these water bodies, and ensuring that these piping mechanisms or the pipe systems that bring water are also routinely chlorinated on a regular basis. Acanthamoeba also is commonly seen in those who use contact lenses, so ensuring that proper hygiene is there while using contact lenses, and preventing overnight wear, and using the proper sterile solutions will also help to prevent such infections.
So thank you, Dr. Shiru. It is a practice which is very important for each and one of us. And what we do in our lab, that is when we examine the CSF under the microscope, we definitely use a mask, we definitely use a gloves, and all the things are practiced very well. Now there's a phenomenon that is there are other bacteria, other organisms along with the CSF. And so what is the phenomenon of Trojan horse? Could you please explain, Pramita?
Yes, another important issue we are facing is that we tend to get a lot of positivity with bacterial pathogens too. When we put the CSF into biofire, we get positivity for pneumococci, we get positivity for enterovirus with meningococci, and we have seen 6 cases where acanthamoeba PCR has been confirmed, and we have had pneumococci also positive in biofire. And that's especially because this amoeba is notorious for working like a transmission vehicle for other organisms, other bacteria, fungi, viruses. In 2 of these cases, actually, we had pneumococci grown also. And both of them succumbed to illness. One was a post-mortem case where we had frank purulent pneumococcal meningitis as well as acanthamoeba seen in the CSF. And the other was a child where acanthamoeba was first confirmed and then later it grew pneumococci also. So that was one of our first cases where we had a doubt whether it was really acanthamoeba, because the pneumococci had grown in culture, but at the same time we had the acanthamoeba also seen in the CSF, but then it was also confirmed by PCR that acanthamoeba was there. So we have had such cases of co-infections, or probably they are just carrying the organisms. We had 2 cases of VZV positivity in CSF. Enterovirus positivity was there. Then meningococci, I said we had 2 of them. So this is another issue. The problem is when we say there is amoeba in the CSF, and when the biofire result tells them there is meningococci or pneumococci, the clinicians will tend to naturally believe that it is a bacterial infection, especially when the CSF parameters, other parameters are pointing to a bacterial infection. So fortunately all these cases had acanthamoeba PCR also positive. So then we were saved that it is not a wrong diagnosis from our side. So this co-infection is an important thing, and they say that there is a possibility of even genetic exchange within the amoeba. It helps these organisms to have better osmotolerance, better ability to evade the immune responses inside the human host. So naturally when we have an increase in acanthamoeba infection, there is a possibility that all these co-infections can also be on the rise. So this Trojan horse phenomenon has been noticed to a great extent in our cases. Thank you.
So that was very interesting to note that the Trojan horse phenomenon. Now let's find out what are the challenges, diagnostic challenges that we face. Dr. Shiru.
Yes, so some of the challenges that we faced, we had 5 cases in Palakkad. I'll just talk about the Palakkad scenario since I'm more familiar with that. So we had 5 cases, out of which 3 were diagnosed to have acanthamoeba, and 2 of the cases PCR was negative. And when we did the environmental surveillance, we usually go, the field teams take the water samples, and we could isolate, we got the result for the water analysis for only 1 particular case. So that was showing acanthamoeba. For the other water samples that we had taken, the results were negative. So getting a source of pinpointing exactly from where the source of infection, that is also a challenge actually in the field situation. And more so because 2 of the patients had, multiple, they used to go to, relatives' houses, stay there, come back to their house. So, but there is a history of, in 3 of the cases where they have bathed in common wells or in canals which are nearby their homes and which were probably not chlorinated. And 2 of these cases had a history of exposure to, or practice of storing water. So in Palakkad that is very common because they store water for longer periods, and since one was a little bit alcoholic, and I think probably he has not looked into, and the color of that water had turned green, so according to his relatives. So So those were the probable exposures could have been that, but we could not really get on the water analysis except for one case. So that is one of the challenges. And the other challenge is most often there is a lack of awareness. So regarding this infection, because most of the two of the patients were initially treated for viral as well as tubercular meningitis. So by the time the CSF results came, then they were started on the treatment for anti-amoebic drugs. So that lack of suspicion was also there. So that was, and by that time the patient had already deteriorated. That's another thing. So there's no point of care testing which is available, which helps to have a faster diagnosis for the patient. The other thing is the lack of awareness even among the general population. I mean, people, because one of the cases happened in the slum area, and where they also store water. And when we go for health education, usually it's a floating population, especially in the slum area. So you don't get them for health education. You may not be able to access them all the time. So poor water safety is one concern. So most of them don't chlorinate the water, or the water that they get is not chlorinated. So these are some of the challenges we face in the field.
Thank you. Shilima. Dr. Mohan, if you could also elaborate on your challenges.
So just to add to what Dr. Shailu had just spoken about environmental sampling, collecting your water from a pond, it need not be all the time same results. That's what was one of the studies I had gone through. It was described clearly there. The presence of the organisms, type of the amoeba, and the area in which it is there, and that water body itself can be varied. So at one point of time you are testing from this area, and the next point of time when you are testing that same area, it may be negative, and it can be there in some other area of that same pond or a same lake. Even that was also documented in the things. It may be because of the ecosystem which is available for its survival in that particular area, and the temperature variability and other things. So environmental surveillance is not that simple. So that could be the reason why they are not able to identify the organism from that area, even though the exposure history was there. And the challenges, just like that, what I can say is, whatever the videos and pictures what madam had shown, very nice, flooded with antcat amoeba and things, nicely motile amoeba, these they were able to capture after hundreds and hundreds of hours of microscopy, day and night, with an expert eye. Only then they were able to capture nice videos and pictures like this and put it here. But what is expected in all the laboratories, if we take the peripheral most laboratories, there may not be an expert who had seen a amoeba before. That is also possible. So even if a motile amoeba is there, whether they will really pick it up or not, that is one question that is there. Other thing is, will the amoeba really move? So the timing, what madam said about 30 minutes to 1 hour, that is the time we need to see, so that we can see the motile organism there. How often it is actually happening? Maybe in an outbreak situation when the panic and fear was so much, it is really happening. But otherwise, how much it happens? That is the kind of challenge even we face every time. Transportation time, how often it reaches the laboratory on time, and how often you are able to see it on time. Even if we see, how often we go for wet mount examination. Majority of the time it's just a gram stain and go for culture. That's how it goes, unless you really suspect, or when an area is having high number of amoebal cases and things. So wet mount can also be part of routine CSF examination, seeing the way how the things are moving out. So that should be definitely included as part of routine examination. And in one of the article when I read, it was shown like about examination of wet mount, even should be under a cover slip. If you obviously in India we don't do routine cell counts by a microbiology laboratory. Cell counts are done in a different laboratories. But in Western countries, what they have quoted, if you look for cells, moving cells in a counting chamber, you may not be able to find a proper amoeboid movement in that counting chambers. It's not possible to visualize their motility, and even the shape will be different. It will be round in a counting chamber. So it should be visualized under a cover slip in a wet mount preparation, so that you can expect a proper amoeboid movement and pseudopodial formation and things. So these are the practical, very practical things I feel which we all have to have a keen eye so that we can pick them up.
Thank you, Dr. Owen. That was a very
that's in summary of all the difficulties we face, especially in the private setup, I feel, when we have lesser staff who can get trained and who have the time to get trained. Because if you send one person to get trained, then there may not be enough people to actually work the lab sometimes. And we ourselves have also seen only maybe less, one or two cases, and how can we teach our technicians to identify these things. Dr. Davis, we would appreciate your input.
Sir has put it quite well. So, current scenario, we'll have to suspect in almost all cases where acute CNS infection is the differential diagnosis. And again, especially if you're suspecting Naegleria, you cannot delay the LP. It has to be done as early as possible. So, to do an early LP and at the same time to get it tested for a wet mount preparation, if needed even at night, that's all within a short period of half an hour to 1 hour of doing the LP. That's all practically hurdles present. Another thing that I would like to point out is that only the Naegleria is the one which directly invades through the nasal cavity cribriform plate. The other ones, Acanthamoeba, Balamuthia, all first enter either through the skin or to the respiratory portal, and then its hematogenous spread to the brain. So your freshwater exposure may not play much of a role for granulomatous amoebic encephalitis. Such cases, looking for a freshwater source may turn negative.
Thank you, sir.
Yeah, as far as microbiology lab is concerned, another important challenge is the lack of molecular confirmation tests being available in all labs. We have only one lab in Kerala which is currently doing molecular tests for all samples. We are just standardizing. Probably in another few weeks' time it will be done. The problem is we don't have validated commercial kits available for diagnosing, PCR kits available for picking up amoeba cases. So that is one important thing. And another thing is when we transport the samples to other laboratory, it takes time. A few days time, and that results in denaturation or degradation of the nucleic acid. So the PCR is not picking up the cases as much as you can pick up with a wet mount. So always we are under pressure until we get a PCR report, because then it is easier to convince the clinician once you have a PCR report in hand. So that is one important thing, that one challenge that we are facing. Another is of course the co-infection I talked about. And then we now have patients coming up with relapse. We have had one case, one 17-year-old girl who had relapsed 3 times, and finally she succumbed on the 4th time with seizure and cardiac arrest. And now we have 3 cases who are admitted with relapse. Yeah, granulomatous, all Acanthamoeba cases. So they're coming back with fever, headache, vomiting, and when you see the wet mount again, you're seeing the organism in there. So actually we are learning from each case. Everyone is learning how to do, and currently what they're doing is you should have 3 clearance of the CSF, MRI picture should be clear, and the patient should be asymptomatic. Only then they are discharging the patient. But sometimes it takes too long, so that they discharge the patients with oral medication, but unfortunately they come back in 2 to 3 weeks time with symptoms. So this relapse is also a problem. It is very difficult to get rid of the organism once it is in the system.
Thank you, Vanitha ma'am, and thank you panelists for that comprehensive discussion into amoebic encephalitis. We would now open the discussion to any questions from the audience.
We have just started to perform now. Culture actually can be done by most of the labs. All you need is non-nutrient agar and a E. coli overlay. You can get culture positive.
Around time for culture, ma'am?
Culture up to 7 days we have to keep for incubation. But usually it can grow in 2 to 3 days time, but we have to keep it at room temperature for 7 days. Pardon? Nasal washings, we have seen, just to see whether there is colonization, we have worked upon some cases with the nasal swab. Those who were infected also, and those who had contact. And we did see Acanthamoeba in some of them. And one case where we had Naegleria, The water sample also we could see the amoeba. Even in the wet mount we could see the neglarial forms. So we are able to see. We are actually planning a study to see how many have nasal colonization. It is not necessary that all of them develop meningitis. One case, two siblings, one case of confirmed meningitis, two siblings had nasal colonization because they all of them had exposure to the same water body. No, we take the same swab which we use for viral. Yeah, that swab is taken, flock swab is taken, and then we put it in sterile normal saline, and the sample is sent to the lab. But then again, we have to differentiate it from columnar epithelial cells and other motile things that you may see in a nasal swab. That is a bit more confusing than the CSF,
Yeah.
but you can see.
Thank you.
Excuse me, ma'am. We would also like to share some of our experience from Trivandrum Medical College. Like we had an RTA case, road traffic accident case. The only history, like we got acanthamoeba from that patient. The only history of exposure that he had was washing the wound with the pond water that was nearby. The patient succumbed to death. But that is one example of not the nose, the nasal entry not being the only source. Like even wounds can let this organism inside. It's a hematogenous spread. The second thing is, like Madam said, we are also getting relapses of cases. There are relapsing cases getting admitted in our hospital. So it's not necessary that like everything is a cocktail of drugs. We are yet to see what is finally effective. Thank you.
Just to add on to one of the things what Madam had told. So hematogenous route, definitely yes, especially for the other amoebas, not for Naegleria. That may not go through a skin wound. So it is specifically written for acanthamoebaitis. And Naegleria, even it is said, even if you ingest that water which has that amoeba, you may not even get an infection. So it's especially going into the nasopharynx and that cribriform plate. Only then we are susceptible to that infection.
Yeah, it is through the nerve route which Naegleria goes. Acanthamoeba and Balanthia has the hematogenous spread.
And the environmental samples also we are getting good yield of positivity for acanthamoeba, Naegleria and Balanthia. And at PGI they have done a study with the environmental samples from Kerala also. And what they have seen is it is the T4 genotype that is seen. Even the patients, the acanthamoeba was seen as T4 genotype. Even the environmental samples they are getting T4 genotype.
Ma'am, you talked about the siblings getting colonized. So is there any protocol that should be followed for those, they are not patients, but whether we should try to eradicate or how long we should follow or things like that?
So these are all just experimental things that we are looking up at. So we are planning a study actually with the cases and some controls also, age match controls, so that we get to know, because there are not many papers or reports on nasal colonization as such. But then we had one known case of nasal colonization in one of the faculty itself in microbiology some time back. So that's why we started looking into nasal colonization possibility.
So we need to have a multidisciplinary or a hand-in-hand contact or discussion with the microbiologists, with the clinicians, pediatricians, physicians, all should go hand in hand in diagnosing and managing the case, which is very important in this current scenario. So thank you very much. Thank you ACM Kerala chapter for having given me this opportunity. Thank you all panelists. Thank you very much.
Thank you everyone. To honor our panelists, first I call upon Dr. Mini PN Ma'am to present the mementos to Dr. Anita PN Ma'am. and Dr. Shilu Sakriya ma'am.
Now I invite Dr. Vinita Mary Joy ma'am to present the mementos to Dr. Davis Manuel sir. And Dr. A. Mohan Kumar sir.
May I please now invite Dr. R. Satyajit sir to present the mementos to our esteemed moderators. First, we have Dr. Minnie P. N. ma'am. And Dr. Vinita Mary Joy ma'am.
Yes.
Thank you, ma'am. The third position goes to Dr. Devi, to Dr. Renuka J. B. From the Government Medical College Thrissur for her topic, Unraveling a Hidden Pathogen Behind a Severe Thrombocytopenia in an Elderly Bedridden Patient. The second place goes to Dr. Devi Raj K. from Government Medical College, Thiruvananthapuram for the topic Coriobacterium violaceum septicemia in a 3-year-old child, a case report. And finally, the first prize goes to Dr. Leah Elizabeth George from Amrita Institute of Medical Science and Research Center, Kochi, for the topic Emergence of BLA CTX M55 and QNRS in Salmonella enterica serotype, Kentucky S8 ST198 clinical isolates in Kerala, India.
For presenting the prizes for the oral paper presentations, we would like to invite Dr. Suryakala R. Nair, the Associate Professor of Government Medical College, Wayanad. The third place goes to Dr. Vidya from Grant Government Medical College and JJ Group of Hospitals, Mumbai, for her topic, a case on pulmonary nocardiosis due to nocardia cryogorgia in an immunocompromised child.
The second place goes to Dr. Purnima MV from Baby Memorial Hospital, Kozhikode, for the topic, an uncommon challenging SSI NTM.
The first place goes to Dr. Shilpa Mohan from Sri Chitra Tirunal Institute of Medical Sciences and Technology, Trivandrum, for her title, From Metrics to Excellence, a quasi-experimental study on reducing catheter-associated urinary tract infection through bundle care training program.
For the poster presentation, category B, mycology and parasitology, the second position goes to Dr. Abhishek S. from Government Medical College, Kottayam, for the topic, meningeal co-infection by Streptococcus pneumonia and acanthamoeba, a rare diagnostic challenge.
Thank you, ma'am. We now invite our beloved Nivedita Mohan, ma'am, Assistant Professor, Department of Microbiology, to speak a few words.
Good evening. This brings us to the end of the session today. Thank you so much. I'm Dr. Nivedita Mohan, Assistant Professor Microbiology in Pikidas Institute of Medical Sciences. And on behalf of my department, I would like to extend a heartfelt gratitude to everyone present here, right from the chairpersons, the speakers, the judges, senior faculty, consultants, postgraduates, delegates, everybody. Thank you so much for being here, for your active participation in making this event a grand success. Hope you all had fun. Have a wonderful evening and a safe travel home. Thank you so much.